Good morning again. And before the official agenda of 9th ABCDCon begins with our academic head, Dr. T.N. Banerjee, this is an announcement that in the small conference hall of Bardhaman Bhavan, there are two added services we have this year. One is hepatic fibroscan and another is HbA1c estimation. So anyone, doctors or non-doctors, they can do their hepatic fibroscan and HbA1c, of course, for free. So you can go there anytime you want. And there are two hospitality stalls outside. So between the sessions, anyone can help yourself with tea and snacks. Thank you.
A very good morning and a very warm welcome to all the ladies and gentlemen present here. Soon we are going to start the session, and before that I want to welcome each and everyone once again to ABCDCon 2023, the 9th annual conference. I will be requesting the remaining delegates to come and join us soon so that we can start today's session. For the pre-lunch academic session, I will be requesting Dr. T.N. Banerjee to come and welcome you all with the welcome address. For that, I will be requesting each and everyone to welcome him with a round of applause. একটু জোরে করতালি দিয়ে আমরা স্বাগত জানাই ডক্টর T.N. Banerjee কে।
Thank you, Sumona, for the kind introduction. Our respected President, Dr. Subrata Bhattacharjee, Organizing Secretary, my beloved Dharma Gupta, Secretary of ABCDCon, Dr. Suhomai Chatterjee, fellow delegates, fellow members of the ABCD. I can see some PGTs also. A very good morning and greetings. It is really my great pleasure, privilege and honor to extend my welcome on behalf of ABCD to this great and entertaining academic program of ABCDCon, 9th ABCDCon. Friends, you all know that in the last 2 decades, we are observing tremendous development in the field of medicine. And it is not possible always to keep in track with this development. And this development is ongoing, and we have a very good platform in Bardhaman in the form of ABCD. We can, last 8 years, we have tried to just give this opportunity to the fellow physicians of the Bardhaman and to keep in track with this development of the medicine. And you know, this, as for example, you know, this we have got SGLT2 molecule which have started this journey as a anti-diabetic agent, and with tremendous evolution, we are now seeing that its benefit as a cardiorenal benefit, not only for the diabetes and as well as non-diabetics. And you know, that's next generation, future generation will see a lot of things, such for example, that's probably one single injection will control blood pressure for 6 months. Maybe that gene addition will help us in controlling this dyslipidemia, and so on and so forth. We are very lucky, and I feel privileged to announce that we have got galaxy of speakers of national and international repute who will represent this today's scientific program. And I think you will get a lot of collections from these great speakers. And I'm really thankful and thankful for for accepting our invitation in this conference. My sincere gratitude to them. And without wasting much time, I will request this Sumana to address the further program. Thank you very much. Jai Hind.
Thank you, sir, once again for the welcome speech. And right now, we will be starting the pre-lunch academic session. I will be requesting our first speaker on stage to come and join us. She is none other than Dr. Sunetra Mondal. Designation and affiliation includes Assistant Professor, Department of Endocrinology, NRS Medical College, Kolkata. Academic qualification includes MBBS, MR, CP, UK, MD, Medicine, DM, Endocrinology. She has got major achievements including the ESI Yuvaratna Award 2023 for Best Research in Private Capacity awarded by Endocrine Society of India, A.V. Gandhi Award for Excellence in Endocrinology in the year 2019 awarded by Endocrine Society of India. We have got more achievement that includes the All India first runner-up and zonal winner in the Young Scholar Award 2018 by Endocrine Society of India, and a University Gold Medal for highest mark in DM final examination in the year 2019. More than 16 awards for papers, posters and quizzes, and publication in Index National and International Journal 17, that includes Original Research 11. Currently, she is a member of RSSDI, Endocrine Society of India, Endocrine Society of Bengal. So ladies and gentlemen present here, please put up your hands together for none other than Dr. Sunetra Mondal. And yes, our chairperson in Dr. T.N. Banerjee and Dr. H.D. Mondal. I will be requesting you both to come and join us on the stage, please. Ma'am, please come and join us on the dais. Good morning, everybody.
I'm very thankful to the organizing team of
Good morning once again. It's a great pleasure to have Dr. Sunita Mondal as a speaker on this topic, this optimizing cardiovascular metabolic care with initial combination therapy with SGL2 plus DP4 inhibitor. And just I'd like to introduce my co-chairperson, this Dr. Hridas Mondal, who happened to be my friendship for last 50 years. And Dr. Sunita Mondal, she's the daughter of Dr. Hridas Mondal. And it's a pride moment for both of us because we are seeing each other for last 50 years. It's a great daughter, great son of our soil, Dr. Sunita Mondal. Please proceed.
Thank you, Dr. Banerjee. Dr. Banerjee is very close friend for me for last 40 years or something like that. And I'm very much proud to be here with him. And although Sunetra is my daughter, she is the daughter of the soil and the daughter of all of yours. And please bless her to achieve more and more.
Thank you so much. And I'm very thankful to the organizing committee of ABCDCon. This is my first time over here. And although everybody in this organizing committee are big names in this city, this state, this country, but as they have said, I have seen them since my early childhood, and they are all father figures to me, except Dr. D.K. Gupta, of course. I cannot call him a father figure. So last 2 or 3 weeks, I had been presenting very unusual topics like diabetes and marriage, fermented foods. But this weekend, this is our bread and butter. So the combination therapy of SGLT2 inhibitor and DPP4 inhibitor, this has been discussed so many innumerable times over the past 4 or 5 years that there is hardly anything new that I can tell you. So just a recapitulation of what we all already know. And so I'll approach it like a few questions that we will try to answer as I proceed. So why is the need, what is the need for a holistic cardio-renal metabolic approach? We now call it CRM approach towards type 2 diabetes. Why gliptins? Why flozins? Why the combination of both? What's special about this combination? Why initial combination? Why to intervene with a combination therapy so early? And whether this combination can actually replace metformin as the first line agent. So starting with my first question, what is the need for a holistic CRM approach? So if we look at the ADA guidelines, which all of us most commonly follow, they have clearly laid down, it's not working, just. No, here the slides are moving, but there it's not. There is a lag period of some 30-40 seconds, I guess. Okay, so if we look at the goals of care laid down by the American Diabetes Association, they are very clear about it. It's not about glycemic control alone. It's about the prevention of complications, be it macro or microvascular, and it's about optimization of the quality of life of people living with diabetes. As you all know, we cannot call a diabetic now. We are to call them people living with diabetes, and their quality of life depends on a number of factors, of which just one is HbA1c reduction. There is an importance to reduce the risk of hypoglycemia, to prevent weight gain, to ensure there is not too much of glycemic variability. With the advent of continuous glucose monitoring, that is also an area of prime concern. It should not be very costly. Of course, in our country, there should be minimal adverse effects, and it should take care of other comorbidities, not just complications. Comorbidities meaning hypertension, dyslipidemia, etc. Now, if we look at the prevalence of again, it's not changing slides. Okay. If we look at the prevalence of cardiovascular, okay, so if we look at the prevalence of cardiovascular disease, so around 7.6% of those living with diabetes would be having stroke. That would be around 1 in 13 people with diabetes having at least one stroke in lifetime. 1 in 10 of them would go on to have myocardial infarction. 1 in 7 would be having a heart failure. 1 in 5 would be having coronary artery disease of some form or the other, not necessarily an acute coronary syndrome. And 1 in 3 will be having any cardiovascular disease, which would be inclusive of atherosclerotic cardiovascular disease, diabetic cardiomyopathy. We know about diabetic autonomic cardiac neuropathy. So 1 in 3 people with diabetes will be having some or the other. Now we know this is a vicious cycle: diabetes, heart failure, CKD. So around up to 58% of people living with type 2 diabetes would be developing CKD of some degree in their lifestyle, in their lifespan. And heart failure and CKD, it forms a very much vicious cycle, because the presence of one can cause or worsen the other. And those with diabetes can have up to 5 times increased risk of heart failure in their lifetime as compared to non-diabetics. And as we all know, the presence of CKD of any degree can amplify the risk of adverse cardiovascular outcomes. Of course, it depends on the EGFR. The increase depends on the EGFR, but can be increased from anything from 1.4 times through 3.4 times, depending on the decrease in EGFR from 45 to less than 15. That is the stage of CKD. If we look at the changes in the mortality trends in diabetes over the past decades, so there has been indeed a drastic decline in the rates of acute myocardial infarction, stroke, or end-stage renal disease. Not so much of end-stage renal disease though, but still the values are quite high. And if we look at all the trials that have tried to look at the effects of intensive glycemic control, there are some controversies regarding the perfect HbA1c to achieve. But overall, the results suggest, yes, intensive glycemic control does reduce the cardiovascular mortality and to some extent all-cause mortality. But more importantly, something that is unambiguous is that we need a multifactorial intervention. Right from the STENO-2 trial, we know that a combined reduction of not only HbA1c but blood pressure and lipids along with can decrease cardiovascular events by as much as 75%, and therefore multifactorial treatment is very important, but still unfortunately it is underused. And no wonder from last year the ADA has clearly emphasized on the fact of importance of multifactorial intervention by their pillar model. So glycemic management is just one of the 4 pillars, which also includes blood pressure, lipid management, and the use of agents which also have additional cardiovascular or renal benefit. And combination therapy, I'll come to it, but the main advantage is that the reduction of pill burden and of course the costs. And there are several studies which have shown that fixed drug combination can lead to a significant improvement in adherence to pharmacological therapy. So that was about my first question. Coming to my next question, why gliptins, why flozins? Again, nothing new to all of us. Light from the difronzose ominous octet, we know that gliptins, it's predominantly the incretin axis on which it acts, an SGLT2 inhibitor. It is mainly the renal glucose reabsorption, I'm sorry it's not there in this slide, on which it acts. And over the past decade, there is unequivocal evidence we know now that there is reduction of the hospitalization for heart failure and the composite of hospitalization for heart failure and cardiovascular death with SGLT2 inhibitors, not only in those with diabetes, but also in those without diabetes. So SGLT2 inhibitor is no less a cardiologist's drug now than a diabetologist or an endocrinologist's drug. But if we look at the trials more carefully, then it's predominantly 2 areas where unequivocally all the SGLT2 inhibitors have shown benefits. Benefit we call when the upper margin of the hazard ratio, the things that are written in the bracket, the upper margin should not be more than 1. So that is true for heart failure hospitalization and renal outcome reduction. If we are talking about cardiovascular death and all-cause death, it has only been seen with some of the SGLT2 inhibitors in some of the trials, so it's still controversial to some extent. And if we look at myocardial infarction and stroke, it has not actually shown any benefit. So SGLT2 inhibitor does improve heart failure hospitalization and nephropathy, but the effect on cardiovascular mortality is still actually controversial. Now, if we subcategorize the effects based on the presence of atherosclerotic cardiovascular disease, as in established atherosclerotic cardiovascular disease, and those who have risk factors but have not yet developed atherosclerotic cardiovascular disease, so the benefits are seen only in the first subgroup, that in patients who already have established cardiovascular disease. Although trials emphasize that it is also useful for primary prevention, but on proper subgroup analysis, in the latter group, that is those who have risk factors but have not yet developed atherosclerotic cardiovascular disease, the benefits are not very prominent. And if we all know about the mechanisms, we can grossly, how it helps, grossly hemodynamic mechanisms. Because of its diuretic effect, it reduces preload, it can reduce afterload because it has some effect on endothelial nitric oxide synthase and therefore arterial relaxation. To some extent, it can inhibit local and systemic renin-angiotensin axis, and to some extent, they can also inhibit sympathetic overactivity. Metabolic mechanisms, they take some time to manifest. So the early benefits that we see with SGLT2 inhibitors are mainly due to the hemodynamic mechanisms and not so much the metabolic effects like glycemic control, weight loss, or uricosuriia. And there are so many novel mechanisms that have been discussed because the SGLT2 inhibitor induce ketosis, and ketone bodies are something that the heart finds easy to use, easier to use than free fatty acids. So euglycemic ketosis is a sort of good for the cardiac myocytes, and there is alteration of intracardiomyocyte calcium channels, there is improved hematocrit, all of these leading to the benefits that we see with SGLT2 inhibitors. So with SGLT2 inhibitors, the intermediate effects that we are seeing is the reduction in intraglomerular pressure, improvement in preload, afterload, left ventricular stress, left ventricular mass, improved hematocrit, and ultimately over the years, we observe the effects like decrease in blood pressure, HbA1c body weight, and finally with passage of even more years, the decline in macro and microvascular complications. We also have evidence now to show that empagliflozin and possibly to some extent dapagliflozin lessens glycemic fluctuations as seen in CGM based study. Also, till now we were only having pioglitazone that can reduce hepatic fibrosis, but with this study we know that empagliflozin can also reduce steatosis as well as fibrosis, and possibly even better than pioglitazone, as was evident in this randomized control trial. And we know empagliflozin can also reduce the risk of new onset obstructive sleep apnea. So we know when we are talking about risk factors for cardiovascular disease nowadays, it's not just lipids, blood pressure, etc. OSA, NFLD, and PCOS are also considered equivalent, cardiovascular risk equivalents. Talking about gliptins, so many trials, especially with the past few years after the Carmelina and Carolina trials, we know they are at least non-inferior to placebo or to glimepiride in the Carolina trial. So we know they are safe, at least they are cardiovascular and renal safe. They may not improve the outcomes, but they are safe to use. And this is a summary of all the trials. So benefit has cardiovascular mortality, if we are talking about, benefit is only with seen in empiric, but the other trials found them quite safe. This is about cardiovascular mortality alone. We know gliptins are known to improve beta cell mass by multiple mechanisms, and again data is there to show that dapagliflozin can also enhance beta cell replication or alpha to beta trans dedifferentiation or even beta cell neogenesis. So that explains why DPP4, why SGLT2 inhibitor. Now why this combination? So we have come a long way from the ominous octet to now we have at least 14 arms of pathogenesis of diabetes, and if we are giving both of them, there are so many of them that we are taking care of. And so this combination it's not just about glycemic reduction, just as I said, because SGLT2 inhibitor will reduce blood pressure, albuminuria, and to some extent improve arterial stiffness and endothelial function, while DPP4 inhibitors by their actions will have some effect on appetite as well. So overall they have a synergistic effects in patients with diabetes. But if we are talking about their effects on the pancreas, it's a bit opposite, because SGLT2 inhibitor increases glucagon level, whereas the gliptins decrease glucagon effect. So one of the prime concerns about SGLT2 inhibitors was this increase in glucagon, which can be taken care of if we are giving a gliptin along with. And of course, whereas SGLT2 inhibitors reduces body weight and blood pressure, at least DPP4 inhibitors do not increase it. They are weight neutral. So they have complementary mechanisms of action. The increased glucagon with SGLT2 inhibitor is reduced with gliptins. The weight neutrality of gliptins enhance the weight reduction effects of SGLT2 inhibitors, and there is none of these increase the risk for hypoglycemia at any cost. So if we are using both of these, we are targeting many organs at a time and providing the patient with multiple benefits. And no wonder they have shown better HbA1c reduction as compared to monotherapy with gliptins or with SGLT2 inhibitors, better effects on blood pressure and weight as well. And if we can remember the DELIGHT trial, it actually showed that while the albuminuria reduction with SGLT2 inhibitor is manifest around after 24 weeks at least, but if we are giving a saxagliptin along with dapagliflozin, the benefits with this combination on albuminuria reduction were prominent even earlier. Regarding safety, overall safety profile is similar to those of the individual components. Rather, if we are using a gliptin along with an SGLT2 inhibitor, there could be a lower rate of genital mycotic infections, because the fungi, they have to express DPP4 enzyme, and if you are in order to proliferate in that pH, but if you are giving DPP4 inhibitor, they cannot do this, and therefore they cannot proliferate in the genital area. So that explains the advantage of using a combination therapy. Now, why initial combination therapy? What is the need to intervene so early? So based on the ICMR INDIAB study, we know only 30 to 40% of our patients are achieving their target HbA1c or target lipid levels. And the prevalence of macro or microvascular complications, even in newly diagnosed type 2 diabetes, is pretty high. The risk factors are also very high. And of course, if we look at the different decades, even as early as 30 to 40 years, the prevalence of hypertension, dyslipidemia, all of these are pretty high. So just even much before the patient is diagnosed with type 2 diabetes, they already develop risk factors, they already develop atherosclerotic cardiovascular disease to some extent, and they already develop microvascular complications. This is why just at the time of diagnosis of type 2 diabetes, we are supposed to screen them for macro and microvascular complications, unlike type 1. And the benefits of the SGLT2 inhibitors in many of the trials were seen very early as day 17 for heart failure reduction, as early as day 27 for cardiovascular death, hospitalization due to heart failure composite reduction. And of course, the benefits are sustained throughout the follow-up period. And right from the UK PDS trial, we know about the concept of metabolic memory, that even if the effects of intensive glycemic reduction are not apparent during the trial on macro or microvascular complications, but in the long run, after 20-30 years, they become very much significant. Last year, the ADA published a young onset diabetes consensus, in which they have clearly mentioned that for them, it's better to consider an early combination therapy. So that explains why initial. Now coming to my last question, can this combination replace metformin as the first line agent for those with type 2 diabetes? So although there were some controversies, but now it's clear that meta-analysis of several trials with metformin, it doesn't really reduce myocardial infarction or cardiovascular deaths. In fact, if we are giving background metformin therapy, to some extent it undermines, it reduces the MACE benefit that are seen with SGLT2 inhibitors. If you look at the mechanism, the way metformin acts is through AMP kinase activation, and the way through which SGLT2 inhibitor demonstrates its benefits on the heart is by SIRT1 as well as AMPK activation. Now, if there is an SIRT1 and AMP kinase, there is some interaction between these two. So, if you are already providing some amount of AMP kinase activation with metformin, background metformin use, the benefits seen with SGLT2 inhibitor may not be so much prominent. So the concept that SGLT2 inhibitor should be the first line therapy, not metformin, was first proposed in the European Society of Cardiology 2019 guidelines, and now ADA incorporated this in 2021 when they said that they can be used irrespective of HbA1c, irrespective of baseline metformin use. So that answers all my questions. So now coming to final practical aspects, whom to give and whom not to give. Of course, if we go by guidelines, all patients with established ASCVD, with risk factors for ASCVD, with heart failure, with CKD or with albuminuria, SGLT2 inhibitors are indicated, and gliptins are a very good add-on. So we can initiate a combination of these. So this is the same thing in with better clarity. Also the AACE guidelines, they also mention that irrespective of baseline metformin use, we can give SGLT2 inhibitors if there are any of these complications. And what about, and when to initiate a combination therapy? Again, clear guidelines when the HbA1c is at least 1.5 to 2% above the target, or the baseline A1c itself is more than 9%. In younger onset diabetes who need some cardiorenal protection, and RSSDI recommends just if the HbA1c is 1.5 above the target, we can initiate a combination therapy. For those without any risk factors, when to give? When metformin is contraindicated. In combination with metformin, if still the HbA1c is high, so in these patients, even if there is no risk factors, we can give this combination therapy. Whom not to give? All of us know the adverse effects. So euglycemic ketosis is actually yesterday only there was a very interesting case report of euglycemic ketoacidosis in patients without diabetes, with who were given SGLT2 inhibitor for heart failure. And we know the mechanisms. The increase in glucagon and decrease in insulin is the chief culprit behind this. But this can be prevented by taking some basic steps like stopping during acute illness. So both of these patients were actually being prepared for a surgery, and they were given SGLT2 inhibitor, and they developed ketosis even though they did not have diabetes. So they should be stopped at least 3 to 4 days before surgery, during any acute illness, in the very elderly of course. And if their patients were already on insulin, the dose should not be reduced, and adequate hydration is very important. But even then, decay is very rare with SGLT2 inhibitors, just that we need to be a bit vigilant, need to be ensure more stringent monitoring if there are any signs. And regarding DPP4, one adverse effect that we frequently tend to forget is serious allergic reactions. Many patients actually complain of, not many, I will say few, but they do complain of itching, generalized pruritus with the initiation of gliptins, or even few weeks after initiation of gliptins, and we tend to forget the effect of DPP4 and how it can cause allergy as well as angioedema, which is of course much more significant. Pancreatitis, I saw one patient who was having very high triglyceride levels, 800, 900. Just after initiation of gliptin, he actually developed acute pancreatitis. So we need to ensure, we may check though it is not any guidelines, but I feel it's essential on our part to check the lipid levels, to ensure the patient is not having very high triglyceride levels or some other factors which can lead to pancreatitis. And joint pains with gliptins, this is also a known entity which we tend to forget because the mechanism is not known, but it typically presents like a rheumatoid arthritis, but thus that the seromarkers are negative and the inflammatory markers like CRP or ESR are not very raised. In Indians, this combination, are we going to benefit in any additional way? So we know we belong to this thin fat phenotype, we are diagnosed at a younger age, we do not have too much of generalized obesity, but a lot of central obesity. We have more of insulin resistance, and this meta-analysis actually showed that SGLT2 inhibitors as well as possibly gliptins, because incretin axis is also a bit different in Asians, so their effect may be greater in studies where predominantly Asian individuals were included. So to summarize, this combination can address multiple pathophysiologic defects, can achieve glycemic target early without any additional risk of hypoglycemia, provide cardiorenal protection and possibly CV death reduction, reduction in body weight, blood pressure and other risk factors, can lower the incidence of genital mycotic infections compared to SGLT2 inhibitor alone, all coming at the convenience of a single once daily pill, and now with the being off patent of so many gliptins and flozins, even at a lower cost. So we know some combinations just do not work, like a Pepsi biryani or Maggi puri, but some combinations are made in heaven, they are just made for each other. So as doctors, to ensure our patient has the best quality of life possible, this is one such combination we can offer to all of them. Thank you so much.
Thank you, Sunetta, for your excellent speech as usual. You have rightly mentioned that where these two molecules can be used together, what are the indication, what are the contraindication. You have updated us the recent guidelines of the management, holistic management of diabetes. Now the floor is open for discussion.
থ্যাংক ইউ সুনেত্রা বাট গুড প্রেজেন্টেশন। আমি একটা কোশ্চেন ছিল যে আমরা জেনেছি যে সিভিরিক্স অলরেডি ডেভেলপ when we diagnose a case of type 2 diabetes. At the time of investigation, at the time diagnosis সময় যদি ইনভেস্টিগেশন করি তো সেখানে কোনো সিভিডি কোনো ইনভেস্টিগেশন করব
না, এটা ক্লিয়ারলি মেনশনড আছে যে এসিম্পটোমেটিক লোকদের শুধু শুধু ইসিজি টিএমটি ইকো করে কিছু লাভ নেই, ইভেন ইফ দে আর লিভিং উইথ ডায়াবেটিস। স্ক্রিনিং অফ এসিম্পটোমেটিক ইন্ডিভিজুয়ালস উইথ সাচ টেস্টস ইজ নট ইন্ডিকেটেড।
অনেক সময় এখানে দেখলাম যে বেনিফিট অফ দি SGLT2 ইনহিবিটর দ্য বিপিও রিডাকশন হচ্ছে, বিপি কমছে। মাঝে মাঝে পেশেন্ট আর T2DM উইথ ব্লাড প্রেশার 110/70, এইসব ক্ষেত্রে আমরা কি SGLT2 দিতে পারি?
হ্যাঁ, হাইপোটেনশন করে না, যাদের হাইপারটেনশন যেমন সুগারের ক্ষেত্রেও তাই, হাইপোগ্লাইসিমিয়া করে না, হাইপারগ্লাইসিমিয়া থেকে নর্মাল করতে পারে, এটাও বিপির ক্ষেত্রেও ব্যাপারটা সেরকমই। শুধু যারা খুব এল্ডারলি, যাদের একটা অ্যাডিশনাল হাইপোটেনশনের রিস্ক থাকে বা হাইপোভলিমিয়া রিস্ক থাকে, তাদের ক্ষেত্রে হয়তো একটু কশাসলি দেওয়া ভালো।
থ্যাংক ইউ।
You have mentioned in one of your slide that young patient we can initiate the combination therapy without starting metformin. So is there any mention of a particular age in the AAC
Actually,
guidelines?
by definition, young onset type 2 diabetes, they have used the cutoff of 40. Though some people use a cutoff of 35, but they had used a cutoff of 40 years.
Okay, thank you.
Already we know that is the obesity is one of the factor nowadays, because obesity is the metabolic de-harassment is there. As you know, we are going to GLP-1 analog is there, oral formation is also there, and that also have a very good study regarding the pioneer study, 10 pattern study. Now, what your think about that? If the patient is coming is obese, if the patient can afford the GLP-1 analog, what is your choice regarding the SGLT inhibitor or GLP-1 analog?
Of course, weight reduction is much better with GLP-1. There is no doubt to it as compared to SGLT2 inhibitor. But certain things are there, like for non-diabetic individuals with obesity, it is not yet recommended. GLP-1 is not yet recommended. But if a non-diabetic individual is also having a heart disease, we can give one SGLT2 inhibitor. Or if a non-diabetic obese individual is also having one renal complication, which most of them actually may be having due to obesity-induced albuminuria and other factors. So we can give SGLT2 inhibitors, but we cannot give a GLP-1. But if we are talking about a diabetes in whom obesity is the only concern, then of course GLP-1 is better than SGLT2 inhibitor.
My question, as you know, in case of diabetes along with NAS and obesity, SGLT inhibitors is much beneficial, that it improves the liver enzymes. Can you highlight in case of non-diabetic NAS, can we use SGLT inhibitors?
There is no such recommendation as of now, but I think in few years it will come. Just as it has come for heart failure and CKD, it will come in maybe on 2-3 years it will come. But it is not there as of now. AASLD, the guidelines we use for liver, fatty liver, it is not yet there for non-diabetes.
if any question from...
Any more question? Ma'am, I will be requesting you to have a seat there. Okay, we have got one more question.
Hello.
Yes.
Myself, Dr. Gautam Bishwas. One of the slide there was showing that allergic reaction is more in sitagliptin and
Not sitagliptin, can occur with any gliptin.
any gliptins, but there was a grade in this slide and sitagliptin
That was
in
for
the
joint pain, not for allergy.
Okay. So I want to know your practical experience regarding frequency of allergic reactions in gliptins.
It is rare, but it does occur. It's rare. Maybe I cannot say the frequency because there is no study done on that, but it can occur actually.
Okay, thank you.
One comment from me. Despite this lot of drugs, these gliptins and this combination of DB4 and SGLT2, we have not seen the decline in the incidence of renal failure, this kidney disease. Maybe one of the reasons that there is some divergence in the parameters such as this albuminuria and EGFR. There is some divergence going on with this introduction of. So there is emergence of one phenotype as non-albuminuric kidney disease. Am I right? So what is your take about these two molecules in those phenotypes of patients, this group of patients? Is this going to benefit the patients? This, because it's a 20 to 25% of patients we are seeing in our practice.
Yes, sir. So, sir, in this non-albuminuric decay, if we look at the mechanism by which SGLT2 inhibitors cause renal benefit, it is not supposed to benefit too much. Rather with GLP-1, because it acts on the fibrosis and oxidant these things, so they should be more effective in this non-albuminuric decay than SGLT2 inhibitor. But in the trials in the renal trials, they have always used a composite. They have never used only non-albuminuric decay reduction for SGLT2 inhibitors. So it will take some time to answer this.
No other comment, last comment by.
Thank you all.
Thank you very much. We have learned a lot. Sunetta, you are not only Sunetta, you are a Subhakta also, you know everything. And we hope to see you in future seminars also.
Thank you so much, ma'am. But before that, we will be felicitating ma'am with a bouquet of flower. And along with that, there is a memento. I will be requesting our chairperson, Dr. T.N. Banerjee and Dr. H.D. Mondal to come forward and felicitate ma'am with a bouquet of flower as well as with a memento and a token of appreciation. And can I request all the people present here in the auditorium to put your hands together for Dr. Sunetra Mondal.
To felicitate Dr. T.N. Banerjee, may I request Dr. Jayanto Rana sir to please hand over a flower of bouquet and memento to Dr. T.N. Banerjee sir, please.
I will be requesting Dr. Subhrata Bhattacharya to come and join us in order to felicitate our chairperson, Dr. H.D. Mondal. Please come and join us. It's a lovely frame and we want each and everyone in the frame. So please come and join us on the stage, please. It's a moment of pride for us. A bouquet of flower and along with that a token of appreciation. So, ladies and gentlemen present here, let's move to the second session. And for the second session, I will be inviting Dr. Prashanta Kumar to come and join us. Dr. Prashanta Kumar qualifications include MBBS, MT in Pulmonary Medicine, FAPS designation of Associate Professor and Senior Consultant, Department of Respiratory, Sleep and Critical Care in the institutes affiliated affiliated with includes the IQ City Medical College and Super Specialty Hospital in Durgapur, West Bengal. एक बार जोरदार से तालियां हो जाए. Ladies and gentlemen, please put up your hands together for Dr. Prashant Kumar. And I will be requesting our chairperson to come and join us once again. I will be requesting our chairperson. I will be requesting our chairperson, Dr. B.D. Chatterjee, Dr. Mofidul Islam to come and join us. Please put up your hands together for our chairperson.
Shall I? Yes, sir. Good morning, everyone. Thanks all the office bearers of ABCDCon, all the seniors, dear colleagues, and fellow practitioners of Bardhaman district. We still call it Bardhaman district, irrespective of Purva Paschim. So this is kind of a home ground for us. And such a wonderful morning, such a wonderful beginning of seeing a father and daughter duo to start the whole conference. So inspiring. We all want to be associated or be like something like that. So I just take that further, and I am here not to teach anything. There's no topic, there's no teaching. It's about discussing a concept. As a pulmonologist, it's my responsibility, like how a diabetologist's responsibility is to tell you about a therapy, how to use, when to use. So as a pulmonologist, my role is to tell you about a therapy which is available, which you are aware of, which everyone knows about it, how to place it in your practice. So see, I will be talking obviously mostly about obstructive airway disease. The thing about obstructive airway disease that all the medicines which you know about obstructive airway disease serve the same purpose. There are two purposes of medicines in obstructive airway disease: reduce the symptoms, reduce the exacerbations. All the medicines will perhaps do that. But the most important thing in the obstructive airway disease is not the drug, is the delivery of the drug. In our OPD, there are at least 5 people talking to patients about how to take the drug. In a respiratory OPD, in my OPD perhaps, there are 5 people talking to all the patients who has visited our OPD about how to take the drug. So the more than the drug is the delivery of the drug which is important. So I'm going to talk about one delivery methodology which needs some attention, and perhaps we need to place it in a more emphasized way rather than more concised way. Generally, we don't use this methodology a lot, this delivery system a lot, but I will tell you that these things needs to be placed in a well. So, this is the topic would be home maintenance nebulization in COPD patients, particularly in COPD patients where the therapy needs to be persistent and for a longer duration of time, their home nebulization, what role it has. So, change হচ্ছে না এটা So I bring greetings from my institute. This is IQ City Medical College and Hospital, and then so what are the objectives? Like I said, so we are going to understand the drug and device usage in acute exacerbation of COPD and patients as discharged, that is maintenance therapy, role of nebulizers in a long-term management of COPD. We have used MDI, DPI and other methodology, oral drugs, but then role of nebulizers here and nebulized drugs that can be used in the management of COPD. So now we have the gold guidelines we have been discussing. So this time gold guideline is the most exciting one. The last one I'm quoting is the most exciting, where they have reduced some confusion, where all the physicians felt that you have COPD, but it was not fitting in the criteria of COPD. So we were at a loss of word to tell what do you have. So you said COPD, but other practitioner or some other source of information said that since you don't have these criteria, you don't have COPD. But you knew that patient has COPD. or going to develop COPD in times to come. Hence, we have certain terminologies which has helped us, that is pre-COPD, that is the pre-COPD, the PRISM, where your lung functions are preserved, but still you have features of COPD. So all these things have really helped us in diagnosing, putting us the patients in categories which need some attention, and we can tell. So global burden of COPD is ever increasing, and perhaps it is also very high for the time being also, because approximately 10 to 11% of burden is huge. So if I vaguely take it also, there's a huge burden, one of the leading morbidity and mortality, having morbidity and mortality in the world. Dialysis, there are lots of work which has been lost due to COPD, there are lots of deaths which has happened to COPD, so huge morbidity and mortality. Smoking is the largest contributor of COPD, but then in India it's a non-smoking COPD which is more common. We all are aware of that, and especially in this part of the world where we practice, there's a non-smoking COPD is also very high compared to smoking COPD. Categories, there were ABCD categories, now only ABE. E is a combination of C and D. I'll not go into the detail of it because my point here to talk here is entirely different today. So now you know that a group A only a bronchodilator, group B a LABA and LAMA, 2 bronchodilators perhaps, and group E LABA LAMA with addition of drugs like oral corticosteroids also. So I'll not go into the therapy because I want to emphasize on few points. So why you want to use a bronchodilator therapy? Because we need to understand few things. Asthma is more of anti-inflammation, COPD is more of bronchodilation. Always remember, if you give lots of anti-inflammation in COPD, that may not help the patient. If you give lots of bronchodilation in asthma patient, that will not help the patient either. Help the patient in the sense, I want to tell you that it will not help as expected to the patient. Patient may have a transient improvement, but there can be problems. So what are the 3 things which we fight, our point of concern are bronchoconstriction, mucus hypersecretion, and airway remodeling. So bronchoconstriction, yes, you have to give lots of bronchodilators. Mucus hypersecretion is always a problem in COPD patients. And airway remodeling, if you don't take care of all these things, then it will lead to airway remodeling. Hence, bronchodilator therapy in COPD is the mainstay of therapy. Hence, like I said, in asthma, it is mostly anti-inflammation. In COPD, it has to be mostly bronchodilation. This is the basic understanding of the therapy in these 2 diseases. So, now reflex cholinergic tone appears to be a major reversible. That's why you see that in a group A, if you have to choose one bronchodilator, it has to be a LAMA, it has to be antimuscarinic, because you must be aware, the practitioners of the past, that COPD was once named as muscarinic crisis and a cholinergic crisis. Hence, anticholinergic agents are still the mainstay of therapy because that gives you the maximum amount of bronchodilation. So I also want to emphasize on a point, a new drug which is glycopyrrolate, which is used as a bronchodilator, and that is an effective bronchodilator that we give in a DPI form. Now few MDI forms have also come, and even in Respule form we can use this bronchodilation. So, so what influences your drug prescription for ACOPD patients with discharge? So one is how do you choose for device? Like I said, it's not the drug, it's the delivery which has to be important. So how do you choose which device to be given? So there can be device related questions, device related decisions, then disease related decisions, drug related decisions, and patient related decisions. So you have to keep all these 4 points in mind while deciding for a device to achieve an effective delivery of the drug. Hence, the device has to be easy to use, it should be widely available, it should be cost effective. Disease means severity of disease. If someone is having severe disease, your device will be entirely different. Drug related, what particular kind of drug you want to deliver, because one device can be used for one particular kind of device. And then patient related, you have to see the condition of the patient. One size does not fit all. Hence, you cannot give one device. I like this device is not the answer for your practice. You have to choose based on the patient. So now, what all devices do we have? So ERS did a very good study where the peak inflow rate or inspiratory flow rate was the criteria, where it was said that there was a cutoff of 30 liters per minute. If someone is having a peak inspiratory flow rate of less than 30 liters, then you cannot give any other device other than nebulizers. And if it is between 30 to 60 liters per minute, then you can give an MDI. But if it is more than 60, then a DPI will be more suitable. This is a very good, but whereas nebulizer is a therapy which can be given to all kinds of patients if you feel that can be given to a patient. So prevalence of low peak inspiratory flow rate at discharge is very common in respiratory patients. We all know that there is approximately 15% of lung function loss in a patient who was admitted for a week with COPD exacerbation. Hence, that time patient may not have that optimal lung function which you require for them to maintain the physiology or even to accept the drug therapy. Hence, that has to be kept in mind, and you have to give a device which is easy to use and deliver the drug effectively. Always, whenever if you have started someone on a nebulizer or something, then every follow-up, there should be an attempt to make it move them to a MDI or DPI. That goes without saying. But then it may not be possible all the time. But then you should not insist irrationally that you must not stop using nebulizer and move to a device which is. If it does not fit him, it does not serve the purpose, you must not. So this already discussed. So selecting the right nebulizers, we have three kinds of nebulizers. The jet nebulizer, the most common nebulizer which we are using now. Then there are ultrasonic nebulizers and vibrating mesh nebulizers. Ultrasonic nebulizer, no point discussing it because we hardly have in our country to be used in this way for home maintenance. And then the next thing with the mesh nebulizers, which has come to the market nowadays, and it's a fancy looking device, battery operated, very handy, takes lesser time to deliver the drug, but unfortunately it cannot drug all the drugs. It cannot deliver all the drugs, hence you have to be very careful. The maintenance cost is more because there is a mesh inside which can get blocked with the molecules, the drugs. Hence, the most commonly used the jet nebulizers are still the way to go, and I think that is the reasonable way to prescribe to a patient where nebulizers are required. So jet nebulizer, like I said, it's a widely preferred. So what all drugs can be given? These are the drugs which are available, which can be nebulized to a COPD patient, like SABA, SAMA, combination of SABA and SAMA. Then you have LABA, LAMA. Then you have ICS and LABA combination, which is also most commonly used nowadays. And then you can also give mucolytics through nebulizers, but you have to be cautious for reflex bronchospasm in cases where you have to give a mucolytic through a nebulizer. Lots of antibiotics can be given nowadays, and they are said to, in the future, they are said to be mainstay of therapy in respiratory infections alone, respiratory infections alone. If they have combined infection, that may not be a way to go. So now if you give a nebulized LABA, like I said, the COPD, LABA is the bronchodilator, is the mainstay of the therapy. If you give nebulizer, it has been shown, it was published in 2018, that it reduces the visit to the ER and your ICU admissions. So now long-term safety of formoterol. What really comes to our mind is if we give a bronchodilator or LABA or LAMA for a long period of time, that may have an adverse effect on mostly cardiac, but then it has been shown that it hardly has any side effect. Theoretically it may have, but practically also it hardly has any side effect, long-term side effect on, if given in a right dose and given for a right duration of time. So efficacy of nebulized formoterol is, like I said, we will talk lots about bronchodilation in COPD rather than anti-inflammation in COPD. So efficacy is equally effective. Formoterol is very effective. even if you add say there is another belief that if you give an ICS to nebulize, you're giving a higher dose, so more side effects and more. If you give it for a longer period of time, patient may suffer, but not so. It is as equal to as giving through MDI or DPI. So don't worry about all that. Giving a higher dose through nebulizers as an inhaled form. So glycopyrrolium, this is a molecule which we should be talking about. We have been using it for quite some time now, and it is a M3 receptor selectivity. Then you have a longer duration of action compared to other LAMA which you already had. Then faster onset of action compared to tiotropium which was being used earlier. Can I have little silence, please? So more potent than tiotropium. So it is more potent with tiotropium. Tiotropium has been used for quite some time now. So it has moved, the practice has moved from tiotropium to glycopyrronium. And lesser oral absorption, hence the side effects are lesser. So glycopyrronium 25 max BD or 50 max OD is the way to go. But what we really worry about the OD dosing is the nighttime symptoms. COPD patient will always have some nighttime symptoms. They may present well to your OPD, but then they may have symptoms in the night. Hence, we from OD dosing of 50 max, we want to tell you that you better use a BD dosing of 25 max to achieve a better symptom control in these kind of patients. So there were different trials based on that. It has Golden 3 and Golden 4 are the trials which are the most spoken about, where they showed that it has also reduction in exacerbation rate. So are there any concerns regarding the cardiac safety of LAMA? Like I said, theoretically yes, but we have not come across any significant number of patients who has come to us with any cardiac issues as such. More so, but then they will have some cardiac overlap disease. So we have to be cautious, there is no doubt about it, but then not significant. It must not be significant when you use these kind of drugs. So good nebulization practice is one thing which has to be followed with all the drugs. Whenever using any drugs through nebulizer, it has to be your good nebulization practice. There is a pharma company who helps you in achieving that, training your nursing staff, training your team members, training yourself rather in good nebulization practice. You must make use of it. Don't think that this is not useful, but this is very, very useful. You can have kiosk. In our OPD, we have our good nebulization practice kiosk where patients are briefed about how to nebulize, because as a doctor you cannot every time tell to the patient all the points about nebulization. Hence there has to be a dedicated staff which can tell you. So this has to be mentioned in all the talks where nebulization is talked about. Good nebulization practice has to be emphasized upon, because this is an hazard to other person also who is there in the room. So some infection can spread, some other complications can happen if you don't follow certain guidelines with nebulization. So what are the take home points? All inhalational devices are equally efficacious if you're giving to the right person, right patient, in right dosing for right duration. Just that you have to be very, very cautious every time with all the patients. You cannot have one size which fits all, like I repeat. And selection of appropriate inhalational device should have individualized and patient specific approach. Like I said, every patient is different. You may feel that this patient can take a DPI, but you will realize that patient cannot take a DPI. Hence, peak inspiratory flow rate has to be measured in your OPD if possible. The device is not commonly used, but it is available in, if someone goes abroad, you can ask them to get one to check it. Not all patients can use handheld devices. Hence, prescribing one device to all will not give you the same results. Thank you very much from my team. Any questions, please? Thank you.
Thank you, Dr. Kumar, for your nice deliberation. All of us learned a lot regarding your nebulization treatment. So now I hand you over.
Thank you. Very good presentation. If there are any question from audience,
Yes.
please carry on.
Hello.
Yes. Thank you for good presentation.
Thank
but
you, sir.
Without ফিগার মানে ছবি টবি না দিয়ে এটা খুব একটা ভালো অ্যাট্রাকশন করে না, কারণ আমরা অনেকজনেই জানি না এইটা নিবে এটা বাড়তে 2-3 বার করে টানবে, কি যে টানছে সেই টানে, এই নাক দিয়েও টানে না, আমার কাছে এসে নাক দিয়েও টানে, আর ওই বিড়ি ফুক ফুক করে, সেই জন্য এখানে একটু প্রেজেন্টেশন দিলে বোধহয় ভালো হতো
স্যার। ওটা অ্যাকচুয়ালি ওটা লাইভ ডেমো ওনার স্টলটা থাকে যেখানে অল দ্য ডিভাইসেস থাকে, যা অবধি আপনি হাতে নিয়ে ওটা বুঝবেন না, it is very difficult to understand from the pictures.
এক নম্বর 2 নম্বর
There is a live demo stall in the CIPLA.
আচ্ছা, আর
There is a live demo.
আর নেবুলাইজেশন অক্সিজেন খুব নেসেসারি।
কি স্যার আমি বুঝতে
অক্সিজেন নেবুলাইজেশন অক্সিজেন খুব প্রয়োজন।
Oxygen? No, COPD patient you have to be very cautious about.
COPD as a whole nebulization.
No sir, no, you have to be very cautious in that, because generally আমরা দেখি কি অক্সিজেন থেকে ওটা অ্যাটাচ করে generally die. That is a very bad practice.
COPD asthma তো হয়,
No sir, যদি অক্সিজেন দরকার হয়, someone not maintaining, then only oxygen is required. Otherwise it is absolutely disastrous for the patient.
Okay, you just in your slides just say that inspiratory flow rate.
Yes,
if
sir.
it is below 30, you have to going for nebulization.
Right, sir.
Is 30 to 60, you have to going for MDI,
Right,
and
sir.
above 60, it is for DPI. But in our chamber, how we measure that the patient is on inspiratory flow rate by what is the rate of that?
Sir, there is actually a device to be measured, honestly
Yes.
speaking. So device has to be purchased by the practitioner.
Oh,
So,
I see.
the
That
peak
actually,
inflow,
otherwise, I can. How can I?
You can, based on the experience, you can say. Otherwise, sir, it's very difficult to. Without the device, you cannot measure it. These are all research data. Hence, this was measured with a device in a research setting.
Yes. Another thing you just tell us that oxygen may not be needed.
Yes.
But we are very much habituated in our ICCU also. We are giving the oxygen in
Right,
COPD patient till his oxygen level is remain above 90%.
Right, sir.
Already we know that in COPD patient is 88 to 92 is
Right, sir.
enough for the patient.
Right, sir.
So is there, if you give the oxygen, because already the ICCU technician they are giving the oxygen, there is any toxicity regarding that? Have you?
Yes, sir. So oxygen, that's a bad practice. Like I said, it is not encouraged with the oxygen. It has to be with the machine, sir. Only if someone is severely hypoxic, then only oxygen has to be there. But for the want of device, perhaps this is what used. It's not a good practice. We discourage it, sir.
Another thing is that you when we give the MDI, when directly inhale, it is probably is not going the
Very less drug delivery, sir.
It is better to give with the spacer.
Right, sir.
There is any mechanical spacer is there which give the more.
No, sir. There's nothing. It has to be active inhalation.
Active
If someone is not able to do active inhalation, then the nebulization is what is close to delivery. But there's no passive inhalation, sir.
Okay, thank you very
Okay.
much, sir.
We are now very much concerned about our pre-diabetics in our clinic and its complication and feature.
Right, sir.
But in your slides, there's a specific term that pre-COPD.
Yes, sir.
What your opinion and this complication and management?
So management means, sir, patient may not be symptomatic, but they are going to develop COPD in times to come. They may have small intermittent symptoms. So there is a group A kind of category in gold where you can place them, or you can give little symptom. You can just avoid exposure to whatever has caused to COPD, maybe smoking, maybe exposure to biomass fuel. Then you can prevent development of COPD. How you can prevent? Just lifestyle modification is the first line of treatment in diabetes. Same thing can happen in COPD also.
Morning, sir.
Hi.
We all know that PMDI with spacer deposits more drug in the lungs.
Most likely.
Most likely. So, for a critical patient while discharging from the hospital, maybe I think we can prescribe nebulization for a few days.
Right, sir.
But considering how the patients maintain a nebulization device, do you personally feel that it is very much feasible to continue in the long term in home nebulization?
See, it is a difficult because it's expensive. It's difficult to manage. All those negative points are there. But if someone requires a nebulizer, you have to give a nebulizer. You don't have a choice. You cannot deny someone a drug. You cannot deny someone drug because it is expensive or something. You have to find a way. You have to educate the person. Like I said, we have nebulization kiosk in our OPD where all the nebulizer patients go through, they are told about, we follow. There are certain pharma companies which are also giving it for free. Nebulizer machines are free, which is the first, the major expense in nebulization practice. So that is also there. Sometimes you can arrange for medicines, if long-term medicines can be arranged directly from the stockist or something to reduce the cost by 20, 25, 30%. So all those maneuvers has to be done by the physician to get the results. Yes, sir.
Okay.
Having nocturnal problem. So how to manage this one? It's a practical problem. Patient with pneumonectomy.
So the patient, if they are having pulmonary hypertension, that's a different thing.
No pulmonary hypertension.
Okay, then you manage as COPD, no problem.
Daily nocturnal problem.
So you give a bronchodilator in the night also.
It's already given.
So you add on to the therapy, you put in the next group, you add on to that, you give oral bronchodilators if required.
Everything is given.
If mucus hypersecretion is there, you have to relieve you have to take care of the mucus.
Should we introduce this midnight nebulization every time?
No, sir. Night. These all are long-acting ones, so you don't have to give it more frequently. You can give it, say, 8 p.m. What we used to call a theophylline 8 p.m. drug. So you can give a 8 p.m. bronchodilation that is sufficient for the whole night. Sir.
But it is not sufficient for some group of patients. Long-acting drugs.
No, you have to add on to the therapy.
Add on to the
therapy, sir. There are different methods of, or you have to find out some other cause of breathlessness.
Thank you very much.
Okay, thank you very much, Dr. Prasanta Kumar, that you are here.
Thank you.
Thank you all for your patient hearing. And thank you, Dr. Kumar, once again.
So thank you, Dr. Prashant Kumar, for your detailed analysis. And now we all will be felicitating Dr. Prashant Kumar, and I will be requesting our chairperson, Dr. B.D. Chatterjee and Dr. Mufidul Islam, to come and join us for the felicitation with a bouquet of flower and a token of appreciation. Ladies and gentlemen, kindly put up your hands together. And now I will be requesting Dr. Arno Banerjee to come and join us and facilitate Dr. B.D. Chatterjee, our chairperson, for this particular session. Thank you so much. একইভাবে অনুরোধ জানাই ডক্টর সুজন সরকারকে মঞ্চে চলে আসার জন্য, and I will be requesting sir to felicitate Dr. Mufidul Islam with a bouquet of flower as well as a token of appreciation. Thank you so much. Let's move forward to the next session. For the next session, I will be requesting the chairpersons to come and join us.
One microphone, please. Hello. Before going into our next session, I would request all of you that our own YouTube and Facebook live channel are active, and it is a live telecast. You just type ABCDCon and you can get it. So that's a request. Another is there are many QR codes hanged everywhere all over the arena of Bardhaman Bhavan. So if anyone is interested to download their photographs, still photographs, they can just scan the QR code and get it in their mobile. Thank you.
Thank you so much, sir. So yes, proceeding, I will be requesting the chairpersons to come and join us. I will be requesting Dr. Subrata Kuntu and Dr. Subrata Bhattacharya to come and join us for this particular session as chairpersons. So ladies and gentlemen present here, kindly put up your hands together for Dr. Subrata Kuntu and Subrata Bhattacharya. And the next speaker that I would like to call upon is none other than Dr. Arunangshu Ganguly. Sir needs no introduction, but still let me just introduce him. He is D&B Cardiology Senior Intervention Cardiologist and Director, Health World Hospital, Durgapur. I will be requesting you all to please put up your hands together for Dr. Arunangshu Ganguly.
So, I would like to put a few lines in this regard that Dr. Arunangshu Ganguly, আমি বাংলাতেই বলছি আমাদের অরুণাংশু দা, আমাদের প্রথম এবিসিডি কন থেকে এটা আমাদের নবম এবিসিডি কন। যদি কোভিড মধ্যে না হতো এটা দশম হতো। প্রথম থেকে নবম পর্যন্ত স্যার আমাদের সঙ্গে আছেন। আমরা যতদিন চালিয়ে যাব আমি প্রার্থনা করি ঈশ্বরের কাছে এবং আশা করি যে অরুণাংশুদা আমাদের সঙ্গেই থাকবেন।
So, as the technology is growing and sir has come up with a new technology, this would be the first time that you will get a QR code from display. You can scan with your mobile and you can...
আমি বলে দিচ্ছি। Respected chairpersons, both Shubhrata, friends, I am really thankful for inviting me to this conference, which is very close to my heart. Since inception, I am there with ABCDCon, and perhaps next year we should do it at a much bigger scale. ABCDCon has grown. There is seldom a few conference, not in the periphery, but in the state itself, which has kept its indomitable presence like ABCDCon has kept in the conference arena over last 9 years. And it has grown in stature, it has grown in quality. This time the list of speakers that I have seen, that was much better than the last time because of not better in the terms of person speaking, but in the terms of collection, the variety. So wish you all a very happy 10th year in advance. And I had promised to remain with ABCDCon, although I shuttle in this zone, but I will remain with ABCDCon all the time. This time, actually, I thought to come forward with a few, a different sort of topic. It's a cardiologist and diabetologist conference. Each time we present only interventions, but there are many things in cardiology beyond interventions or before and after interventions. It appears to all and sundry that intervention is the only thing that cardiology has, but in actuality it is not so. So I have taken up a very intriguing topic, oral anticoagulation therapy, the caveats for the physicians. What I have done is not much of theoretical discussion. I have presented, this can be a workshop. I have a collection of a huge number of cases. But here I have taken up 6 situations, only 6 cases. Now these cases will be given. There will be a QR code coming there. With your camera you scan the QR code. When the answer comes you can vote it. And the vote shows the response. Let us see if the net permits me, then at least 2-3 cases we will do. And if you want we can do all the 6 cases. But if net doesn't permit, then I'll go the normal way, okay? Why oral anticoagulants? You see, there was a time when we had warfarin and acetrom only. So that pitiable INR, the variation in INR, when to do, nothing to eat almost, because if you take up Google and find out vitamin K containing Bengali foods, almost everything goes out. So this was the thing which has continued for 50-60 long years. With the advent of these newer generation anticoagulants and the utmost necessity of using anticoagulation in atrial fibrillation and all our patients aging because of increased life expectancy rate, because of early intervention and management of disease processes, atrial fibrillation is gradually becoming more and more common. So therefore, the use of anticoagulation is becoming more and more common. And with the advent of this new generation and anticoagulants, where there is no limitation to food, where there is no limitation to drugs, where there is mild limitation to other things, easy of use, no need to do INR, the floodgates have opened, and we have started writing these oral anticoagulants, which we call as NOACs or DOACs, newer generation oral anticoagulants. But the problem with us is every day, when to use it, how to use it, at all to use it or not, these questions haunts us. So that is the reason I chose the topic with only a few situations in mind. We all know that vitamin K, mainly 2, 7, 9, 10 inhibitors, and we have 3 anticoagulants which are newer generation anticoagulants, which are direct anticoagulants: dabigatran, apixaban, rivaroxaban, and a little edoxaban is also there, but a little less used on the eastern parts of the country somehow. So of them, dabigatran is a direct thrombin inhibitor. The rest 3, they are factor 10A inhibitor. This is the difference. They are competitive reversible inhibitors. Factor 10A inhibitors are 3: apixaban, rivaroxaban, and edoxaban. And direct thrombin inhibitor is dabigatran, the first to come. So let us take up case 1. A 67-year-old female complains of palpitation, shortness of breath, dizziness and fatigue, known diabetic and hypertensive, dyslipidemia, obesity and GERD. This is the common patient that we get in the OPD. Blood pressure 150/86. He has an atrial fibrillation with a fast ventricular rate of 132. Lab parameters otherwise unremarkable, and home medications otherwise unremarkable. Metoprolol was started for red control. Now, how do we approach the patient? Now, approach to anticoagulation is a double-edged sword, because you have to balance between the thrombotic or embolic stroke risk and the bleeding episode. Suppose a patient comes to you who is having a thrombotic stroke. You find that the patient has an atrial fibrillation. You start an anticoagulation, and the patient comes back to you with a severe GI hemorrhage or a hemorrhagic stroke. What are you to answer the patient? So therefore, this delicate balance is very important, to keep the balance, because there are options wherein oral anticoagulation, without oral anticoagulation, you can manage the stroke incidence. How? By putting in left atrial appendage closure devices. Now, this appears very big, but it every day happens in all the big hospitals in the state. We do it almost 5-6 a month. You just put a left atrial appendage occluding device, and you do not need anticoagulation. Initial 6 months, some antiplatelet, light anticoagulation. After that, the patient leads a normal life. So a patient who has more chances of having hemorrhage, we can avoid oral anticoagulation. So therefore, what is there to be in your desk? This score chart, CHA2DS2-VASc score chart, because this score chart gives you what is the annual rate of stroke risk in the patient. This has to be there. How much prone the patient is to stroke. There should be another chart which is called has bled score. This gives you the chance of having major bleeding. So it is balance between CHA2DS2-VASc score and Hasbled score, that determines whether you ought to give anticoagulation or not. Now, if the Hasbled score is very high, more than 4, rather more than 3, you will think twice. But if it is more than 4, you will stop yourself from giving anticoagulation. Although the Chatsworth score may be very high, there you go in for left atrial appendage occlusion. But if you have a Chatsworth score borderline 0 to 1, you may think about, and the Hasbled score is around 2 to 3, you may think around about whether to give a low dose anticoagulation or antiplatelet according to the situation. Therefore, that is the thing. If the patient does not have a mechanical heart valve, the patient has a stroke risk. Where the stroke risk is very low, that is Chatsworth score is 0, no anticoagulant is required. With 1, oral anticoagulant should be considered. But with 2 or more than 2, oral anticoagulation is indicated. It can be OAC, it can be NOACs, and if these two cannot be given, it can be left atrial appendage closure. Now you scan this. Let us see whether it works or not. Scan হয়ে result আসছে? Show me what is the result coming? हाँ, ठीक है. So we can, this is a case wherein no questions are asked. From the next case onward, questions will be asked. So the approach I told you, according to, there are two studies, Active A and Active W. Active A shows at least antiplatelets is better than nothing in stroke, reducing stroke risk, and warfarin is more effective than aspirin or clopidogrel in reducing stroke risk. In this patient, since the Chatsworth score is 3 and Hasbled score is 2, you have to give an oral anticoagulation. It can be OACs or NOACs. So that is the key point that I have mentioned. Now case 2, this is important. Prosthetic heart valves. 66-year-old male patient just got out of surgery for bioprosthetic aortic valve replacement. Past history, atrial fibrillation, hypertension, gout and BPH. The patient is on apixaban, lisinopril, hydrochlorothiazide and tamsulosin. Labs and renal functions are within normal limit. Which of the following medications is the best for this patient's anticoagulation needs? Apixaban, warfarin with a goal of 2 to 3, warfarin with a goal of 2.5 to 3.5, aspirin plus clopidogrel. Now you scan it and put your answer. ওইখানে ইমেজটা ওখান থেকে সরিয়ে দাও. এগুলো votes. Warfarin 67%, apixaban again 50-50. Acha. This is the answer. আমি একটু differ করব after the preliminary data of enable study. I'll differ slightly a bit with this answer. The correct answer is B. The patients had a Charles-Vast score of 2. 1 point each for age and hypertension, which indicates that anticoagulation is needed in the patient. Now see that the patient is on a bioprosthetic aortic valve. As such, in bioprosthesis, we give a low dose anticoagulation for first 6 months. After that, anticoagulation is usually not required in a bioprosthetic valve. The patient has a valvular atrial fibrillation, no doubt, so the patient requires oral anticoagulation. Any valve which is a mechanical valve, they need warfarin only. You cannot use till date a NOAC in a mechanical valve, because all studies have shown non-inferiority of NOAC compared to warfarin, but superiority has not yet been established. And when you have a traditional therapy and you have a non-inferior report, you cannot put a guideline for that. Therefore, we are awaiting ENABLE study where these groups have been included, including mechanical prosthetic valve, to find out the outcome. Till ENABLE published completely the full data. But ENABLE is also showing that these oral anticoagulation NOACs are favoring good in comparison to warfarin. Okay? So here, if somebody uses apixaban, I cannot say no, because the patient is on a bioprosthetic valve. So first 6 months only I have to cover. After that you don't need in a bioprosthetic valve. So that you have to use warfarin is not a mandate. Okay? Now a patient has to be given oral anticoagulation but has GI hemorrhage. "68-year-old male, history of upper GI bleed 2 months ago while on aspirin enteric coated 81. Aspirin was discontinued and a proton pump inhibitor was initiated. Charles-Vast score is 3, Hasbled score is 3. He has difficulty for follow-up and depends on brother for transport. The patient's estimated creatinine clearance is 85 liters per minute. Based on the case description, which is the preferred anticoagulant? Warfarin, apixaban, dabigatran, edoxaban and rivaroxaban. Finished? Yeah. One of the safest. See, if a patient has a GI bleed while on an anticoagulant, consideration to resume therapy should be done as early possible when the patient is hemodynamically stable. Because it has been seen that these patients, if you do not give anticoagulation, in that situation, the patient fares much worse than giving anticoagulation. So, according to Aristotle's study, the incidence of GI bleeding versus warfarin, you have to choose one where it is not more than warfarin. So, in Aristotle's study, there was no difference between warfarin and apixaban. Okay? Low dose edoxaban had statistically lower bleeding risk but higher thrombotic risk. Dabigatran had statistically higher risk in the dosage required in Charles-Vast 3. Had it been 0 to 1, it wouldn't have mattered, you could have given low dose. But since you cannot give low dose, and in rivaroxaban, the incidence of GI bleed is higher compared to warfarin. Therefore, apixaban is the treatment of choice here. Okay? So in patients with non-valvular atrial fibrillation, CHA2DS2-VASc score should be used in conjunction with a Hasbled score to guide therapeutic decisions. Okay? Case 4, intracranial hemorrhage. Patient has an intracranial hemorrhage. Now the patient has atrial fibrillation. What to do? Here the most important thing, 47-year-old female presented to emergency with complaint of worst headache. Triage, she found slurred speech, blurred vision, right-sided face drooping. She is hypertensive, having atrial fibrillation, type 2 diabetes, hyperlipidemia. INR was found to be 4.2 and blood pressure 187/103. CT confirmed intracranial hemorrhage. Warfarin was held and she was treated with intravenous 10 mg vitamin K and prothrombin complex concentrate to reverse anticoagulation. Question is, what is the appropriate time to wait before restarting long-term anticoagulation after an intracerebral hemorrhage? 1 to 3 weeks, 1 week, 10 to 30 weeks, after 40 weeks. Okay, finished? All voting? Now see the case specific areas. First, you have to evaluate individual's risk of thrombotic and hemorrhagic stroke. Second, choose the optimal anticoagulant and appropriate timing. Third, reduce the risk of recurrent hemorrhage through controlling modifiable risk factors like hypertension, anemia, renal function, diabetes. The timing of oral anticoagulant restarting depends on individual clinical condition. In patients with brainstem or cerebellar intracellular hemorrhage, the timing should be delayed at least for 8 to 10 weeks after the event. On the other hand, if the patient is on a prosthetic mechanical valve who have a very high risk of thromboembolism, it can be resumed as early as 2 weeks after the onset of ICH. But on an average, 10 to 30 weeks is the right time to restart oral anticoagulation following intracerebral hemorrhage. Renal failure. When choosing an anticoagulant in chronic kidney disease, consider that the patient with CKD were excluded from landmark studies. Okay? Now, 58-year-old Caucasian female, history of hypertension, CKD but dialysis not required with atrial fibrillation. What is the most appropriate NOAC for her? Apixaban, dabigatran, edoxaban and rivaroxaban. Which of the four is now? Tell us. Finished? All voting? Any more votes to come? Again apixaban. Why? See, here you have to know that apixaban has only 27% renal excretion, whereas dabigatran has 80% renal excretion
Edoxaban has 50%, rivaroxaban has 35%. So first is apixaban. If the patient wants, you have to give a single dose therapy, then you can think of rivaroxaban, but remember one thing. Everywhere, the maximum creatinine clearance decrease to which the drugs have been tried are various in various situations. For example, less than 30 number of trial patients, less than 5 were 19% only. Only in apixaban did you come down up to 25 ml per minute, and in rest all it is 30 ml per minute. A CCR less than 25 ml per minute, you do not know how the drugs will act, because there is no data so far. Okay? So FDA approved dosage are for dabigatran 75 twice daily from 15 to 30 ml per minute CCR creatinine clearance. Rivaroxaban 15 milligram daily from 15 to 50. Apixaban 2.5 milligram twice daily if more than 2 criteria are met. And edoxaban 30 milligram daily, 30 to 50, not less than 30. Okay? This is, I think, the last slide. Patient with acute venous thromboembolism. Parenteral and overlap oral has to be used. Okay? 55-year-old male comes to emergency with pure DVT. Vitals are stable, hepatic renal function is normal. What oral anticoagulants can be used for transition in this patient? A transition, parenteral to oral. Warfarin, apixaban, dabigatran, rivaroxaban. We know that in DVT, rivaroxaban has the maximum data. Still then, we are wanting to know this. Let us see the answer. Apixaban and rivaroxaban. Apixaban is one of the safest oral anticoagulants possible in elderly, less bleeding risk. In CKD, you can go with less dose modification. In DVT, very good for transition. So apixaban is really good. So this one is a chart. You take it from me and keep it in which situation the dose adjustments are required. This you keep it there. What is the typical dosing in DVT? How in acute DVT? If I go on telling also, you will not register. Now a patient is on warfarin. Will you switch to NOACs or not? And if you switch, how do you switch? Usually remember that a patient who is stable on warfarin, what do you mean by a patient stable on warfarin? That means at least 60% of time therapeutic levels are maintained. That is, the INR is in optimal state at least 60% of the time. Then you say that the patient is stable on warfarin. So now if a patient is stable on warfarin or to the extent acetrom, there is no need to switch over to NOACs because NOACs are costly. This is easier to maintain, and if they keep themselves 60% of the time on oral anticoagulation, chances of thromboembolic incidents are much lower. So in that case situation, we try to persist. But if the patient wants to eat everything, no food interaction, no drug interaction required by them, then only we switch for patient convenience, otherwise not. So 66-year-old male on warfarin for atrial fibrillation wants to carry on his oral anticoagulant therapy with a single daily dose drug with minimal monitoring. The decision was made to switch to rivaroxaban because single daily dose is with rivaroxaban. Given today's INR 2.7 and that he took his last dose of warfarin the evening before. Last evening he has taken warfarin and today INR is 2.7. Which of the following is the best plan for switching this patient from warfarin to rivaroxaban? Discontinue warfarin and initiate rivaroxaban when the INR is less than 0.2. Discontinue warfarin and initiate rivaroxaban when the INR is less than 2.5. Since his INR is less than 3, switch to rivaroxaban beginning with tonight's dose. Or although his INR is less than 3, he should wait 72 hours before switching to rivaroxaban. What should it be? Vote please. This is the last slide. After this, a thank you slide comes. The explanation of this and the thank you slide. This is the answer. Now why? Now you see, changing from, I'm sorry, now changing from DOAC to warfarin and warfarin to DOAC. So in this situation, we are changing from warfarin to DOAC. So if it is apixaban, stop warfarin and start apixaban when INR is less than 2. If it is dabigatran, stop warfarin, start dabigatran when INR is less than 2. If it is edoxaban, then again the same, but INR less than 2.5. But if it is rivaroxaban, you can start when the INR is less than 3. When you change from warfarin to DOAC. If you want to change from DOAC to warfarin, this one, I'll give you the table, keep it with you, because this you cannot memorize right at this point of time. Thank you so much. It can continue and continue in other situations, but thank you for patient hearing.
Thank Dr. Ganguly. No word is sufficient for his wonderful lecture. Though we are lagging time, please just one or two quick questions for him.
Hello. What is the take of this NOAC in case of liver failure? Suppose the patient having the CLD or the severe viral hepatitis, should we continue or should we discontinue?
This is an extremely good question. The reason being, see, in cases of liver failure, the INR rises because the vitamin K dependent clotting factors are not there. So now INR decides everything. So if you have an INR of 2.5 or 3, in that situation, addition of any other agent is not required to prevent a embolic stroke. So here, close monitoring of the INR is required. If for any reason we have to use it, then we have to use a drug whose hepatic clearance is the minimum. And in that situation, dabigatran comes, which has most excretion through the kidneys. 83% is excreted through the kidneys, and you can use low dose dabigatran if the INR is less than 2. Otherwise, If the INR is more than 2.5, there is no need for anticoagulation to prevent atrial fibrillation.
When we will start? When we will start the NOAC again?
After you have at least seen that the INR remains persistently less than 2 on 3 separate occasions. That is the safest way. There is no dictum on it. But what I practice is at least on 3 separate occasions, because INR, secondly, very important thing is INR varies due to various reasons. Number one, if you collect the blood and keep it pending for more than 1 hour before the test, your INR is erroneous. Suppose you have any vegetables, not only salads and green vegetables, but almost any vegetable, it changes the INR picture. So without any vegetable, at least for 7 to 10 days, and then do an INR in a center who does replacements and all, because they have to be very careful about the INR. So they get an INR done there with the blood drawn immediately and tested instantly. Then also, if you find that the INR is less than 2, then you can use anticoagulation in cases of CLD, because it's a very dicey situation.
Yes, it is a very tricky situation.
Yeah,
Another
because
question.
variceal hemorrhages, they have torrential bleeding.
Yeah. Another question is that the patient has documented intermittent atrial fibrillation, having an increased risk of hemorrhagic stroke or GI bleeding. Should we continue lifelong this anticoagulant, whether NOAC or warfarin, anything?
Dada, this is again a wonderful question we face every day in the OPD.
Yeah.
Any patient with atrial fibrillation comes with you with a first onset atrial fibrillation to usually peripheral practitioners, whom we call coax and all. They do not come to us. They come to us with history of intermittent atrial fibrillation. That is the commonest presentation in any physician's OPD. Now, if you take intermittent atrial fibrillation, there is no clot in the left atrial appendage through TEE. There are many guidelines which suggest that you carry on without with antiplatelets. But further studies have proved that if you carry on in antiplatelets in this, the switch from intermittent to persistent and permanent is a silent switch. You do not know that the person who has frequent intermittent atrial fibrillation starts having a persistent atrial fibrillation within 7 days and goes to a permanent atrial fibrillation after 3 weeks or 1 month. So this journey is unpredictable, and the patient doesn't come to you, nor can we monitor the patient 24 hours. So basically, a patient who has frequent intermittent atrial fibrillation, anticoagulation is a must. And since atrial fibrillation does not regress to normal, even if you do radiofrequency ablations, in that situations also there is a high recurrence rate till now. 30 to 40% recurrence rate. Now, if post radiofrequency ablation patient maintains normal sinus rhythm, there is no need of anticoagulation. As soon as the patient has breakthrough atrial fibrillation, anticoagulation has to be restarted. So only one thing, isolated atrial fibrillation, balloon atrial fibrillation who have peripulmonary venous focus where we do radiofrequency ablation, they turn and stay in normal sinus rhythm for quite some time. Only in those patients can anticoagulation be stopped, not others.
And another question is that when the recurrent infarction, recurrent lacunar infarction or recurrent stroke, even the heart rate is in sinus rhythm, the neurologists now say that it is due to the intermittent fibrillation. And probably it is the cardioembolic aneurysm, not it is the atherosclerotic disease. So if there is a recurrent stroke without any documented atrial fibrillation, or the patient has got a multiple lacunar stroke, now neurologists used to give a anticoagulant for a long time. Is it right from the cardiological point
Actually,
of view?
Dada, we have to find out the cause. A patent foramen ovale, we neglected. Nothing happens. But a patent foramen ovale is one of the most important causes of these lacunar strokes. So today we close them with device closures. That reduces the chances of stroke. Okay? There are situations where we have 7 days, 24 days monitoring through various ETPs. Not implantable devices, but wearable devices by which you can plot intermittent atrial fibrillation. First is, see, when anticoagulation is a double-edged sword. So before starting anticoagulation, we must be very sure that anticoagulation is really required because of the disease process. Whether the disease process can be mitigated by something else other than a persistent and permanent oral anticoagulation use. So therefore, that thinking only led to this patent foramen ovale device closures, which are now rampant in the Western countries. We are doing it at quite frequent rates, because that itself prevents these lacunar strokes. Now, when we are using oral anticoagulation, we are also subjecting the patient to chances of intracerebral hemorrhage. So why should we do that, provided other than patent foramen ovale, there is no evidence of atrial fibrillation? So close the patent foramen ovale, do not give oral anticoagulation. So that should be the treatment. Otherwise, when we are not doing that, we have to document at least one episode of atrial fibrillation.
Thank you.
Arindam, am I correct?
Whether the neurologist has said that the recurrent lacunar stroke is not due to the atherosclerotic disease.
It is due to embolism, and it is due to patent foramen ovale that has been proved.
So should we give the anticoagulant to
Dada,
all the...
why not close the patent foramen ovale?
I don't know.
It's a non-surgical procedure.
I don't know.
Takes 15 minutes to close it.
That is the cardiologist's point of view.
No. If you close it, you do not need anticoagulation, because embolic stroke will not happen.
Okay, thank you. I have taken much more.
There is, sir, there is one more question from the forum. Please answer it, because there is a continuous interaction between you two.
One patient has come with non-valvular atrial fibrillation and receiving rivaroxaban for 1 year. Now the patient has come intense leg pain. After color Doppler study and ultrasonography of the leg, it's found that the arteries are normal. We thought it a DVT, but the arteries are normal, vessels are normal, but found a acute hematoma under the left soleus muscle.
Yes.
Huge pain, huge swelling. Patient is very toxic. We have given other all and just stopped the rivaroxaban. What should I do about the?
We have to find
later on.
Now, why we have to find out that what was the dose of rivaroxaban?
15 milligram OD.
15 milligram OD caused them. What is the age of the patient?
70.
70. Any creatinine clearance?
1.8.
No, that is serum creatinine. What?
About 35 to 40.
1.8, 70 years.
Initially it was 1.6.
1.6, 70 years. I think it should be less than 35, Dada. 30. So in this situation, rivaroxaban is a tough choice. You should go in for, let this heal first. You need antibiotics.
I have stopped it.
Let this heal first. You may have to give reversal agents of rivaroxaban that is available now. Not only dabigatran's reversal agent, but all the NOAC's reversal agents are available. So if you feel that the patient's life is at risk, you reverse with the reversal agent. Otherwise, treat it conservatively, let this episode pass.
Next NOAC choice?
It should be apixaban, half the dose.
2.5?
Yeah.
BD?
Yeah, 2.5 BD.
BD, right. Thank you.
Okay, thank you. Sir, just a minute.
So thank you so much, sir, for such a warm explanation. Ladies and gentlemen, please put up your hands together for Dr. Arunangshu Ganguly. And right now, I will be requesting our chairperson, Dr. Subrata Kuntu and Dr. Subrata Bhattacharya, to facilitate, sir, with a bouquet of flower, followed by that, a token of appreciation. And now, I will be requesting Dr. T.N. Banerjee, Scientific Committee ABCDCon, to come and facilitate Dr. Subrata Kuntu, the chairperson. Followed by that, I will be requesting Dr. Shubhamoy Chatterjee, the Secretary of ABCDCon, to come and join us on the stage and facilitate Dr. Subrata Bhattacharya. Thank you so much. Followed by that, not only one, we will be having two speakers. We will be having Dr. Arindam Pante and Dr. Shomobrata Roy Choudhury. Dr. Arindam Pante, MBBS Honours, MD, DM Cardio, FESC, FSCAI, FACC and FRCP. Yes, currently posted as Assistant Professor, Department of Gynae and Obstetrics, Medical College and Hospital, Kolkata. His current designation includes a Senior Consultant, Interventionologist, Cardiologist, Department of Cardiology, Medical Super Speciality Hospital, Kolkata, observership cum training workshop at National Heart Center, Singapore, cardiac resynchronization technique and advanced course in optimization of device, consultant and academic coordination, DNB cardiology and PGDCC training, Department of Cardiology, Apollo Gleneagles Hospital, Kolkata. And I will be requesting Dr. Shomobrata Roy Choudhury also to come and join us. MBBS, MSc, MRCP, PG Diploma in Clinical Endocrinology and Diabetes, Certification in Diabetes and Endocrinology, PG Diploma and Fellowship in Diabetes Food Management. His membership and affiliations includes in ECE and AACC. Current position includes a Consultant Endocrinology and Diabetes, Woodlands Hospital and Anandalok Hospital, Kolkata. So yes, ladies and gentlemen present here, please put up your hands together for both of them. Followed by that, I will be requesting our moderator also to come and join us, Dr. Sujan Sarkar. I will be requesting sir to come and join us, and I will be requesting our chairperson, Dr. Sumanto Das Bokshi, the Assistant Professor of Bardhaman Medical College, to come and join us. He is the chairperson of this session.
And Dr. Sujan Sarkar, no need for introduction. He is our academic and digital coordination committee here in the ABCDCon. He is controlling that.
Thank you, Dr. Chatterjee.
Check.
Hello. Hello. Thank you, Dr. Chatterjee. Okay, next is our panel discussion. We have two very eminent speakers today. I request the speakers to come on the stage, please. As we are running much behind the time, I think without wasting any more time, let's proceed with the proceedings. Now, diabetes, we all know, is a big global problem and a bigger local problem as such. We start with the mandatory slide that comes up in every discussions regarding diabetes. The number of people with diabetes was 2,000 all over the world, and it's projected to be 366 million in coming 2030, more than double. In India, in 2000 it was 32 million, and it's projected to be 79 million in 2030. So now, the kidney complications occur early in type 2 diabetes, highlighting the need for early management of kidney risk. And the prevalence of microvascular complications at the time of type 2 diabetes is pretty high. And the first comorbidity identified in CV-free patients with type 2 diabetes, you can see in the pie chart. It has got a high prevalence in India with the added disadvantage of a delayed diagnosis. More than 2 lakh patients are on dialysis right now in India, and nearly 5,000 dialysis centers have sprouted all over the country to deal with these patients. Now, let's start with a case study, an imaginary case, of course. A 54-year-old teacher who has got type 2 diabetes for the last 5 years, dyslipidemia for 6 years, hypertension for 6 years, and a background of diabetic retinopathy. On examination, he had a BP of 135/80 millimeter of mercury. His BMI was 30 kg per square meter, and HbA1c was 7.4%. His eGFR was estimated to be 56 ml per minute per 1.73 square meter. That is, he is in diabetic nephropathy stage 3A, and the urinary albumin creatinine ratio was 88 milligram per gram. Her total count, his total count was 180 milligram per deciliter, LDL was 110, HDL 40, and a fasting triglyceride was found to be 120 milligram per deciliter. The current treatment he is on is metformin 500 milligram twice daily, along with sitagliptin 100 milligram once daily, with ramipril 5 milligram once daily and hydrochlorothiazide 12.5 milligram once daily, with rosuvastatin 20 milligram once daily to top it all. Now, a holistic management approach of this patient would include the metabolic correction of HbA1c, the weight reduction by endocrinologist and diabetologist, protecting the kidney by a nephrologist, and a protecting heart by a cardiologist. This patient's HbA1c is 7.4%. He has got multiple risk factors and an eGFR of 56 ml per minute per 1.73 square meter, and the urinary albumin creatinine ratio is 88 milligram per deciliter per gram. So my question to the diabetologist is, what would be your treatment approach grossly for this patient?
Thank you, and a warm welcome to all who are out here. Thanks to Astra for asking me over here, and thanks to my colleagues on the dais. This is a patient with diabetes, 5 years, and established renal problems. And the recent guidelines have categorically stated that in such a patient, an SGLT2 inhibitor with a proven renal benefit is the drug of choice. If they do not, or there are contraindications to use that, you might use the GLP-1 receptor agonist later on.
Thank you. Dr. Pandey, any comment?
So I fully agree with my endocrinologist colleague, but at the same time, we can see the HbA1c was 7.4. Probably in a young person, we need to go for a more stringent goal of HbA1c. At the same time,
64 years.
At the same time, LDL was 110. Yep. Though he was on rosuvastatin 20 milligram, which is a reasonably good dose, but we know a long-term diabetic individual, particularly the BMI is 30, is hypertensive. So I'll go for a more stringent LDL goal in this particular gentleman. So 110 is not acceptable for me. So I'll go for a goal of LDL at least less than 70, if not further lower. So either the rosuvastatin dose has to be increased, or if the patient having any issue of tolerance, then I can add some other agent to further lower the LDL.
Okay, thank you. According to 2023 ADA standards of care, for patients with CKD and albuminuria, that is more than 200 milligram per gram of creatinine, the use of SGLT2 inhibitors are preferred regardless of baseline A1C, the individualized A1C target, or metformin use. This was discussed in the first session of this morning. Preferably an SGLT2 inhibitor with primary evidence of reducing CKD progression, or an SGLT2 inhibitor with primary evidence of reducing CKD progression in CV outcome trials, or a GLP-1 receptor agonist with proven CVD benefit if SGLT2 inhibitors are not tolerated or are contraindicated. Now, if the A1C level is still above target, for patients on SGLT2 inhibitor, we have to consider incorporating a GLP-1 receptor agonist and vice versa. For a patient with CKD, for example, who has got eGFR less than 60 ml per minute per square 1.73 square meter without albuminuria, the recommendation is the use of SGLT2 inhibitors or GLP-1 receptor agonist with proven CVD benefit recommended, regardless of the baseline A1C or the individualized A1C target or a metformin use. We have to recommend the following to reduce CV risk, that is GLP-1 receptor agonist with proven CVD benefit, with or without an SGLT2 inhibitor with proven CVD benefit. If the A1C is above target, then for patients on SGLT2 inhibitor, consider incorporating a GLP-1 receptor agonist and vice versa. So, sir, what would be your treatment approach as this patient has early stage CKD?
Hello. So, the primary goal here is, as Dr. Pandey has already stated, to get the HbA1c down to at least less than 7, if not 6.5, and also protect the kidneys. So both of this would be perhaps achieved if we give a SGLT2 inhibitor with a proven benefit of renal protection, because we have seen in the trials also that even for a patient with a normal, with an intensively controlled HbA1c, there is still a residual risk of kidney disease. So just HbA1c control does not translate into renal benefits, and there is always a risk of renal downfall in such a patient. So using a SGLT2 inhibitor with a proven CKD benefit would be the our target of therapy in this patient, which could be, as we have already shown, as per guidelines, by using a SGLT2 inhibitor, and if it is not tolerated, you can use the GLP-1 receptor agonist, which are now coming up recently with renal benefit studies.
Dr. Pandey, please.
Yeah, I fully agree. I fully agree. In fact, already discussed. At the same time, I'd like to assess the urinary albumin excretion of this patient. So that is also important. And as the patient is already hypertensive, so I'll first try to incorporate either ARB. If
I think patient is on a ARB.
So if the ARB can actually control the albuminuria, then it's fine. Otherwise, SGLT2 inhibitor can also reduce the albuminuria. So that will be an additional advantage of adding an SGLT2 inhibitor. And even after adding ARB in adequate dose, maximum tolerated dose, recommended dose, and an SGLT2 inhibitor, if still the patient is losing protein to the kidney, I'll try to address that as well, because nowadays we do have other molecule in the form of carindia.
Non-steroidal MRAs would be a of choice, but then potassium is to be frequently checked. That caveat is to be taken, that if the potassium goes up, the non-steroidal MRA has to be taken down. Because if you look at the KDIGO guidelines, previously the albuminuria part was not that important, but the current KDIGO guidelines, this patient would come under moderately high risk, because G3A and A2, this is the particular staging of this patient's kidney. So as you said, up titrating the ARBs to the maximal tolerated dose, adding of the SGLT2 inhibitors, and if still you see that you are getting stuck with regards to reduction of albuminuria, checking of the potassium and introduction of a non-steroidal MRA would help. And if the patient can tolerate, we start at a lower dose of a non-steroidal MRA and then we elevate to the full dose.
Okay, thank you. We have seen that optimal risk factor management does not eliminate the risk of diabetic nephropathy. If we see in this table at the left side of the present A, the treatment goals for standard and intensive treatment groups are like this. For systolic BP, for conventional group, it should be less than 160, but for intensive management group, it should be less than 140 millimeter mercury. For diastolic, in conventionally, we tend to reduce it below 95, but for intensive management, it should be below 85. HbA1c should be below 7.5 and 6.5 respectively. Triglycerides less than 2.2 and 1.7. Cholesterol, total cholesterol is less than 6.5 and 5 millimole. HDL cholesterol should be more than 0.9 and 1.1 respectively. AC inhibitors, irrespective of BP, should not be added in the conventional mode of control, but for intensive control, AC inhibitors should be added. And aspirins should be added in both the groups in patients who have known ischemia. Aspirins in patients with peripheral vascular disease, it's recommended in intensive management group, but not for the conventional control group. And vitamin C and E supplements should be added in the patients whom we intend for an intensive control. We come to a holistic approach for improving outcomes in patients with diabetes and CKD. The lifestyle we know, the healthy diet, physical activity, smoking cessation and weight management. In the first line drug therapy, SGLT2 inhibitor and metformin should be started with regular assessment of glycemia, albuminuria, BP, CVD risk and lipids. And we have to add GLP-1 receptor agonist if needed to achieve the individualized glycemic target. And if it's still not controlled, then other glucose lowering drugs if are needed to achieve the individualized glycemic target. Along with these anti-diabetic drugs, the RAS inhibitor should be added at maximum tolerated dose if the hypertension is there. These are non-steroidal MRAs. If the ACR is more than 30 milligram per gram, that is more than 3 milligram per millimole, and the potassium level is normal. We have to add a dihydropyridine calcium channel blocker with or without a diuretic if needed to achieve the individualized BP target. And if it is not capable of controlling the BP fully, then a steroidal MRA is needed for resistant hypertension provided the eGFR is more than 45. The other thing is moderate or high intensity statin along with antiplatelet agents for clinical ASCVD and ezetimibe or PCSK9I or eicosapentaethyl if indicated based on the ASCVD risk and lipids. The regular risk factor assessment should be done every 3 to 6 months. In 2022 KDIGO treatment algorithm for patients with type 2 diabetes and CKD, along with lifestyle therapy, the first line therapy, if the eGFR is more than 30 ml per minute per 1.73 square meter, were metformin and SGLT2 inhibitor. If eGFR is less than 45, we have to reduce the dose of metformin, and if the eGFR is less than 30, or if the patient has gone on to start dialysis, then we have to discontinue the metformin. SGLT2 inhibitors should not be initiated if the eGFR is already less than 20, and when the patient has gone to dialysis, then it has to be discontinued. Additional drugs that are needed for glycemic control if the need arises are GLP-1 receptor agonist, which is the preferred agent, along with DPP-4 inhibitors, insulin, sulfonylureas, thiazolidinediones, and alpha-glucosidase inhibitors, guided by the patient's preferences, presence of comorbidities, eGFR, and the cost of the treatment. This includes the patients with eGFR less than 30 or the patients treated with dialysis. Now, so which SGLT2 inhibitor would you choose among the present agents?
Well, with the current data that is available, we also need the echo data of the particular patient which is not present here. I presume that there is no gross reduction. Whether the patient has got ejection fraction which is near about 60, then it changes the whole picture. And well, if you really talk about the SGLT2 inhibitors here, I think you have skipped a slide on the CVD-DL which showed that SGLT2 inhibitor in a diabetic patient with renal disease, in a meta-analysis they proved that it is better than any other glucose-lowering therapy. The meta-analysis had all the forest plot which was to the left of the unity line, and if you really look at the series of SGLT2 inhibitor studies on CKD, the first to come was Credence with canagliflozin, but it only took into account diabetic subjects. Then came the DAPA CKD, and then you also have the EMPA kidney study. But if you really dissect the study, and if you look at this patient, you would perhaps put this patient with multiple risk factors, a patient with multiple risk factors. And the greatest evidence perhaps came from the DECLARE TIMI, which had 17,000 patients, with Dr. Subodh Verma's paper, which quoted is for pumps, pipes and filters. I think there would be a slide on your presentation also, where you see that there is the hospitalization heart failure and the renal benefit, which is available to patients with multiple risk factors with dapagliflozin. And by the sheer numbers of the DAPA, DECLARE TIMI study, and also backed by the evidence of DAPA CKD, I would possibly choose a dapagliflozin in this particular subject. Audindo, your take?
Yeah. To be honest, we have two fantastic SGLT2 inhibitor in our hand in this kind of situation. Though canagliflozin is also a very good SGLT2 inhibitor. Mostly it has very good evidence in obese person. Now we can use in a dose of 300 milligram. But otherwise, for this kind of patients where probably heart failure is there, patient is obese and obesity, heart failure, they go hand by hand. Ejection fraction data, as my colleague mentioned, that it is very important. Now, heart failure is a situation, if that is present, then two SGLT2 inhibitor you are supposed to give, either empagliflozin or dapagliflozin.
The heart failure, the canagliflozin studies are perhaps with 100 milligram.
Yes.
All the evidence
all the evidence, but nowadays it is approved for obesity management in a 300 milligram dose.
Motivist is there.
Motivist is there. But it is not for cardiovascular protection, and incremental dose of any SGLT2 inhibitor, there is no evidence as of now which has incremental cardiovascular benefit. So all the SGLT2 inhibitor, they have a fixed size. I mean, either it is 10 milligram of DAPA, 10 milligram of empagliflozin. Though empagliflozin do have a dose of more than 10 up to 25, but incremental cardiovascular benefit is not proved. So in this kind of situation, we are suspecting the patient is having heart failure. We do have two options. One is empagliflozin, another is dapagliflozin. Both the molecule have evidence both in reduced as well as preserved ejection fraction. Now, dapagliflozin has some advantage in this regard because DELIVER trial is the preserved ejection fraction trial with dapagliflozin. This trial included a particular group of patients which is not yet included in any other studies, is the heart failure with recovered ejection fraction, because this is a known entity, established entity. Suppose a patient where the ejection fraction was less than 40 initially. So he is a patient of heart failure with reduced ejection fraction. Now you started some therapy of heart failure, be it ARNI, be it SGLT2 inhibitor, or be it some intervention in the form of angioplasty, bypass surgery, or cardiac resynchronization therapy. So with all this therapy, the ejection fraction now starts improving. Now ejection fraction, say for example, either 50, 50, 45. So how do you categorize? Mildly reduced, preserved? Answer is no. They should be categorized as heart failure with improved ejection fraction. Even if the ejection fraction becomes normal, 60%, they should be categorized as improved ejection fraction heart failure patient. And there are n number of studies which has clearly shown that in this particular group of patients, if you stop the intervention or medicine which resulted in improvement of ejection fraction, the pumping will go down in more than 50% of patients. So you are not supposed to withhold the treatment or intervention. If you stop the CRT, the pumping will go down. If you stop ARNI or SGLT2 inhibitor, the pumping will go down. Now, DELIVER trial is the only trial which included particularly the patient who had this kind of diagnosis. And they showed that dapagliflozin, even in this group of patients, has improvement in terms of reduction of heart failure hospitalization as well as mortality. So if that is present, my choice will be dapagliflozin. In all other situations, though there are some statistical jugglery in between EMPA and DAPA. DAPA, preserved ejection fraction and reduced ejection fraction heart failure trial has shown to reduce the cardiovascular mortality, which EMPA did not show. Again, primary prevention trial with empagliflozin shown mortality reduction, which dapagliflozin as of now do not have. But why this has happened? This is because of difference in the inclusion criteria of the patient. So I'll not go into that. Only this improved ejection fraction, I do have compelling indication of using DAPA. All other situation, I can use any of the molecule.
Thank you.
Let me be a devil's advocate and ask Arindam, that in this patient, wouldn't you give canagliflozin a try?
Yes, canagliflozin can be used because as of now, whatever evidence we are having, that do not say that
diabetic subject.
That do not say the patient is having heart failure. So we can also use canagliflozin. We should make it very clear. But if we further analyze the patient and we find some evidence, say for example NT-proBNP is done and that is found to be high, then our decision will change. Otherwise, in this case, where the information is not yet there, we actually can use canagliflozin as well.
Thank you. In this meta-analysis of SGLT2 inhibitor trials on the composite renal endpoints, we'll find that DECLARE TIMI 58 is one of the most celebrated and prominent trials. What is the prevention benefits from CKD perspective in DECLARE, as we talked about most inclusive trial as the DECLARE?
If you look at the 3 landmark trials with SGLT2 inhibitor, it is, as Arindam said, that they all had different patient profiles which were included. In the empagliflozin trial, the EMPA-REG outcome, which was read out in the EASD, they had 99% acute patients, secondary prevention group of patients. However, canagliflozin had a split of 25-75, where 25 were primary prevention, and dapagliflozin, out of those 17,000, had a roughly 60-40 division of primary prevention and secondary prevention patients. The secondary prevention data and it narrowly missed the superiority. The A was upper bound of the confidence interval, as far as I remember, is 1.01. So it was proven to be non-inferior. But if you really dissect into the trial and see that, yes, you had a predominant set of primary prevention patients who had hospitalization, heart failure, as well as renal benefits from this trial. And this was the first trial which had a combined cardiac outcome as a primary prevention, primary endpoint. Arindam, I think you would be a better person to talk about the combined cardiac outcome benefits of.
So I agree, because DECLARE trial was a trial more of a real life situation. So if you are practicing as a cardiologist, your job is easy, fine. But majority of us here are actually practicing as physician, endocrinologist, diabetologist. So if they want to see a real life case, I think DECLARE is the trial to quote. Because if you see, there is some percentage of patient which will be a secondary prevention, but majority will be primary prevention. So from that perspective, I do agree with Dr. Somobroto that DECLARE is probably the most representative of our day-to-day
real life practice.
Okay. Now I'll quickly go through this. Dapagliflozin slowed the renal disease progression in type 2 diabetes patients who have got relatively good baseline renal function, and the deterioration of albuminuria category from baseline, that is
Slides up, please.
progression, is also improved. The regression criteria in the albuminuria category has also improved. And while we come to cardiorenal outcomes, but SGLT2 inhibitors are not preferred agent for glycemic control. Why this is so? My question to the diabetologist.
Well, for glycemic outcomes, you know, for all medications that we have in allopathic medicine, the more the effect, the more the side effect. So if you really look at the SUs, which perhaps have one of the greatest reductions in terms of HbA1c, you will have a problem of having a hypoglycemia. Even look at the antihistamines. If you take a prawn and if you have prawn allergy, your fexofenadine is never going to work. You have to go back to the good old Evel. So the reduction of the newer agents is between 0.7 to 0.9. And of course, we know that as we go up the tires of HbA1c, you will have greater reductions. But the problem with SGLT2 is that if you use it in a higher tertile of HbA1c, it will give out more of glucose, and the problem of UTI and GMI possibly is much more. Dr. Arindam uses it more in non-diabetic patients. He would be able to give us an overview of the UTI GMI problem in a diabetic subject versus a non-diabetic subject. If we really consider another mechanistic aspect, that as your renal function is coming down, the glucose excretion is going to go down. But still, we are seeing that the lower limit of usage of SGLT2 inhibitor is coming down, down and down, because although the HbA1c reduction potential goes, the other benefits, the cardiorenal benefits, are really preserved even in lower regions of EGFR. So that's why possibly we use it for cardiorenal protection and some amount of HbA1c benefit, rather than bringing down a HbA1c of 10 to 7%.
So already Dr. Shomoboto is here, Dr. Kollan Ganguly I can see. So, you know, the reduction of HbA1c depends at what baseline HbA1c you are starting the medicine. The problem with DAPA or IMPA or any other SGLT2 inhibitor, they are as of now not first line agents. So when they are started at HbA1c of 7.5, 7.3, as in this case, the index case which you have shown. So it is obvious, if you start the molecule at a lower HbA1c, the reduction will be lower. In fact, all the trials has clarified this. If you start even SGLT2 inhibitor at a HbA1c of 10, the reduction will be higher. So I partially agree with Dr. Shomoboto that they are not very strong agent, but if properly used, they also probably can reduce HbA1c very nicely. This is number one. In my practice, I initiate DAPA, IMPA more in non-diabetic patient than diabetic. And I'm very, very comfortable in doing so, because all the problems, all the complications of this molecule are more commonly seen very interestingly in diabetic individuals. Say for example, diabetic ketoacidosis. You are not going to have it in non-diabetic individual. Similarly, nowadays we are starting this molecule in hospital for acute heart failure patient. Yes, obviously there are some criteria. If the patient fulfills those, then you actually can start this molecule in hospital for heart failure patients. And I am very comfortable in starting heart failure medicine, as an heart failure medicine, this molecule in non-diabetic individual, because all the complication, even the genital mycotic infection, there will be no issue, because if the sugar is not high, it is not going to excrete sugar through the urine. So the issue of genital mycotic infection doesn't arise. And in fact, all the heart failure trials, all the CKD trials, 50-50 proportion, non-diabetic individuals were actually included. So they are very nicely accepted to be used in non-diabetic individual. My personal experience, all the complications of SGLT2 inhibitor are almost negligible in non-diabetic individual.
And Arindam, if you really look into the trials and dissect it, the benefits in both the DAPA CKD and DAPA heart failure were more in the non-diabetic subjects than in the diabetic subjects, which is an irony, because it came into our hands as a diabetic and you guys have stolen it away.
Okay. Just this morning only, Dr. Sunetra Mondal reported 2 cases of non-diabetic patients receiving SGLT2 inhibitors who developed a diabetic ketoacidosis. Okay, such an interesting discussion I think can go on and on and on, but as we are running almost 1 hour late, and the inauguration session is already overdue, and our very busy principal sir is already here to inaugurate the session. I would call it a day, and I invite few questions from the audience. Three questions.
Hello. In the canvas trial, there is an increased incidence of amputation of legs. The inclusion criteria was that probably there has got more patients with the peripheral vascular disease. Now this canagliflozin probably is not in a very good noise probably for this fact. Now what is the level of blood pressure? In that case is you can start this SGLT inhibitor. Suppose the patient has got a 90/60 blood pressure. Should we start this SGLT inhibitors?
Sir, I am quoting your canvas trial again. They had an Indian subset of patients who they had studied in summer also. They showed very negligible drop in blood pressure and also electrolyte imbalance in this subset of patients, and that's reported. Arindam, your take? I think in many of the heart failure reduced ejection fraction, you do have a BP of 90/60. Do you prefer giving the other agents or start with a SGLT2 inhibitor which you would be comfortable hemodynamically?
So first of all, the issue of lower limb amputation, Fournier's gangrene, fracture, spine fracture are all gone because there are n number of trials. More we study this molecule, those things are actually not found, so we should not be bothered about them. Second,
only thing, Arindam, which I say that which we do not do, please put your hand on the arteria dorsalis pedis of the patient before starting an SGLT2 inhibitor. That I think we should do. We do not open the socks and the shoes and put our hands on arteria dorsalis pedis. So
yeah, agree, fully agree.
It is better to be a little bit cautious.
It is better to avoid the SGLT.
You should not say better to avoid because you can actually treat the peripheral artery disease as well. But you should be, putting a extra caution. Yeah. That is for sure. Now coming to blood pressure, recently European Society of Hypertension guideline, they have included 2 new molecules which are actually not ever included in any hypertensive guideline. So what are those molecules? One is ARNI, second is SGLT2 inhibitor. They have clearly mentioned this molecule. Whenever the patient is having heart failure, they can be used as an antihypertensive agent. So ARNI, the blood pressure lowering capacity we all know, but as of now it is not approved for uncomplicated hypertension management. There are many trials which are undergoing. So as of now we do not have the evidence in hand, so we cannot advise to go for it. But in heart failure with hypertension, ARNI comes very early. Now SGLT2 inhibitor will have an advantage, as Dr. Shomobuto mentioned, in a patient who's 90 systolic blood pressure, probably will be little overcautious in starting ARNI. But you probably can start SGLT2 inhibitor because recommendation they allow you. There is no contraindication of starting SGLT2 inhibitor. But believe me, in my practice also many of the cardiology, we are using this molecule like right and left. So in long run, it do reduces blood pressure. It has happened many times that many of the other antihypertensive has to be withdrawn. Only SGLT2 inhibitor could actually control the blood pressure. So in long run, acute reduction of blood pressure is not seen, but if the patient is taking the molecule for very long, they do have very good potential in reducing the blood pressure, probably by some other mechanism which is not yet fully explored.
That means even the blood pressure is 90/60, we can start it.
Yes, you can start. There is no contraindication as per the recommendation. You can start.
Okay, thanks all. I thank the speakers. If you have any more questions, please ask the speakers backstage. They will be more than happy to address them. time to felicitate the speakers and the chairperson.
So may I request Dr. Dasbakshi sir to please felicitate Dr. Arindam Pandey with a flower of bouquet and token of memento. And Dr. Sujan Sarkar sir, please felicitate our next second speaker, Dr. Somavarto Roy Chaudhary sir, please. A big hand of clap, please.
Not only for the felicitation, but for the excellent moderation.
And may I ask Dr. Sumay Chatterjee sir to please felicitate Dr. Sumanto Dasbakshi sir. And may I request Dr. A.K. Mukherjee sir to please felicitate Dr. Sujan Sarkar sir for his excellent moderation of this session. And for this session, actually, all this Herculean task has been done by our academic head, Dr. T.N. Banerjee sir. But for this particular session, sir has worked really very hard. So, big hands of clap for Dr. T.N. Banerjee sir, our academic head. Colleagues, amongst us, it's a privilege to have my teacher, my principal, Dr. Kaustor Nayak sir, HOD, Department of Pediatrics, and right now sir is acting as a principal of Bardhaman Medical College, and sir will inaugurate our program today. And I would request to sir to please come on the dais, sir. And I would ask our secretary, Dr. Sumay Chatterjee sir, to please felicitate sir with a flower of bouquet and a memento, please. It has been a great task which has been carried out by Dr. Kaustor Nayak sir after taking the charge of Principal Bardhaman Medical College. Sir, we are really grateful to you to come and honor our organization on this auspicious day, that is 9th annual conference of Bardhaman Association of Physicians, Cardiologists and Diabetologists. Thank you, sir. Please grace the ceremony with few words, sir.
Good afternoon, everybody. Truly speaking, I was not aware of ABCD. Only few days ago, I have heard from Sujan that they are going to organize one conference under the banner of ABCD. And ABCD, I have heard from him that it is Association of Bardhaman Cardiologists and Diabetologists. But here, after coming over here, I am totally amazed to see such a beautiful organization, such a large organization has been organized by them. And as a pediatrician and also central executive member of pediatrics, I know what is the importance of organizing this type of conference. Huge exchange of knowledge will be there. But as there are many diabetologists and cardiologists, I want to share one or two experiences from pediatrics. All of you are, as I have heard in last half an hour, you are discussing on type 2. But in our PICU, every week we are getting two or at least two cases of decay admitted in our PICU in an unconscious state. After getting insulin, they are recovering and they are discharged, but after going home, they are not taking the insulin. Again after 15 or 1 month they are coming. And it is my request to you all whether something can be done for these children or not. And from the cardiology point of view, again I want to share one of my experiences. Previously, rheumatic heart disease was the commonest heart disease in pediatrics, but nowadays rheumatic heart disease had gone down, but post-COVID cardiac manifestations are coming, and also we are getting more and more cases of Kawasaki disease. So cardiac manifestations following Kawasaki disease is taking the upper hand. So these are two my experiences I am sharing with you. And I wish that this program will be very much successful. Thank you all.
Thank you so much, sir. And now we will be requesting Dr. Amitabh Biswas, the chairman of Bengal Diabetes Foundation, Durgapur, to come and join us. So please come and join us. And it will be felicitated by our president, Dr. Subroto Bhattacharya.
So, it's an honor to have Dr. Amitabh Biswas sir from Durgapur. Sir is pioneer in setting up diabetic clinic outside Kolkata in a second tier city like Durgapur, and that is his biggest lifetime achievement in our thought. Sir has done an excellent job in sharing the information and also conducting annual conference at regular basis in Durgapur, which is a huge successful one. We all know that, and we are honored to have sir on our dais today, on our platform, and as a organizing secretary, as a team ABCD, we are very much thankful again and again. And may I ask Dr. Subroto Bhattacharya sir, our president, to please felicitate Dr. Amitabh Biswas sir.
And Dr. Biswas is very close to our heart since his inception in Durgapur. He comes every year to ABCDCon, and our heartfelt gratitude to him.
And now I would request all the organizing committee members of 9th ABCDCon to please come on the dais for the lighting the lamp proceedings. Please. Abhinavo, Dr. Joyanto Rana sir, A.K. Mukherjee sir, B.D. Chatterjee sir, Mofidul Islam sir, please, everybody. Please don't go away, the organizing committee. Please stay here for a group photo, and I will request the concerned person for group photo, please. Thank you all for joining us. And after this, we will move to our next session. Sumana, please. Oh, okay. A few words from Dr.
Thank you very much. I feel honored to have this felicitation. And really, I accept this on behalf of Bengal Diabetes Foundation, which was formed in 2012 with a mission to fight and work for the diabetes in this South Bengal area. And this is an honor, literally, not only for me, for the Bengal Diabetes Foundation, for ABCD, for ACDA, for my doctor fraternity friends, my family friends, and the pharmaceutical industry, which has literally supported BDF to raise the situation. Thank you all. Thank you very much.
Thank you so much, sir. And now we will be moving forward for the next presentation. Before inviting the speaker on the dais, I will be requesting our chairperson, Dr. M.M. Ganguly, to come and join us.
One thing we have forgotten because of the this delay in the conference. So every year we have done something new, particularly after COVID, for the digitization of the whole organization. Last 2 years we have done our own Facebook Live and YouTube channel, which is right now running. And this year we have launched our website, that is abcdbengal.in. And I would like to request our principal sir to open our website, abcdbengal.in. That is the first registrar of this digital platform, and it is an honor to us. Thank you, sir. Thank you, sir.
Thank you each and everyone, and now moving forward to the next session, I will be inviting our chairperson, Dr. M.M. Ganguly is already here on the stage, and I will be inviting our next chairperson, Dr. Arno Banerjee, to come and join us on the stage, please. Can I request Dr. Arno Banerjee to come and so please join us on the stage. Dr. Arno Banerjee, is he here? Okay, let us proceed, and I will be inviting our speaker, Dr. Angshuman Mukherjee, to come and join us. He is the speaker of this session, a consultant pulmonologist, MARI Hospitals, Kolkata, MD Pulmonology, Medical College, Kolkata, 2014, European Diploma in Adult Respiratory Medicine, 2015, Amsterdam, Netherlands, trained in Leeds Teaching Institute, UK on NIV and sleep, trained in Advanced Bronchoscopy and EBUS, ACCP course, Chicago, 2016, MBBS from RG Kar Medical College, 2003, till 2008 and he is interested in sleep medicine and interstitial lung disease. So ladies and gentlemen present here, please put up your hands together for Dr. Angshuman Mukherjee.
Good afternoon. I'm Dr. T.N. Banerjee. In absence of Dr. Arnav Banerjee, I'm chairing the session. And needless to say, after these COVID-19, we have come across a lot of cases of interstitial lung disease. And this interstitial lung disease has got real bad prognosis, bad quality of life, all the bad things with the interstitial lung disease. We don't have much options to treat ILD. And to discuss more these things, we have got none other than Dr. Mukherjee, who is really need no introduction. He has come to our place many a times. May I request Dr. Mukherjee to proceed with.
I think there is some sort of technical snag going on, but before I could start, I think ABCDCon has given me the opportunity consecutive 2 years to come up here and talk about a different segment which you people are discussing right now. This is about pulmonology, and I just missed Dr. Prashant Kumar's presentation for a bit. He was talking about COPD. Today I'll be talking about a entirely different subject which I think people are slowly getting interested in it. I think I'll be talking about interstitial lung disease. I am sure that you people have heard this name because this is one of the meanest, one of the very dangerous disease which is actually killing people throughout the world. Is it okay? Ready? এটাতে প্রেজেন্ট করে দেবো কোথাও প্রবলেম হচ্ছে পেন ড্রাইভ নিয়ে এখানে আসছে ওখানে আসছে just a minute zero তোমার নাম্বার করতে হবে না 7278 this is what we are going to talk about. It's about interstitial lung disease, and we will be discussing about this disease because it is still very much not clear even to the pulmonologist, to the whole world. We are still trying to find out a suitable drug, a suitable treatment, or giving a better quality of life to our patients. So when a patient comes with chronic exertional dyspnea, this is what we can have as a differential diagnosis. Like you can think about different scenarios of neuromuscular problem, pulmonary, cardiac, vascular, and other problem. But if you consider the mid two, the yellow two, that is pulmonary and cardiac problems, and it could be between anything between asthma, COPD, ILD, cardiomyopathy, and so on. So basically, clinically, you can think about whether it is asthma COPD versus ILD, because if it is a Velcro crackles, I think you know about Velcro, and if it is a Velcro crackles, you can surely, almost surely stamp it that this is going to be a case of ILD unless proved otherwise. So what you have to do, you have to go for a typical HRCT thorax, and this HRCT thorax in today's era with a better center of scan, you can almost confidently diagnose the types of ILD even. Now this is the investigation parameters of a suspected ILD. Mind it, I am presenting a presentation which is slightly older, which is not giving you the absolute data which is going on through the world right now. It is slightly older, of 2015, 17, 19 data, but I think this is one of the important thing, because ILD is still we are not able to absorb this whole thing still very much, and that's why this presentation I am trying to present over here. So you have to go through the history, through the chest x-ray, spirometry, and so on. Now coming to this portion, if you are confident enough with the diagnosis, yes, if it is yes, you can go through your right side. If it is no, you can consider a bronchoalveolar lavage along with a transbronchial biopsy. Transbronchial lung biopsy, or in today's era a cryobiopsy, is almost equivalent to a surgical lung biopsy, and we seldom did a surgical lung biopsy or refer a patient for a surgical lung biopsy in case of diagnosing a ILD which is not being diagnosed by HRCT thorax. So in that case, when the pathologist give you the report, the radiology, the pathology, and the pulmonologist, they can sit together with a multidisciplinary therapy approach, and then you can decide what sort of ILD, what type of ILD you are going to treat it. Now considering about the right side, when it is almost sure that you are diagnosing, you are detecting a ILD patient, now what we have to do, we have to go for a severity assessment by a full lung function test, a 6-minute walk test, and an overnight oximetry. You have to exclude the complication by a echocardiogram. You have to think about cardiomyopathy, whether cardiomyopathy is present or not, left to right shunt is present or not, and there are some disease specific investigations, especially when don't consider these things about this gallium scan and so on, but what I would request you, before jumping into a conclusion, definitely rule out whether connective tissue disease is associated with this ILD or not. This is very much important in our system. This is diagnostic algorithm for idiopathic pulmonary fibrosis, one of the very major ILD we always get to know about. So if it is a suspected IPF, you have to find out what I have just told you, identifiable causes for ILD. So amongst them, number one is this connective tissue disorder, number two is drugs like amiodarone, number three is different exposure, especially exposure to pigeons, especially exposure to dust and everything, coal dust and everything. So if there is any identifiable cause, that is definitely not an IPF. Now in the second scenario, you have to go for a chest HRCT thorax, and if the chest HRCT thorax shows a pattern called UIP, usual interstitial pneumonia, I'll be talking about this UIP, but if there is a definite UIP pattern in this HRCT thorax, you can stamp it as an idiopathic pulmonary fibrosis, which is probably the dreadest of disease in the pulmonary system. If it is not UIP, again it is a non-IPF case, and then there are scenarios where it can be possible UIP, probable UIP, inconsistent with UIP. In those cases, you can go for transbronchial lung biopsy or cryobiopsy, which will give you definite data that whether it is IPF or a non-IPF cases. This is actually diagnostic algorithm. Now, what is most important distinction to make? That is whether it is UIP or it is not UIP. So, what is UIP? I'll talk about UIP and why UIP IPF is so important, because the prognosis is altogether different from other IPFs and the treatment is altogether again different. This is the prognosis. If you see the prognosis of IPF, the downward curve up to the age of 10 years, up to the time after diagnosis of 10 years, you can see the mortality rate, the morbidity is very high compared to other IPF or other interstitial pneumonias like non-specific interstitial pneumonias and so on. In my career of 13 years, I have seen only one patient who lived up to the age of 9 years after the diagnosis of IPF. So that is that much of dreaded this disease is. This is official ATS, ERS, JRS and ALERT clinical practice guideline. It is being updated every year, and I told you that I have purposefully kept it older version. This is from 2011, and it showed that there are different agents which we use in IPF patient or rather ILD patients. There are different agents which have been tried throughout the world, but I will show you which are against the flow, which is for the flow. If you see anticoagulants, they are strongly against the flow. You cannot use anticoagulant in any sort of ILD patients. Imatinib, the combination of prednisolone, azathioprine and N-acetylcysteine, the ambrisentan, these are of strongly against using in patient of ILD. There are some conditional scenarios where you can use sildenafil, bosentan or NAC monotherapy, but the more the data is coming, it is showing that treating pulmonary hypertension even in case of ILD is not very much helpful to reduce the shortness of breath. What are in favor of ILD? In favor of ILD is nintedanib, pirfenidone and anti-acid medications which you can give, but the irony is there is nothing, no medication is there throughout the world till date which is strongly favors in ILD patients, strongly give you benefit in ILD patient. That is the irony till date. Why the early referral is required? Because more you refer your patient to a pulmonologist or the person who is dealing with ILD day-to-day basis, more you save the life or the quality of life in your patient, because the longer delay will lead to more morbidity and mortality in patient with ILD. This is about the summary. If you delay in diagnosis and you keep the patient on different inhalers, high dose steroids and so on, there will be delay in evaluation of lung transplantation. And why I am talking about lung transplantation? Because this is the only therapy, only definite therapy you can give your patient in today's era. Lung transplantation can only give the benefit in ILD patient. Otherwise, no other therapy is still now available. The only effective treatment, because the second one you can see that if you recognize this disease promptly, in the first case, if you recognize this disease, you can have an access to the ILD specialty center. You can institute early therapies like drug therapy of nintedanib, pirfenidone. You can use long-term oxygen therapy, and you can have timely access to clinical trials as well as lung transplant evaluation. So this is important, early referral to a person who knows ILD. Now, what are the new concept of treating UIP and not only IPF? So I am talking about UIP. UIP is a pattern in HRCT thorax. So there are different situations, definite IPF, probable IPF, possible IPF and not IPF. So with HRCT thorax, you can think about which strata of disease or which kind of disease you are treating. So what is UIP? What is UIP? UIP can cover all these 4 factors, that is starting from not UIPF, not IPF to definite IPF. So everything can be under the banner of UIP, because UIP is an HRCT thorax pattern. This is kind of UIP, but this is a scenario where a 55-year-old man with rheumatoid factor positive as well as anti-CCP positive, there is a high positive, but the patient is not having arthritis, and this is an HRCT thorax which will tell you that this is UIP, usual interstitial pneumonia, but this is not IPF. Why not IPF? Because in IPF, you have to have honeycombing pattern. It's like a beehive kind of pattern in HRCT thorax. I'll show you. In these cases, if I tell you that this is not honeycombing, so this is not IPF. This is not definite IPF. Okay. Now what is this? This is actually rheumatoid factor associated or rheumatoid arthritis associated ILD. So this is actually a confusing factor, but with evolution of better quality HRCT thorax, we can easily diagnose, and with what I told you, that if you can evaluate this rheumatoid factor or the CTD factors in an early stage, you can easily diagnose whether this is an CTD related ILD versus a IPF. Now this is Senesis trial, which showed that it is done throughout many countries including India. It's a double-blind randomized trial which was mainly with patient of systemic sclerosis associated interstitial lung disease. This is very important because these SSILDs are really bad in presentation, and treatment is quite difficult. So the Senesis trial also showed about this UIP pattern and about different disease. Now this is very important. This is about ILD India registry, and this ILD India registry was in collaboration with Indian Chest Society as well as University of Washington. And so this is one sort of registry which helped us, the pulmonologist, knowing about this fantastic disease more and more. And the Indian scenario is such different than the other part of the globe. So we will have we do have our own data right now. So what are the objective of ILD India registry? It is to characterize the new onset ILD by creating a prospective ILD registry in India, and diagnosis being validated by MDD, multidisciplinary discussion. So pathologist, radiologist, and pulmonologist, everyone is involved in this scenario. So this was from Center for ILD, University of Washington, Seattle, USA, and in India, the nodal center was in Jaipur. So from different parts of India, data were submitted to the nodal center. The ILD India registry, it has got 27 centers in 19 cities, and from Jaipur, it has been conglomerated with Seattle, and that's why we have formed this ILD India registry. It has got a duration of study from 2012 to 2015. Almost 1100 adult patients of Indian origin with new onset of ILD were recruited. This is one of the largest multi-center study from India, one of the first prospective study in this world also. It has got an inclusion criteria of patients of Indian origin who are more than 18 years of age, presenting to the site investigator across these 27 centers with new onset respiratory complaints and high resolution computed tomography suggestive of diffuse interstitial lung disease. So that is very important. New onset patient more than 18 years of age. What are the exclusion criteria? Obviously less than 18 years, pulmonary tuberculosis with sputum positive for AAB at the time of entry or initial evaluation, and lung malignancy. These people were excluded. Now what has been done in this ILD India registry? Initially the detailed case report forms or the CRF designed to specifically and prompting elicitation of exposure history into the site investigator. So we have taken the history of exposure, history of BARD exposure, coal exposure, and so on things. Then MDD at National Data Coordinating Center, Jaipur, India has been performed, and ultimately MDD at the center of ILD, Seattle, USA has been performed. So that is the pyramid, how this is formed actually. So what are the data elements? So mainly detailed history, physical examination, pulmonary function test, HRCT thorax, and if there is any other clinical data. And it showed that in case of imaging characteristic, we have taken a data like UIP where there will be subpleural and basilar predominant. This is very important. In UIP cases, you have to have a subpleural and a basilar predominant. You have a reticular abnormality, honeycombing, absence of feature inconsistent of UIPA. So that is probable UIP, and the possible UIP, subpleural and basilar predominant, reticular abnormality, and absence of features inconsistent with UIPA. So that is actually difference between possible and definite UIP, the honeycombing factor. If there is honeycombing, you can tell that this is usual interstitial pneumonia. So this is honeycombing. HRCT image of an advanced IPF with abnormalities expanding beyond basal and subpleural region. You can see this portion, this almost looks like cyst, but this is actually honeycombs, or rather small cystic changes in different layers, which is giving this appearance of like a beehive. So this is called honeycombing in HRCT thorax in patient with IPF. And there are traction bronchiectasis. Because of abnormal traction, the airway, the end on view of the airway looks like a bizarre one, and that is called traction bronchiectasis. And there are reticular aposities. So these three are main features of an UIP pattern. Now what is ILD India registry shows? So patient demographic data, age is around, the median age is around 55 years, more in case of males. Symptom duration prior to diagnosis is almost 4 years. So this is very important. This 4 years the patient was going in different doctors, different centers, but this is important. This is what I am trying to convey you. Try to diagnose this case as early as possible, or rather think about this, suspect this disease, because if you can save that 4 years, you can give a better quality of life to your patient, as well as chances of lung transplantation, which will give the ultimate benefit. Significant number of current smoker, GERD is very prominent. You can see the spirometry, the FVC predicted is around 57% in this population. This is ILD India registry, and this is the crux of this study, and this is the beauty of this study. After this ILD registry in India, we are surprised that in India the predominant ILD is not IPF, it is HP, that is hypersensitivity pneumonitis, because of bird exposure. That is very, very important. In Southeast Asian region mostly, we see that HP is very prominent, not the IPF, which is contrary to the other part of the globe. This is different person, Dr. Jindal, Dr. Sharma, who has contributed in this ILD India registry, and it shows that, contributed in this ILD India registry, and you can see a significant number of here is actually hypersensitivity pneumonitis. International data also shows that in India it is where it is almost 47%. Throughout the world it is not so high. In other part of world, IPF or CTD ILD actually predominates. Now why highest number of patient had HP? There is almost 513 patients among this 1084 patients. 96% cases had chronic HP and 4% had subacute HP. It was shown that people who are exposed to pigeons and other birds, as well as people who are mostly sleeping in air conditioner, and this air conditioner is not being serviced regularly, those air conditioner is containing fungus like element, which is ultimately causing this sort of ILD, HP kind of ILD in patients in India. ILD India registry, it also shows the type of exposure. You can see from air cooler it is around 48%, air cooler and AC it comprises of 48 and 26%, so high. Birds is actually coming third, 21%. From molds, occupational factors and other factors, there are the other group of patients. So that you need to keep in mind. Servicing your AC is a prime important. Even in summer days, unless and until you service your AC, there will be a chance that you can develop ILD when you are staying in India. So what are the limitations? There are limitations in diagnostic criteria. Only 7.5% patient had histopathology, that is we could do transbronchial lung biopsy or cryobiopsy, and there were obviously some selection bias. So this is about ILD in developing countries. Spectrum of interstitial lung disease at a tertiary center in a developing country. This is done from PGI Chandigarh. It was prospectively done between 2015 and 17. Detailed history has been taken. Presence of connective tissue disease has been excluded. Also the drug and environmental factors. Investigation on basis of suspected diagnosis like chest X-ray, HRCT, spirometry, autoimmune serology, serum ACE level, these are evaluated. Pathological diagnosis like bronchoalveolar lavage, transbronchial needle aspiration, either it is EBUS or conventional.
You have got 2 minutes left only.
Yeah. TBLB. So these things has been done, and diagnosis, I'm not going into this. Diagnosis has been made. There are different types of ILD like IPF, sarcoidosis, chronic HP, CTD related ILD. So I'm leaving this. Now Chronic HP is definitely a common form of DPLD through just basis, though just basing this diagnosis on presence of trigger and HRCT features or over-diagnosing it. IPF is less common of DPLD in India, and maybe an overlap between sarcoidosis and HP unless there is histology is used. Now, this is important. Pioneer observational studies is an observational practice-based open-label non-comparative and multi-center study which was having an objective of understanding the clinical profile of patient prescribed pirfenidone therapy, and it showed in this is European Respiratory Society 2014 International Congress, which ultimately showed that patient of mean age of 60, 96 of males, patient are presenting with mostly dry cough, dyspnea, desaturation on exercise. The mean dose of pirfenidone used was around 1080 milligram. So this was in this trial. HRCT thorax data was available in 88 patients. In a small subgroup of patients who had FVC data at 24 and 48 weeks, pirfenidone appears to stabilize the lung function. This is important. There is no cure of this disease. This particular medicine can stabilize the lung function. This was about pirfenidone. Now, how do you approach to drug therapy in case of this ILD? Definitely a trial of PPI is very important, because you see that GERD is so much related with ILD. So no good correlation between symptoms and presence of GERD, but 30% of patients with GERD on a manometry do not have any symptoms, but you can use PPI because it is relatively safe and relatively cheaper drug. This Ascendant capacity trial, they also showed that this is pooled all cause mortality data up to the week of 52, and treatment group curves diverge early and continue separating throughout the study period. You can see this is the treatment group with pirfenidone, and this is with placebo. So pirfenidone actually reduces the cumulative risk of death up to 12 months in this study.
Can you wrap up quickly?
I'll be trying, sir. So I'll be just talking about another very important drug. This is Impulses 1 and Impulses 2 trials, which talked about nintedanib in idiopathic pulmonary fibrosis. And till date, I'm not going into detail of this, but in today's era, we are using nintedanib in different scenario, because nintedanib is actually reducing the chances of death, especially the chances of exacerbation, as well as improving the quality of life in patient with ILD. Due to lack of time, I'm not showing you the data, but this is really important about nintedanib. It slows the disease progression by reducing an annual FVC decline by almost 50%. This is important. And efficacy further supported by a numerical reduction in the risk of acute exacerbation, all-cause mortality, and consistent effects across the predefined subgroups. And it has got a significantly manageable safety profile. So what is the carry-home message? Think of chronic HP and sarcoidosis is the most important differential for ILD in India. Whenever you are having such a patient, always think about sarcoidosis and HP before thinking about IPF, because IPF diagnosis is easy. You can diagnose it directly from the HRCT thorax. Make sure you have got a liaise with your radiologist who is looking at the CT. Talk to him, biopsy more and when appropriate. Use the best biopsy modality appropriate. Select drugs wisely when you have definite and probable UIP and most cases of possible UIP, and most likely treating the pattern rather than the disease. This is important. Thank you.
Thank you, Dr. Mukherjee, for your excellent presentation. Time is the only constant. You know, the interstitial lung disease is not a matter of 20 minutes talk. At least it takes 2 days. You can discuss this interstitial lung disease.
Absolutely.
It is a fact that after this COVID incidents, we have come across, at least we are the general physicians, we are aware of this presence of this interstitial lung disease, and only 2 or 3 questions are allowed. Any questions from the floor? Only 2 questions allowed.
Pirfenidone and nintedanib, can it be added? Can it be given simultaneously?
There are few studies where it has been shown that this nintedanib can be conglomerated with pirfenidone in some cases, but generally we don't do. There are papers which shows that if the patient is having CTD ILD and the patient is on say mycophenolate, at some point of time the patient is ultimately developing IPF like features, UIP pattern more in HRCT thorax, you can use mycophenolate with nintedanib. This combination is actually we are giving in patients, but generally we don't give pirfenidone and nintedanib combined.
And what is the role of steroid in preventing the initial symptom?
So only exacerbation in IPF cases, or rather in ILD cases, only in case of exacerbation steroid is necessary. Yes, you can say in chronic HP steroid is the mainstay of treatment, because in chronic HP and sarcoidosis before any relapse you can use steroid easily, and that is the mainstay of treatment in those two varieties actually.
Hello. Actually, thanks for your delivered presentation. Actually, we have some ILD patient in case of, you just tell your slides, that is RF factor positive, rheumatoid arthritis as well as anti-TCP highly positive. But arthritis is not there. In that cases, in ILD, how to manage the cases?
So what we, this is very important question. There are plenty of patients who have not developed this arthritis phenomena. So we have to think about what is lagging behind, whether the lung symptoms or the arthritic symptoms, which is lagging behind. So generally there are almost 30% patients where the lung symptoms is predominant, arthritic symptoms are not so much present. In those cases, what we generally start is, as he was speaking, the SAD was speaking, we generally start with steroid, but as soon as the steroid dose has been tapered to say 10 milligram of prednisolone, we start with a disease modifying agent, preferably, in my preference it is mycophenolate mofetil. We start with mycophenolate, we titrate the dose of mycophenolate up to 2 gram twice daily, because the approved dose is up to 3 gram BD, but in Indian scenario we cannot go up to 3 gram BD because of different situations. 2 gram BD is acceptable in Indian scenario. When it is, when you have reached the 2 gram BD scenario, you stop the steroid and then see the response. That is what we do generally.
In this regard, I think it's wise to mention that methotrexate itself can cause this.
That is
very important.
Very important. That's why I have talked about drugs, amiodarone and methotrexate. These are two drugs, and you will find plenty of patient who is having rheumatoid arthritis, getting methotrexate, and then having ILD, and it is really very difficult. It is a diagnostic challenge actually, whether this ILD is happening due to rheumatoid arthritis or due to methotrexate.
Right. So, thank you very much, Dr. Mukherjee.
Thank you.
We look forward to your future presentation. Thank you.
Thank you so much, sir, and I will be requesting, so please have a seat, and I will be requesting our chairperson to please come and join us to facilitate Dr. Angshuman Mukherjee with a bouquet of flower, followed by that a token of appreciation. Ladies and gentlemen, kindly put up your hands together for Dr. Angshuman Mukherjee. Similarly, I will be requesting Dr. Mofidul Islam to come and join us and facilitate our chairperson, Dr. M.M. Ganguly. Thank you so much for this session, and now, without wasting much time, let's move forward to the next session. Thank you so much, each and everyone. Let's take a picture, and moving forward to the next session. The next session, the speaker that I would like to invite on the stage is none other than K.K. Ganguly. But before that, let me call out the chairperson. The first chairperson that I would like to call on the stage, Dr. Gautameshwar Mujumdar. Followed by that, I will be requesting Dr. B.T. Bormon to come and join us. Can I request both the chairperson to come and join us? Ladies and gentlemen, kindly put up your hands together for the chairperson. And now, we are talking about the speaker K.K. Ganguly, MD 1996, MRCP 2000 and CCST Endocrinology in 2007. He has won quite a number of prestigious awards that includes 20 publication in international journal, 19 publication in national journals, 15 abstract publication in international journals with 4 book chapters. Currently, he is posted as a consultant in endocrinology, C.K. Birla Hospital, Peerless Hospital, Kolkata. Thank you so much, sir, for being here today. Thank you so much for giving us time out of your busy and hectic schedule.
On behalf of ABCDCon, I welcome Professor K.K. Ganguly to enlighten us on this very important topic, role of insulin in 2024, because we all know the bulk of type 2 diabetes mellitus and type 1 diabetes mellitus are increasing day by day because of our lifestyle pattern and sedentary habituate and corporate activity. So this is a very important topic, and we all know that we are all practitioners. We know that the failure rate of insulin therapy is very high so far the rural practice is concerned. Educated people in metropolitan cities, they stick to the doctor, they advise, follow the advice of a doctor, they take their insulin in regular basis. But in type 2 cities and in small towns and villages, it is very difficult to continue insulin therapy for a long time. Just to start, it is okay. Now, I'll request sir to deliver his speech.
Thank you, Chairperson, sir. So it's always nice to be here, and my batchmate Dr. Sujan Sarkar is here, so it's reunion time as well for me. তো এবার ছোটবেলা থেকে বড় হয়েছি ইন্টার্নশিপ, স্টুডেন্ট লাইফ, হাউস স্টাফশিপে যে ইনসুলিন ইজ দি বেস্ট মলিকিউল ever discovered, and I truly believe that it is the best molecule ever discovered. 5টা Nobel Prize পেয়েছে, কোনো ট্যাবলেট, ক্যান্সারের ট্যাবলেট একটার বেশি পায়নি. There is no question about it. It is a lifesaver. But আমি একটুখানি I'll be going against the tide. হ্যাঁ, তখন যেটা MBBS পাস করার সময় 35 বছর আগে তখন যা পড়েছিলাম এখন কি সেটা স্ট্যান্ড করে about insulin. So আমরা প্যারামিটার্স কি ইউজ করি টু ডিসাইড অন ইনিশিয়াল থেরাপি? যে আমি একটা ডায়াবেটিস পেশেন্ট এলাম, একে যে ওষুধ দেব এ কি বিটা সেল ফেলিয়ারটা আটকে দেবে? কার্ডিয়াক আউটকাম, হার্ট ফেলিয়ার, সিকেডি এগুলোতে কি ভালো কাজ করবে? ডায়াবেটিসের সাথে অ্যাসোসিয়েটেড there are lot of entities which are associated with diabetes. Will it have an impact on them? And lastly, adverse effects. So এগুলো দিয়ে, so as you know, insulin's only adverse effects is hypoglycemia and bit of weight gain. Weight gainটা আমাদের বিদেশে অনেক বেশি হয়, they need very high doses of insulin, আমাদের অতটা হয় না। তো সেদিকে দেখতে গেলে সবচেয়ে ন্যাচারালি is insulin, and the hypoglycemia is the only adverse effect. ইনসুলিনের একটা ডিফেক্ট আছে, ইনসুলিনের দোষ নয়, আমরা কিভাবে দিচ্ছি সেটার দোষ। কারণ ইনসুলিন, it is made in the portal vein. So নর্মাল যাদের ডায়াবেটিস নেই তার পোর্টাল ভেনের ইনসুলিন লেভেল এইখানে, পেরিফেরাল এখানে, আর আমরা যখন দিচ্ছি উল্টো হয়ে যাচ্ছে। সো কেউ যদি আবিষ্কার করতো ডাইরেক্ট পোর্টাল ভেনে ইনসুলিন দেওয়ার মেডিসিন, আমার মনে হয় অনেক কিছু ডিফারেন্ট হতো। নেভারদিলেস, এবার বিটা সেল ফেলিয়ার। সো এবারে প্রথম যে ট্রায়ালটা হয়েছিল, সে এই স্লাইডটা আমরা বারবার দেখি যে বিটা সেলস গেট লস্ট, about 80 to 85% are lost when you have type 2 diabetes. আমার অনেক ডাক্তার বন্ধুরা প্রায় চোখে জল নিয়ে বলে, আমার তো গেল ডায়াবেটিস হয়ে গেছে, মানে আমার 80% বিটা সেল নেই। আমার বিটা সেল নেই, তার মানে আমার প্যানক্রিয়াসে স্টেন করে দিয়ে দেখি একটা দুটো পড়ে আছে বিটা সেল, কি অবস্থা ভাব। So now this is the first data which যেখানে ইনসুলিনটা বিটা সেল আটকে রাখছে, বিটা সেল প্রলং করছে, ডায়াবেটিসটা ধরে রাখছে। This was the first paper. So this was in 2008. Now here you see, if I take you through this, newly diagnosed, এটা কিন্তু আজকের দিনে হলে পরে এথিক্যাল কমিটি আটকে দেবে। It's not possible to do it like this, trial like this in today's world. নতুন ডায়াবেটিস হয়েছে, 3 ভাগে ভাগ করলাম। একটা দলকে আমরা কন্টিনিউয়াস সাবকিউটেনিয়াস ইনসুলিন ইনফিউশন পাম্পে দিলাম, একটা দলকে 4 বার বেজাল বোলাস ইনসুলিন দিলাম, আরেকটা দলকে খালি ট্যাবলেট দিলাম। ট্যাবলেটটা কি? মেটফরমিন আর পুরনো দিনের সালফেনিউরিয়া। ওকে, মেটফরমিন সালফেনিউরিয়া। তো তিনটে দলে ভাগ করা হলো। এবারে কেন আজকালকার দিনে ট্রায়ালটা অ্যাপ্রুভাল পাবে না? নর্মোগ্লাইসিমিয়া 2 সপ্তাহ যদি মেনটেন করা যায় এই ট্রিটমেন্ট দিয়ে, তাহলে ট্রিটমেন্ট বন্ধ। মানে আমি সাবকিউটিনিয়াস পাম্প ইনসুলিন দিয়ে 2 সপ্তাহ যদি দেখি সুগার কন্ট্রোল, বন্ধ। 4 বার ইনসুলিন দিচ্ছি 2 সপ্তাহ ধরে, সুগার কন্ট্রোল বন্ধ। ট্যাবলেট দিচ্ছি 2 সপ্তাহ ধরে, সুগার কন্ট্রোল বন্ধ। নাথিং, পেশেন্ট ইজ অন নাথিং। সো নাও ইফ ইউ ফলো ফর দেম ফর 1 year, কিচ্ছু না দিয়ে, এগুলো দিয়ে দেখা গেল যে 51% অফ দ্য পেশেন্ট রিমেইনড ইন রেমিশন। কোনটা? যারা কন্টিনিউয়াস ইনসুলিন পাচ্ছিল পাম্পে, আর যারা বেজাল বোলাস পাচ্ছিল 45%, আর যারা ওরাল পাচ্ছিল 26%। তো এখানেই প্রথম বললো যে দেখো, দ্যাট দেয়ারফোর দি ওরাল ট্যাবলেটস ডু নট হোল্ড অন টু দ্য বিটা সেল, দি ইনসুলিন হেল্পস ইন কনজার্ভিং দ্য বিটা সেলস। এরপরে অনেকগুলো চলে এলো পেপার, একটার পর একটা। সো দিস ইজ রেগুলারলি শোন ইন আওয়ার ইনসুলিন কোম্পানি মিটিংস, রেগুলারলি চলে এলো। আর যে কোনো নতুন ড্রাগ আবিষ্কার হলেই সালফোনিউরিয়াকে আগে স্কেপগোট বানানো হোক, ওকে ধরে পেটাও। মোস্ট ওয়াইডলি ইউজড ট্যাবলেট ইন দি হোল ওয়ার্ল্ড, ওকে ধরে পেটাও, ও খারাপ, ও বিটা সেল ধ্বংস করে দেয়। সো দেন দিস স্লাইড ইজ অলওয়েজ শোন যে HbA1c ড্রপ করার পরে ইউকেপিডিয়াস যেটা, সুগার আবার বেড়ে যাচ্ছে। বাট এবারে I'm going to contradict my statement now. So if you see in the UKPDS trial, I don't know if people from there can see it, maybe I'll show it there. HbA1c drop করে আবার বেড়ে যাচ্ছে। But if you see here, প্রত্যেকটাতে কনভেনশনাল আর্ম হোক, সালফেনিউরিয়া আর্ম হোক, মেটফরমিন হোক, এমনকি ইনসুলিন আর্মেও HbA1c বেড়ে যাচ্ছে। তবে কেন আমরা বাকিগুলোকে দোষ দিচ্ছি যে ওটা বিটা সেল ফেল করছে? এবারে বিটা সেল নেই আমার, 85% চলে গেল। দেন এক্সপ্লেন টু মি দিস, ডায়াবেটিসে বেরিয়াট্রিক সার্জারির পরে অনেক পেশেন্টরা মাল্টিপল ইনসুলিন নিচ্ছে। বেরিয়াট্রিক সার্জারি, আমরা প্যাঙ্ক্রিয়াসে হাতই দিলাম না, সার্জারি করে দেখা গেল দের ইজ remission of diabetes and up to 50 to 60% of patients are off insulin for 1 year. তাহলে কি হলো? বিটা সেল চলে গিয়েছিল, তো আবার কি হলো তাহলে? এই তো বললেন যে বিটা সেল নেই, 80% ডেড। আর এখানে এই পেশেন্টদের 1 বছর হয়ে গেল, কোনো ওষুধ কিচ্ছু লাগছে না। So the new theory is now coming up, which is this, that the chameleon is changing color. So এটা হলো গিয়ে নর্মাল বিটা সেল, চ্যালেঞ্জড বিটা সেল। এইখানে দুটো প্রকৃতি হতে পারে, একটা বিটা সেল ডেড হয়ে গেল, আরেকটা বিটা সেল ট্রান্সফর্মস ইনটু আনাদার ফর্ম অফ সেল, ডেল্টা আলফা যাই হোক। সো দেয়ারফোর দেখতে লাগছে বিটা সেল কমে গেছে, কিন্তু অ্যাকচুয়ালি ওটা মরেনি, সবকটা অনেকগুলো চেঞ্জ হয়ে গেছে। এবারে এই চেঞ্জ হওয়াকে ফেরত আবার বিটা সেলের মধ্যে আনা যায় কিনা, দ্যাট ইজ দি কোয়েশ্চেন। উই ডোন্ট হ্যাভ এনি ডেটা যে করা যায় কিনা, বাট I'm going to show you some data which suggests that it can. আমার জন্যে, I am not a clinical scientist, I am just a doctor, practicing doctor just like you. আমার জন্যে বিটা সেলকে কে ধরে রাখবে ওই ড্রাগটাই সবচেয়ে ভালো। যে আমি এখনই বললাম ইম্পেয়ার্ড গ্লুকোজ টলারেন্স মানে 50% বিটা সেল গন। সে ইম্পেয়ার্ড গ্লুকোজ টলারেন্স থেকে ডায়াবেটিস হওয়া যে আটকাতে পারবে সেই ড্রাগটা বিটা সেল ধরে রাখতে পারছে, কারণ সে 50% ড্যামেজ থেকে 80% ড্যামেজ হতে দেয়নি। আমার জন্যই দিস ইজ আ সিম্পল টুল। সো ইফ আই নাও সি যে ড্রাগ কোন ড্রাগ কতখানি আটকাতে পারছে, ইজ দেয়ার এনি ডেটা? ইনসুলিন দিয়ে আমি কি কতখানি আটকাতে পারছি? সো দিস ইজ দি biggest trial till date, আর এতটা বড় ট্রায়াল আর কোনোদিন হবে না। 40 countries, more than 12,500 patients, and this is the purest insulin trial. কারণ ওখানে কি করা হলো, patients with high CV risk with newly diagnosed diabetes or IGT, impaired glucose tolerance, এদেরকে স্ট্যান্ডার্ড গ্লাইসেমিক ক্লিয়ার দেওয়া হলো বা ইনসুলিন দেওয়া হলো। মাইন্ড ইউ, ইম্পেয়ার্ড গ্লুকোজ টলারেন্স পেশেন্টদেরও ইনসুলিন দেওয়া হয়েছে, ডায়াবেটিস হয়নি। তো 2 ভাগে ভাগ, এই স্ট্যান্ডার্ড গ্রুপে কেউ ইনসুলিন পাবে না, আর এই গ্রুপে সবাই ইনসুলিন পাবে। দিস ইজ দি পিওরেস্ট ট্রায়াল। তো যা এফেক্ট বা সাইড এফেক্ট বা গুড এফেক্ট আমরা ক্লিয়ারলি বলতে পারবো, হয় ইনসুলিনের জন্য ভালো হলে ইনসুলিনের জন্য ভালো, ভালো না হলে ইনসুলিনের জন্য ভালো না। দিস ইজ দ্য বেস্ট ক্লিয়ারেস্ট ট্রায়াল। সো এইখানে you can see here about 17% did not have diabetes, they had pre-diabetes, and the rest had newly onset diabetes. So ekhane if you look amra ki korte perechi, impaired glucose tolerance theke diabetes 28% atkate perechi with insulin, shetake 3 mas pore dekha gelo it drops down to 20%. So insulin e ami je higher figure tao dhori, এই গ্রুপকে 28% ইম্পেয়ার্ড গ্লুকোজ টলারেন্স থেকে ডায়াবেটিস 28% আটকাতে পেরেছে। অন্য ডেটাগুলো কি আছে? ইউ ক্যান সি হিয়ার, ইউ ক্যান সি উইথ মেটফরমিন ইট ইজ 31%, অ্যাকারবোজ ইজ 25%, হাইয়েস্ট কে পায়োগ্লিটাজোন 72%। তো আমার মতে তো বেস্ট ড্রাগ গ্লিটাজোন গ্রুপ which will prevent the progression from IG to diabetes. এই সবচেয়ে ভালো বিটা। এবং if you look at the literature, that is the only insulin sensitizer. No other drug is insulin sensitizer, only glitazone. But ওটার ব্যাগেজ আছে, postmenopausal women, fractures, heart failure, macular edema. So these problems are there, and insulin is at 28%. It is close to the bottom actually. তারপরে আরেকটা ট্রায়াল এলো, this is a great trial and this is more recent. এখানে patients with type 2 diabetes on metformin, ওরা metformin পাচ্ছিল, they divided into 4 groups. একটা glimepiride পেলো, একদল sitagliptin পেলো, একদল liraglutide GLP-1 receptor agonist পেলো, আরেক দল ইনসুলিন পেলো। এবারে এদের আউটকামটা সিম্পল, কে ফেল করছে আগে, যে তত তাড়াতাড়ি ফেল করবে যে তত খারাপ, যে যত বেশি দিন পরে ফেল করবে সে তত ভালো। So that is the main. This was heavily criticized in the ADA meeting itself. যে SGLT2 আর pioglitazone কেন ইনক্লুড করা হয়নি। So but anyway, ওটা করলে হয়তো আরো একটু ইন্টারেস্টিং হতো। But this is the data with the great trial. And what was the outcome? So primary outcome was time to HbA1c more than 7. And you can see here, সবাই তো সালফিনিরাকে ধরে পেটায়। So you can see here, liraglutide was the best. ও সবচেয়ে বেশি ধরে রেখেছিল HbA1cটা 882 days, followed by glargine 860, insulin 861. সালফিনিরিয়া কিন্তু বেশি পিছিয়ে নেই, 810 days ahead of DPP4 inhibitor. So but yet still আমরা সালফিনিরিয়াকে ধরে পেটাবো। Now this is another landmark trial. So Defronzo did it because he to কি বলে ওটাকে revolutionary, বাগি যাকে বলে হিন্দিতে, against the tide. So what he did was, again newly diagnosed diabetes কে দুভাগে ভাগ করলো, একটা দলকে ট্যাবলেট তারপরে কমছে না ইনসুলিন, আরেকটা দলকে স্ট্রেট অ্যাওয়ে মেটফরমিন, পায়োগ্লিটাজোন, এক্সেনাটাইড, তিনটে একসাথে। ইউ ক্যান সি হিয়ার ইনিশিয়াল কম্বিনেশন থেরাপি উইথ মেটফরমিন, পায়োগ্লিটাজোন, এক্সেনাটাইড, আর আরেকটা গ্রুপকে ট্যাবলেট এবং ইনসুলিন। তো সেটা দেখা গেল hypoglycemia was 3 times less in the triple drug group, in a metformin, exenatide, pioglitazone. Weight gain was more in the insulin arm and was -1 kilogram in the other arm, and HbA1c was again better. এবং শুধু তাই নয়, if you see the graph for 6 years, triple armটার it maintained the HbA1c for a period of 6 years. So therefore, if you go back to the UKPDS data again, যেখানে আমরা প্রথম বলেছি আরে তো নাইকি কার্ভের মতন উঠে যাচ্ছে HbA1cটা। সো আমরা যদি দুটো গ্রুপ দেখি, নন ওভারওয়েট আর ওভারওয়েট, দিস ইজ বিটা সেল ফাংশন, দিস ইজ দি বিটা সেল ফাংশন। তো এবারে আমরা যদি কনভেনশনাল আর্মকে দেখি, বিটা সেল ফাংশন কমে আসছে, দ্যাট ইজ দি ন্যাচারাল হিস্ট্রি। ডায়াবেটিস মানেই বিটা সেল ফাংশন কমে আসবে, দিস ইজ কমে আসছে। Now if you see with the sulfonylurea, beta cell function improve করলো, কারণ ইনসুলিন বেশি তৈরি করছে, ওটাও কমে আসছে। But you can see it at the end of 6 years, ওর বিটা সেল ফাংশন এখানে আর কনভেনশনাল আর্মের কিন্তু এখানে। তাহলে আমরা কেন বলছি যে সালফিনিউরিয়া মেরে দিচ্ছে বিটা সেলকে? ও তো কমে আসছে কিন্তু এও কমে আসছে, ইট ইজ দ্য সেম রেট। So I think for lack of time, I have to rush through this. So this is another trial, Tosca IT, but I'll come to that if I get time at the end. So next, holo giye CV outcome. Tebare diabetes patients, and I heard the discussion earlier. So diabetes patients die of heart disease, they have stroke, they have got heart failure. Tale insulin diye ki amra heart attack atkate parchi ba heart failure atkate parchi kina for diabetes patients. So if you see GLP-1 receptor agonist, I think 4 of them, which is the liraglutide, Susten 6 with semaglutide, you have got data with Rewind, which is dulaglutide, and albiglutide not available. Egulate 3-point MACE was achieved. Baki shopgulote was trend in the right direction. So GLP-1 receptor agonist, good group of drugs, anti-atherogenic effect. Now, heart failure GLP-1 you have to take it with a little bit of pinch of salt. Heart failure meta-analysis dekhache, yes, it does reduce. Kintu ektai trial, the Amplitude O trial, was the one which showed reduction in heart failure. No other trial showed reduction in heart failure. It was in the center. Shopgulo data niye average eta asche. But GLP-1 receptor agonist, je kono trial ache done in heart failure patients failed to show any improvement in heart failure. So GLP-1 3-point MACE, non-fatal MI, non-fatal stroke, MI stroke, এইটা কমাতে পেরেছে, heart failure কিন্তু কমাতে পারেনি, but at least একটা right direction এ গেছে. So T2 inhibitors, এই স্লাইডগুলো আপনারা বহুবার দেখেছেন, বস্তা পচা হয়ে গেছে. So we have got clear evidence of 3-point MACE reduction with all 3, starting off with empagliflozin to begin with. And we can see patients with history of heart failure ekhane and patients without history of heart failure, and this is very important. Jar heart failure nei ajke take ami confidently bolte parchi je ami ajke dicchi SGLT2 inhibitors, empagliflozin ajke আপনাকে দিলাম, আপনার হার্ট ফেলিয়ার রিস্ক আমি অনেকটা কমিয়ে দিলাম, 21% আমি কমিয়ে দিতে পারছি, আপনার হার্ট ফেলিয়ারে বিন্দুমাত্র কিচ্ছু নেই. So this we can say with confidence. We cannot say that with any other anti-diabetic agent so far. And not only the heart failure with reduced ejection fraction, you can see here, ekhane ejection fraction 40 to 50%, 50 to 60%, third is more than 60%, or ekhane total heart failure outcome. So whatever is your ejection fraction, now we have got good data with 2 molecules, that whether it is reduced or preserved, if you have got heart failure, it will improve. If you don't have any form of heart failure, it will improve. So about insulin. So again, ami origin e ferot achi, otate duto cardiovascular outcome chilo co-primary. First was death from CV cause, non-fatal MI, non-fatal stroke. Our second was or moddhe hospitalization for heart failure dewa chilo. So ami insulin diye prothomei shuru kore 6 বছর টেনে, am I able to reduce 3-point MACE? Am I able to reduce heart failure? So the answer is this. No. Answer is no. It is all in the center. Heart failure, otau center. So there was no benefit giving insulin for 6 years in relatively newly diagnosed diabetes or pre-diabetes for patients with high CV risk. No improvement. So ebare that biggest my point, তাহলে আমি HbA1c কমালাম, HbA1c কমিয়ে আমি microvascular endpoint কমাতে পারছি, নেফ্রোপ্যাথি, রেটিনোপ্যাথি, পেরিফেরাল নিউরোপ্যাথি, গুড, কিন্তু যেতে মারা যাচ্ছে পেশেন্ট হলো গিয়ে কার্ডিওভ্যাসকুলার এন্ড হার্ট ফেলিয়ার, সেটা কিন্তু আমি কমাতে পারছি না with insulin. So CKD, and these are the 3 landmark trials of SGLT2 inhibitors. CKD te GLP-1 receptor agonisted ekhon obdi data shows that albuminuria komache but not reduction of the GFR. But with the SGLT2 inhibitors, the brilliance is that khali albuminuria komache na. I am against a drug which just reduces albuminuria. You know, সব কটা DPP4 ইনহিবিটর অ্যালবুমিনিউরিয়া কমায়, পায়োগ্লিটাজোন কমায়, অনেক ড্রাগ আছে অ্যালবুমিনিউরিয়া কমায়, আমার কি লাভ যদি আমি পেশেন্টকে ডায়ালিসিস টেবিলের উপরে আটকাতে না পারলাম? So this stops patients from going to dialysis. stops the doubling of the EGFR. So of these three, there are three different. So you can see credence, DAPA CKD, and EMPA kidney. EMPA kidney difference from DAPA is that there were more patients, so more than 6,500 patients. EGFR, if you look, it's from 20 to 45, as low as 20. EGFR low হয়ে গেলে সুগারটা অত কমে না, কিন্তু কার্ডিয়াক আর রিনাল বেনিফিটটা কিন্তু পারসিস্টেন্ট থাকে. And you can see here, at any level of albuminuria, so a good chunk of patients, more than 20%, did not have any albuminuria. The albuminuria thakuk, na thakuk, EGFR 20 obdi, if you give, then you have got benefit in progression of CKD. So I've got 2 minutes more. So there you can see 28% reduction in the primary CKD endpoint. Last few points, impacts on other parameters, and this is becoming increasingly important. So liver enzymes, this is the meta-analysis of empagliflozin on non-alcoholic fatty liver disease. Although I have shown you the slides for SGLT2, I must hasten to add.
Speaker, please justify the time.
Yes. So I'll just take 2 minutes, I'll finish. So GLP-1 receptor agonist kintu better data ache than SGLT2 as far as non-alcoholic fatty liver disease. Biopsy proof ache. Tar moddhe liraglutide is the top, and then followed by semaglutide. But SGLT2 emerging data, I am showing you a meta-analysis of empagliflozin showing good reduction of AST, ALT, and radiological improvement in fatty liver. And this is a very, very important area, very much neglected. আমি 100টা পেশেন্টকে যদি বলি আমার মনে হচ্ছে আপনার অবস্ট্রাকটিভ স্লিপ আপনিয়া আছে, আপনি একটু টেস্ট করে নিন, একটা হয়তো করাবে খুব মুশকিলে, আর করিয়ে তার রেজাল্ট 100 জনের যদি করায় তার মধ্যে একজন ট্রিটমেন্ট নেবে, and it is a killer. Obstructive sleep apnea kills. So this is the first time which has been shown that with the, this is the data from EMPA-REG, empagliflozin, showing there was a 52% reduction in onset of new onset obstructive sleep apnea. We can discuss that, the reasons in the end. So the last slide, with the ACE, they have shown that glucocentric algorithm, মানে যাদের কোনো কিচ্ছু রকম আর কিছু নেই, খালি পিওর ডায়াবেটিস আছে, for them you might start with metformin and then go on to the other drugs. কিন্তু একটাও যদি রিস্ক ফ্যাক্টর স্টার্ট হয়, you must start with either an SGLT2 or a GLP-1 receptor agonist to begin with. So Chairperson sir, this is the last slide for the audience. So এগুলো আমি বানিয়েছি, যে প্যারামিটারগুলো রয়েছে, আর এই কোন এই কমনেস্ট যেগুলো ডায়াবেটিস, ইনসুলিন, সালফিনিয়া, মেটফর্মিন, পায়ো, DPP4, GLP-1, SGLT2, HbA1c সবাই কমাবে, ওয়েট এই দুটো কমাবে, ব্লাড প্রেশার এই দুটো কমাবে, CVOTর এই দুটো ডেটা আছে, হার্ট ফেলিয়ারের SGLT2 ডেটা আছে, CKD অনলি SGLT2 ডেটা, ইউরিক অ্যাসিড, রিনাল ক্যালকুলার গাউট SGLT2 ডেটা, NAFLD, we have got data with pioglitazone, best data is with pioglitazone, then GLP-1, then SGLT2, and obstructive sleep apnea is this. So I think the answer, will it be relegated as last line therapy, insulin? 30 years ago, I would have said, a pagoltake stage ke uthiyeche. But now I will say most cases, no, it will be relegated to last line. Some cases, yes, but most cases, no, because of all of these reasons. If anybody having catabolic symptoms, very high blood sugar, lost 5% of their body weight, severe polyuria, polydipsia, any infection, insulin first choice, no question. But apart from that, these are the parameters, and this is the slide which I end my talk with. Thank you very much.
Thank you, my learned speaker, Dr. Ganguly. You have lucid and elaborate deliberation of your lecture in favor of all oral hypoglycemic agent against the insulin. But the thing is that by definition, insulin is a relative and absolute deficiency of insulin. So in that cases, ultimately we may have to treat with the insulin to those subjects. So whatsoever it may be, and also it is the true anabolic hormone. In that cases, it is very much helpful in our body. So far, your discussion, it is very good and lucid, and always in favor of your oral. Thank you. Regarding the questions, the audience will not be allowed questions now. They will go for question in the lunch session during the lunch. And I'm now handing over the mic to the organizer.
Thank you so much, sir. And now I will be requesting our chairperson to facilitate K.K. Ganguly. Dr. K.K. Ganguly will be facilitated with a bouquet of flower, followed by that a token of appreciation. So ladies and gentlemen, kindly put up your hands together. And now I will be requesting Dr. D.K. Gupta to come and join us on the stage to facilitate Dr. Gautameshwar Mujumdar, the chairperson of today's session. I will be requesting Dr. Ashish Kumar Mukherjee to come and facilitate Dr. B.D. Bormon. So please come and join us. We should have a picture with all the dignified personalities on the stage. All four of you together, please, for a picture. It's a request. Sir, please come and join for a picture. Sir, please come and join for a picture. Thank you so much. Let's proceed to the next session. And yes, for the next session, I would like to call the chairpersons, Professor Aditya Prasad Roy. So please come and join us. It's a privilege that sir is here with us. And I will be requesting Dr. Jayanta Chakraborty to come and join us as a chairperson. I will be requesting both the chairperson to come and join us. Professor Adit.
Please give them passage. Professor Sarkar and Dr. Jayanta Chakraborty.
I will be inviting on the dais Dr. Soumendranath Haldar. Dr. Soumendranath Haldar is an infectious disease specialist. He has completed his MD in tropical medicine from School of Tropical Medicine and DM in infectious disease from AIIMS, New Delhi. He has experience in treating infections in immunocompetent and immunocompromised patient. Area of expertise include the infectious diseases, HIV, tuberculosis, systematic fungal infections in solid organ transplant, and HSCT adult traveler screening of infections in patients with immunomodulator recipient, dengue, malaria, tropical diseases, hepatitis B and C infection, torch infection in pregnancy, COVID-19 infection, surgical site infection. So yes, people present here, please put up your hands together for Dr. Soumendranath Haldar.
Hello. Good afternoon all. So I am in between lunch and the last session, so it's very difficult for me. And respected my dignitaries, my chairpersons, thanks ABCDCon Scientific Committee for giving me the opportunity. My topic is vaccination in adults and underutilized opportunity. So disclaimer, GSK is the sponsor for this session. So the outlines are immunity, barriers of adult immunization, why we are so poor in adult immunization, presentation and the risk factors, impact of quality of life, recommendations, safety and efficacy, and conclusion. So about the vaccination, few lines like what is the site of administration of a vaccine that should be taken care of, schedule of vaccine, how many doses are there for a vaccine, adverse reactions, what are the fatal and non-fatal adverse reactions, usually mild, harmless and systemic symptoms are rare with the common vaccines. Contraindications, there are some absolute contraindications and there are some relative contraindications. Live versus inactivated vaccine and indication of the vaccine. So for immunization schedule, there are certain indications for vaccines. One is age. So when the CDC, they formulate the guidelines for vaccination, there are certain indicators. One is age, like above a certain age you should take some vaccine. Second is some medical conditions, like if you're suffering from diabetes, if you're suffering from hypertension, if you're suffering from CLD, CKD, then you are a eligible candidate for the vaccine. Third is special population. So these are the populations now we are moving towards this world. In comparison to the previous days, nowadays transplantation is happening almost all the corporate sectors of Kolkata, and hematopoietic stem cell transplantation is also increasing. Third is the number of patients with autoimmune rheumatological diseases are coming to the OPDs more. So they are the special populations who need the vaccination most. Less immunosuppressed conditions, like a patient who is having CKD or CLD, they are having to some extent such sort of B cell or T cell dysfunction. They need the vaccines. Travel related vaccines, these subjects are rapidly growing up, like a student who is going abroad for his study, or if you are going like African countries for safari or any other countries, there are some guidelines from the CDC, so you have to take those vaccines before going to those countries. And undergoing some procedure, like a patient who is going to for a splenectomy, like a thalassemia patient, like traumatic abrasion of the spleen and splenectomy is needed. So these kind of patients needs vaccination. So our immune system changes over individual's life. Like when we are small, our immune system is not adequate to control all the infections. Then it develops through childhood to adulthood, and after a certain age, the immunosenescence happens to us. So what exactly happens in immunosenescence? Like the T cell replicative capacity reduces, hematopoiesis reduces, B cell functions reduces. As you know, there are two kinds of vaccines. One is polysaccharide vaccine, one is conjugate vaccine. Conjugate vaccine for activity needs both T and B cell function. But for the polysaccharide vaccines, T cell is good enough. For that reason, there is no memory cell formation with the polysaccharide vaccine. Chemokine productivity, cytokine productivity, cytotoxicity, all are reduced. Phagocytic and chemolytic capacity is reduced. This kind of immunosuppression is common in diabetic population, in CKD population, and in CLD population. So impaired function of the organs, as shown in this picture, there is reduced function of muscle mass formation, cardiac wall strength, myelin sheath integrity. So if you want to improve the quality of life, then apart from healthy eating, physical activity, smoking avoidance, screening of health conditions and hygiene, you should be adequately vaccinated also. So the older adults who is more than 50 years will account for 27% of total population in India by 2026. So this graph is showing that the adult population, that is more than elderly population, more than 50 years population, will reach 27%. And if I consider the population of India, so it's a huge number which may require vaccination. So if I am it is a cardio-diabetic forum, if I see the graph, 10.2%, the increasing age is associated with higher risk of chronic health conditions, and for the diabetic population, the benefit is 10.2% of the population is 75 years, and almost more than 10%, more than 15% of population is above 50 years. This is very important. So what is the real world data? This is a data from the AIIMS Jodhpur. So limited data and coverage suggest that the adult vaccination coverage in country is negligible. Data from AIIMS Jodhpur is post-exposure prophylaxis taken 583 for tetanus toxoid and 278 for anti-rabies vaccines. These kind of things are happening before, so some awareness is there about anti-rabies vaccine and anti-tetanus vaccines. But the newer vaccines, the awareness is very poor. Pre-exposure vaccination, yellow fever for traveling, hepatitis B for healthcare workers, pneumococcal vaccine also for healthcare workers, and now some patients with they're having risk factors, typhoid and influenza vaccine. So what are the barriers for adult immunization? It is the lack of surveillance, lack of national guidelines, lack of coordinated adult vaccination program. We are very unfortunate that we are not having a national guidelines. Yes, some bodies are there like API, like RSSDI, they are formulating according to their population, but still we are lacking our national guidelines for adult immunization. Treatment taking precedence over the prevention, it's better because the vaccine, if I consider some vaccine, it costs more than 5,000, more than 8,000 rupees, whether the treatment completes within 400 or 500 rupees. So cost is also an issue. And still in India, the vaccination part is still never not covered by the insurance companies. They are very reluctant to cover it. For that reason, as the vaccine company, as the insurance companies are not covering, so it's a challenge for us also to prescribe. Then is the lack of provider recommendation, cost, lack of recognition of benefits, efficacy or safety. So we are running our own adult immunization clinic at School of Tropical Medicine since last 2 years. We have given these kind of vaccines, PCV 120 doses, PPSV 23, 325, influenza 350, hepatitis B 500 doses. We have given 15 doses of meningococcal vaccine. All are supplied from the government of West Bengal. And we are having Shingrix vaccine, herpes zoster recombinant vaccine. But in our setup, we are very stringent for making our own policy, because every day we are getting almost thousands of eligible patients for the vaccinations, but we are not able to offer them all. So we are formulated our own criteria for giving them vaccine. This is the adult immunization schedules. I think I should discuss this later. So 99.5% of the more than 50 years of age are infected with varicella zoster virus and are at risk of shingles. So basically it's a reactivation. So the varicella zoster virus becomes latent in the sensory ganglia nerves. Apart from varicella zoster, all kinds of herpes group of viruses remain dormant in the or remains latent in the dorsal root ganglia, and it in any point of time, if there is any kind of immunosuppressions, it reactivates. So up to 1 in 3 people will develop shingles in their lifetime due to varicella zoster virus reactivation. So age and immunocompromising conditions are well recognized risk factors. Decreased varicella zoster virus specific CMI in this group leads to the reactivation. And if I go by real, these patients have attended in our hospital. So see the severity of the infections. These 2 patients are suffering from varicella zoster infection. The left hand patient, the patient is diabetic. The patient was having poorly controlled diabetes, hypertension and early renal disease. Second picture was taken from a patient who was suffering from malignancy. He has undergone some mandibulectomy. After that, on post of day like 13 or 14, the patient developed this kind of herpes zoster, extensive involvement involving the eye also. This kind of presentation usually we get in our OPD. This is presentation in immunocompetent patients. Localized, very small area is involved. In the right side, the just few lesions. Left side also, this is classical presentation you may get in your clinic. So what is the data? So global data is like worldwide incidence is 3 per 1,000. Risk of developing postherpetic neuralgia is 5 to 30%. But the data for India is to some extent different. More than 50 years of age, it is more, 15 to 81%. And postherpetic neuralgia following the herpes zoster infection is also more in India. It's almost 10 to 54%. Comorbid conditions were frequently predisposing for this kind of presentation. So this slide shows that the incidence rate gone up when the age is gone up, and it is more than 50 years, it is almost, the prevalence is more than 15% or 20% like that. And in the right side, the pooled risk ratio for herpes zoster at this is the diabetic forum. So for diabetes mellitus, it is more. The risk is 1.24. So although the risk is much more with the physiological stress, physical trauma and COPD, but for diabetes also it's 1.24. So, and what about the pain? It's extremely severe, it's excruciating pain. If you are getting a patient of postherpetic neuralgia, it's very, very difficult sometimes to control the pain with all kinds of available drugs. And see the left side, acute pain, it's more than the labor pain, and it's more than the postoperative pain. So please think that it's better to prevent for a patient to develop the postherpetic neuralgia. So regarding the why the vaccine is needed, this is like an immunocompetent patient, if he develops herpes zoster and if his or her immune system is okay, then he spontaneously recover. But if the patient is developing this kind of complications, it's very severe. So what kind of patient we usually see in tertiary care hospitals? We see transplant patients. So if a transplant patient is developing herpes zoster, we are very scared, because if the patient is developing encephalitis or aseptic meningitis, mortality is almost more than 90%. So please be very cautious. So for that reason, sometimes the nephrologist wait for the vaccination, because you have to wait, you have to give an interval between the vaccination and the transplant. Ideally it is 4 to 8 weeks. So even if a patient is not vaccinated with the herpes zoster vaccine, sometimes the nephrologist wait for the vaccination and postpone the transplant for another couple of weeks. So this is in addition to age. These are the factors, like for COPD 24 to 41% increased risk, for cardiovascular disease 34%, stress 47%, steroid use is a very strong risk factor, up to 6 times increased risk. For diabetes 38% increased risk for developing herpes zoster. And autoimmune disease, nowadays some guidelines are there for different autoimmune societies, and they are now strongly recommending this herpes zoster vaccine. So if I am thinking about the diabetes is an independent risk factor for post-herpetic neuralgia. Relative risk is 1.35, and increased healthcare resource uses following the herpes zoster episodes indicate that it is more severe in people with diabetes mellitus, herpes zoster. As I have shown in my previous picture, that patient extensive herpes lesions are suffering from the poorly controlled diabetes. So when usually it happens? So following in any acute event, like it may be a myocardial infarction, it may be a CVA. So and it happens most commonly within week to months. So when a patient is having some myocardial infarction or having some CVA, see it's within first month the risk is highest. It is 1.78 for a patient with stroke and 1.68 a patient who is suffering from myocardial infarction. So these are the COPD patients. They are more prone to develop herpes zoster. So oral corticosteroid is the systemic steroid therapy is the most important risk factor, followed by inhaled corticosteroids. This is the vaccine. Actually what the vaccine does, it is a glycoprotein E protein against which our immunity develops. And basically what is a vaccine? Vaccine is a component of the pathogen without having the virulence. That is the basic principle of a vaccine. So here see we have given some adjuvant to the vaccine to increase the efficacy. So without the adjuvant see the immune response is very low, but when we are adding the adjuvant it is much higher. So Shingrix, so this is 2 trials. I will very rapidly go through these 2 trials. Primary objective was efficacy for prevention of herpes zoster and post-herpetic neuralgia. 2 groups, one is above 50 years, another was above 70 years. 2 vaccine was given, 0.5 ml around 0 and 2 months to both this group, and primary objective was efficacy for prevention of herpes zoster and post-herpetic neuralgia. And see the results in all groups. The efficacy was more than 90% for both 2 studies, ZOE 50 for 50 years age and 70 for 70 years age. And more important is that vaccine efficacy against post-herpetic neuralgia, it is 91%, almost around 90% for both the groups, 50 and 70. And up to 10 years, the data shows 89% efficacy. Although most of the standard guidelines or textbooks recommends that more than 85% efficacy is there with all kind of vaccines for at least 5 years. So the adverse reactions, so it is almost within 3 days all kind of adverse reaction subsides. This is the mild form of adverse reactions like pain, redness, swelling at local site and the fatigue, fever, GI. What about the fatal side effects? So for the this is the serious adverse effects, SAE, fatal SAE, and another thing is potential immune mediated disease. See, there is no significant difference between the placebo and the vaccine group. So for diabetes, pooled post hoc analysis of 50 and 70 data shows the efficacy is more than 90%. Now regarding what is the approval of this vaccine, so for recombinant herpes zoster vaccine, Shingrix, 50 approvals are there and 24 national recommendations are there. So what is the standard guidelines today? So 2024 guidelines, they recommend that adult aged 50 years or above, recombinant zoster vaccine may be used. But above 50 years, the patient with comorbidities like chronic renal failure, diabetes, rheumatoid arthritis, COPD should receive varicella zoster vaccine. This is very important. This subgroup should not deprive of the herpes zoster vaccine. First thing, if the patient is, so what we do for tomorrow, all patients above 50 years, should we give them? We should offer them with those subgroup of population who are having risk factors. Asthma, adults, COPD patients should receive the herpes zoster vaccine. For diabetes, these are the different governing bodies, or they usually made some recommendations for the vaccination. CDC, ACIP, they clearly made the recommendation above 50 years with diabetes mellitus should receive the vaccine. Germany guidelines, same, almost all the guidelines. Indian guidelines, RSSDI, they preferred singles vaccine due to its higher efficacy and longer duration of protection. In Indian setting, it is a good option for all diabetes above 50 years of age. This statement is very important. And the ADS, Standard of Medical Care in Diabetic, recommend 2 doses of the vaccine aged more than 50 years. So 2023 gold guidelines is in adults with COPD, in addition to the other vaccines, also the routine use of single vaccine should be done. So these are the few guidelines practices. So for autoimmune diseases, that for rheumatoid arthritis, SLE, inflammatory bowel disease, psoriatic arthritis, multiple sclerosis and rheumatic and musculoskeletal diseases, these bodies recommend Shingrix vaccine. And for the other group of immunocompromised patients like cancer, solid organ transplant, HIV and multiple myeloma, as I am emphasizing on this slide because number of patients of solid renal organ or renal transplant and hematopoietic stem cell transplant patients are rapidly increasing in our country also, because nowadays the organ donation awareness is much higher, and in the newspaper we usually see some news of organ donation. So please, this is an opportunity where you can use the vaccine. So Shingrix is indicated for prevention of herpes zoster and postherpetic neuralgia in adults ages 50 plus years. It is 2-dose series, 0.5 ml and from 2 to 6 months apart. But like a patient who is awaiting for the renal transplant, we usually give after 4 weeks. You can reduce the interval to 4 weeks also. 1 vial of antigen should be reconstituted with 1 ml of adjuvant suspension, and for IM use only. Shingrix is not indicated for the prevention of primary varicella
2 minutes
infection.
more.
Yeah. Sir, so be very clear. See, varicella vaccine is absolutely separate from the herpes zoster vaccine, number one. There is a live vaccine called Zostavax. Don't confuse Zostavax with Shingrix. Shingrix is a recombinant vaccine, so you can give it to the patients who is getting some immunosuppression, who is having some other kinds of immunosuppression like HIV, like transplant, who is getting triple immunosuppression, like hematopoietic stem cell transplant. These patients who are having immunosuppression don't give live vaccine or Zostavax. So this is the information regarding the vaccine, and this is the 2024 guidelines. So here it's very clear. See, there are 3 colors. So the yellow colors is the recommended vaccination for adults who meet age requirement, lack of documentation of vaccination or lack of evidence of immunity. And one good thing about the Shingrix is it is indicated in a patient who is suffering from the herpes zoster. One of my residents asked me, sir, why we will give? Because we are giving the patient for increasing the IgG. The patient is already having the infections, he is having IgG. Why we are offering the patient the herpes zoster? Because of post-herpetic neuralgia and recurrence. So Shingrix vaccine is indicated in a patient who is a history of herpes zoster, 1. Number 2, like a patient of other vaccines like MMR, we usually do a rubella IgG. If it is negative, then we give the vaccine. Here it's not needed. Varicella IgG is not needed for giving the vaccine. So for herpes zoster recombinant vaccine, this is age criteria. So 2 doses of immunocompromised. So for less than 50 years, if the patient is having some immunocompromising condition, then offer it, otherwise not. Above 50 years, you can offer the vaccine to all group of patients, but don't miss the opportunity to give the vaccine to a diabetic CKD patients or diabetic CLD patient. Yes, sir. 2 slides, sir. So this is the according to the specific disease wise different kinds of immunosuppression. Like for herpes zoster vaccine, it is for diabetic, it is recommended also. Now a 34 years old male patient without micro or macrovascular complications of diabetes, what you will do? You should offer the vaccine. Yes, I should offer the vaccine. A 60 years old male patient without any comorbidities, yes, I will offer the vaccine. 56 years old male with diabetes, specifically whether the patient is having micro or macrovascular complications, the patient should receive the vaccine. It's not like the previous 2 conditions. Here the patient should receive the vaccine. 60 years old male patient with history of herpes zoster, yes, he is an eligible candidate. A patient with hematological malignancy, definitely the patient should get it, or solid organ transplant patient. A patient on immunosuppression for lupus nephritis, yes, the patient should get the vaccine. A patient is waiting for the renal transplantation, should get the vaccine. Thank you all. This is my team at School of Tropical Medicine. These are our DM residents. If there are any question, I am happy to answer.
Thank you, sir, for your nice presentation. Now, any question from the floor, please?
Yeah. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Sir, if a patient is receiving varicella vaccine, even after that the patient should receive the recombinant zoster vaccine, because the vaccine, one thing is prevents herpes zoster. In addition to that, it prevents the post-herpetic neuralgia, where the varicella vaccine is not effective to prevent the recurrence and the post-herpetic neuralgia, sir.
I have got one question.
Sir?
Octogenarian.
Yes,
more
sir.
Than 80 years of age.
Yes, sir. More than
Can we
80
give-
years of old, there should be more immunosenescence, and the efficacy of the vaccine should be less than a patient who is having 60 years of age.
So
Still, sir, it is recommended.
So life expectancy is not considered here.
No, sir, and it's increasing, sir, day by day. It was 60, now it is 84, like that, sir.
For me, the last question, just how do you treat the patient who are having herpes zoster in your institute, the way you have shown? So a course of acyclovir is needed, and it is very
Yes, sir.
responsive to the medicine.
Yes, sir.
So my question is, do you feel that this section is cost effective, being given a vaccination, or just to treat it like that?
Yes, sir. Very nice question. Sir, the thing is, two aspects is there. One is, I have shown one picture also for an immunocompetent patient. That kind of patient, sir, like the patient is not having any comorbidities, just suffering from the herpes zoster, I am able to manage the patient with oral acyclovir or valacyclovir, then I am fine. I will suggest, or patient may get, but it's not mandatory for the patient. But a patient, sir, who is having some renal transplant, sir, I have seen at least 3 to 4 deaths patients where the patient post-transplant immunosuppression and patient died of herpes zoster encephalitis. So, sir, that for that kind of patient, sir, even like if I am getting one patient with transplant, after recovering from the herpes zoster, after an interval of 2 to 4 months, I will offer the patient for the vaccination.
Thank you. One question. What is the cost of this vaccine?
Sir, the cost is 2 doses. Each dose, sir, almost 8.5 thousand rupees, sir. Yes, sir. So almost, sir, 16 to 17,000. Yes, sir. Absolutely, sir. Absolutely.
That is the only barrier.
That
came to my chamber. Then when I will suggest and how to just make him or her understand that this is very important, because the incidence is, I think, 2 to 3% of the patients who's having herpes zoster recur this herpes zoster. Then how can
yes,
I
sir. Yes,
recur
sir.
herpes zoster?
So for the, sir, immunocompetent patients, the recurrence is, sir, less than 5%. For the patients who are getting immunosuppression or the patients who is above 50 years, sir, the recurrence is more. And specifically those subgroup of patients with different kinds of immunosuppressions, the fatality rate also, sir, it is happening is less than 1%. The herpes encephalitis is less than 1%, but mortality is 100% almost. So for that reason, it's better. Immunocompetent, sir, I will offer, but I won't say like you have to take the vaccine.
Thank
yes,
you.
sir.
So thank you, Professor Haldar, for an excellent deliberation and on a very different topic, deviating from our usual cardio-diabetic metabolic common soil disease. So we are few here, others are having lunch, but give a big hand to Professor Haldar. And I would request both of my chairpersons, Professor Sarkar and Dr. Chakraborty, to present a small token of gratitude to Professor Haldar. Please take a photograph. And I would request Dr. T.N. Banerjee to present Professor Aditya Prasad Sarkar a small token of gratitude on behalf of ABCD. And I would request Dr. Arnab Banerjee to present Dr. Jayanto Chakraborty a small token of gratitude on behalf of our scientific committee. A photograph, please. Thank you all. Thank you. So, without stopping here, we are going to start our next session. And this session will be delivered by Dr. Dipankar Ghosh Dostidar, and I would request Dr. T.N. Banerjee and Dr. Satrajit Ray to please chair this session. Please come to the stage. Dr. Banerjee and Dr. Ray, please. And a few words about Dr. Ghosh Dostidar, sir. Have a seat, please. Okay. So, Dr. Dipankar Ghosh Dostidar is currently Associate Professor and Head of the Department of Cardiology at Bardwan Medical College. Having done his DM Cardiology from IPGMER Hospital, Kolkata, he has worked in several hospitals including SSKM and Kolkata Medical College as a teacher, clinician and interventional cardiologist. He has several publications to his name. He has been awarded FESC, FSCC, FICP, FCSI and FSCAI. He keenly participates in national and state conferences as speaker and has been conducting the quiz program at CSI Update West Bengal annually. He was the scientific chairman of the CSI Update program 2019 at Kolkata. He is currently executive member of Central CSI Committee. He is the associate editor of the prestigious Indian Heart Journal. And apart from all these words, what I can say, after coming to Bardhaman, Dr. Ghosh Dostidar actually is very close to us. We do not miss usually, if we are in Bardhaman, we do not miss usually his CME and lectures. So, the microphone and stage is all yours, Dr. Ghosh Dostidar.
Thank you. Thank you, Shubham sir. Now, sir will deliver his lecture on heart failure with preserved ejection fraction, mechanism remodeling, and the translational perspective. Sir.
So, thank you, sir, for the kind words, and thanks to the organizers for having me here. Now, my talk will be on heart failure with preserved ejection fraction. Okay. So, heart failure with preserved ejection fraction is a clinical syndrome in which patients have signs and symptoms of heart failure, like breathlessness, caused by structural or functional cardiac abnormality, causing high left ventricular filling pressure. Their pump function is normal. So, despite normal ejection fraction, they have high left ventricular filling pressure, and they are corroborated by either elevated natriuretic peptide levels, or there is objective evidence of cardiogenic pulmonary or systemic venous congestion. So, like we have the systolic dysfunction where the ejection fraction is less than 40%, there is eccentric LV remodeling with low LV mass to volume ratio. But here in HFF, we have ejection fraction usually above 50%, and there is concentric LV remodeling and with high LV mass to volume ratio. Now, the universal definition of heart failure, they classify the different phenotypes according to the left ventricular ejection fraction. So, reduced ejection fraction is less than 40%, and then we have the mid-range ejection fraction from 41 to 49, and then comes the HFF with ejection fraction above 50%. And there is one more subset with heart failure with improved ejection fraction, where initially the ejection fraction was less than 40%, but there is a 10-point increase from the baseline LVEF, and the second measurement, the LVEF is now above 40%. So, these are the various subsets of heart failure. Now, just before moving on to the mainstream, just to differentiate between the stages of heart failure and the class of heart failure. Now by stage we mean stage A, B, C, D. Now in stage A, the patient does not have any structural abnormality, but there are risk factors only. So the patient may be diabetic, hypertensive, like that. So it will be as stage A. Now in stage B, there is some structural abnormality, like the patient has aortic stenosis, but no symptoms. So it's stage B. In stage C, it starts with symptoms. So once you are facing a patient of heart failure who has symptoms, it's straight away stage C. And stage D is patients who are undergoing recurrent hospitalizations. Now a key feature here is that once a patient is in stage C, he cannot go back to stage A and B. He is always stage C or beyond stage C. Whereas in class, when class 1, their patient is almost asymptomatic, class 2 is mild symptoms, class 3 is reduction in the ordinary physical activity, and class 4 is almost bedbound. So in class, with treatment, class may go from class 3 to class 2, again it may go to class 4 suddenly, and with treatment may come back to class 2. So this is all about stage and class. Now the key difference between heart failure with reduced ejection fraction with heart failure with preserved ejection fraction is that in reduced ejection fraction, the ROS activated causes autophagy, apoptosis, necrosis. So there is cell loss and there is dilatation of the heart with decreased pump function. Whereas in preserved ejection fraction, the ROS activity increases the protein kinase and there is extra hypertrophy and collagen interstitial fibrosis. So leading to stiffening of the heart with increased filling pressure. So this is mainly about the pathophysiology of heart failure, and there are a lot of intracellular changes, namely there is downregulation of the beta adrenergic receptors, and there is modification of the titin, there is calcium overloading in the cells. So all leading to increased stiffness. And apart from the cellular dysfunction, there is ventricular vascular stiffening, there is problem in the skeletal muscle in form of exercise intolerance. So, and the lung, kidney and abdominal organs are also affected. Now, is heart failure with preserved ejection fraction equally dangerous like heart failure with reduced ejection fraction? The answer is straight away yes. You can see OPD visits, 21.5% are heart failure with preserved ejection fraction compared to 20.1 with heart failure with reduced ejection. So more patients in the OPD are with preserved ejection fraction. And also the emergency visits are more with heart failure with preserved ejection fraction compared with heart failure with reduced ejection fraction. Now heart failure hospitalization is the #1 cause of hospitalization in patients above 65 years of age. And most important, 30% of patients with heart failure with preserved ejection fraction, they die within 1 year of heart failure hospitalization. So the mortality is also pretty high. Now, how do you diagnose a patient of heart failure with preserved ejection fraction? So just remember this mnemonic H2F PEF. Now H2 is heavy, meaning by which it's increased body mass index. And the patient, the second H stands for hypertension, meaning by which patient is taking 2 or more antihypertensive medications. The F stands for atrial fibrillation. Patient may have coexisting pulmonary hypertension picked up by echo, and the age is above 60 years of age, and raised filling pressure, namely E by E dashed, is very high. Mitral E by E dashed comes above 9. Usually we get values around 15, 16, something like that. So the higher the score, the more probability of the patient in having HFpEF. There are other scoring systems also, like HFA PEP study, basically looking at the same thing in a more detailed manner. So echo, the functional abnormality in the longitudinal strain is there. The morphological abnormalities are also there. There will be concentric hypertrophy and the LS size will be large, and you will have positive biomarkers. So once your patient is diagnosed with heart failure with preserved ejection fraction, you move on to the second algorithm, which is HFpEF. Now, the P stands for pre-test assessment. So you look at the signs and symptoms, you look at the comorbidities, you look at the ECG, echo, and you look at his exercise capacity. So that's all about the pre-test workup. Next, you look at the diagnostic workup, which is the echocardiography and the natriuretic peptide score. So this the number 2. So the echo, you will look at, like we said, you look at the LA mass, the LV mass index. So these are the main features you look at. And the biomarkers, the value varies whether the patient is in sinus rhythm or the patient is in atrial fibrillation. Now, the third step, the F, will be the functional testing in case of uncertainty. If you are in a gray zone, what you do is that you do a stress test to this patient and you do a stress echocardiography. You will immediately see that if he is indeed he is in heart failure, the hemodynamics will change. And the last would be to look for the etiology, and so final etiology, what he is suffering from. So these are the main algorithms we are all concerned with. So basically there are multiple pathophysiologic contributors with heart failure with preserved ejection fraction. So not only there is longitudinal systolic dysfunction, there is chronotropic incompetence, autonomic dysfunction, there is associated pulmonary hypertension and abnormal ventricular arterial coupling, arterial stiffness, and volume overload. Now, the strange thing is that now the treatment of heart failure with reduced ejection fraction is pretty streamlined, and we have almost now 5 to 6 pillars of it. The main pillars are ARNI, beta blockers, SGLT2 inhibitors, and then you have iron therapy in form of ferric carboxymaltose. So these are all pillars in heart failure with reduced ejection fraction. Strangely, when you apply these medicines to heart failure with preserved ejection fraction, none of them works. None of them works. Why? Because this is a very heterogeneous population. And now, with use of artificial intelligence, people are now doing phenomapping in heart failure with preserved ejection fraction. Mainly you have 3 types of heart failure with preserved ejection fraction phenotypically. One is the older elderly patient with vascular atherosclerosis or arteriosclerosis, so calcified vessels. Their prognosis is bad. The second variant, you have the metabolic obese phenotype, namely with mainly obstructive sleep apnea like that. And the third is the relatively younger patient with low BNP phenotype. So this phenotyping is now coming, and the treatment will vary according to the phenotype of the patient. Now LV filling pressure predicts mortality. And you see the biomarkers, they also predict mortality. The higher the biomarkers, the more bad is the prognosis. And the survival is definitely as bad as persons with reduced ejection fraction. Now this is what the overview of the landscape trials. On the left side, if you look at the heart failure with reduced ejection fraction medications. ACE inhibitor, ARB, beta blockers, SGLT2 inhibitors, all are beneficial. Mineralocorticoid receptor antagonist, hydralazine isosorbide dinitrate combination, vericiguat. But if you look to the right side, all the trials, major trials, are a failure. You look at the PEP-CHF trial with perindropil, you look at the CHARM preserve trial with candesartan, I-preserve trial with irbesartan, all of them are failure in heart failure with preserved ejection fraction. Only the SGLT2 inhibitors, namely the Emperor preserved heart failure, and the Deliver, which has concluded now with dapagliflozin, these 3 trials have shown to be beneficial in heart failure with preserved ejection fraction. TOPCAT and Paragon heart failure is successful only to certain extent in heart failure with preserved ejection fraction in certain subset of population. So if you look at this chart, CHARM preserved, PEP, CHF, I preserved, and TOPCAT, all of them, there is no difference with the placebo. These are long duration trials in heart failure with preserved ejection fraction. TOPCAT in certain male population only, it showed some benefit, not in female population. So there was a sex difference in the results of TOPCAT. Now coming to the Paragon heart failure study, which tried ARNI in patients of heart failure with preserved ejection fraction. Now the inclusion criteria, mainly the patients were in stage C heart failure and the age was more than 50 years of age. They ruled out kidney disease and extremes of blood pressure, and they ruled out also acute decompensated heart failure. Now, this is the results, and you see the p-value was not too much significant. So, only in a certain female population here, again a sex bias is seen, a female population and ejection fraction up to 57%, a benefit was noted. But in males or beyond 57% of ejection fraction, no benefit of ARNI in HEP was noted. Sorry. So now we move on to the SGLT2 inhibitors, and there are multiple mechanisms of action, namely causing diuresis, natriuresis, glycosuria, and thereby decreasing the preload, afterload, and probably they change myocardial energetics also. So the landmark two trials I will be discussing, one is the Emperor Preserved and one is the Deliver trial. Emperor Preserved is with empagliflozin and Deliver is with dapagliflozin. Pretty similar subset of patients. First is empagliflozin, tried in a dose of 10 milligram in patients with preserved ejection fraction, that was more than 40% of EF. So again, similar stage C heart failure patients were picked up, and they excluded acute decompensated heart failure, and extremes of blood pressure were excluded. And you look at, it was the median age was 71 years around, and female represented almost half of the study population. Now, one important thing to note here is Emperor Preserved, which asks a few questions. You see a lot of benefit in persons who have ejection fraction from 40 to 50% or up to 60%. Beyond 60%, the benefit was not so robust. So, overall, there was a 21% reduction in heart failure hospitalization, and the number needed to treat was as low as 31, and so it was pretty significant. And possibly this was the first molecule which was successfully used in heart failure with preserved ejection fraction. So it decreased cardiovascular death to the tune of 15% and heart failure hospitalization to the tune of 32%. A strange phenomenon was observed here when comparing with DAPA heart failure trial and Emperor reduced trial. It was seen that the cardiovascular death with DAPA was only 0.82 compared to Emperor reduced 0.92, whereas in diabetic patients with DAPA it was 0.92 and only 0.59 in EMPA-REG outcome. Possibly the inclusion criteria of diabetic patient or the cardiovascular disease involvement caused this kind of difference. So this is what I was speaking. If you look at the ejection fraction chart, the benefit is very robust with less than 50% and up to 60%, but beyond 60%, the confidence interval limit includes the figure 1, so it's hardly any difference with placebo. The key adverse effects, nothing serious, and most important, hypoglycemia was as good as in placebo. A small trial, preserved heart failure, looked at the used DAPA 10 milligram and looked at the exercise tolerance of the patients. Namely, it looked at the Kansas clinical score and the clinical questionnaire score and the 6-minute walk distance, both of which improved with use of dapagliflozin. So then came this Deliver trial and answering the 3 prime questions which were there after the Emperor Preserved trial. One was whether these molecules work in ejection fraction more than 60%. Can we give it during or soon after hospitalization? And can we give it in patients with improved ejection fraction? The answer to all these questions are yes, so far as the DAPA Deliver trial results are concerned. So, dapagliflozin could be used in entire spectrum of ejection fraction, right from low EF to mid-range to above 60% also. So, the baseline characteristics again were pretty similar to the patient subset of the Emperor Preserved, and the other drug molecules were there. Very high rate of mineralocorticoid use was seen, and you can see the primary result again. Almost the hazard ratio is 0.82, so 18% benefit is there, and the number needed to treat there was 31, here it is 32. So pretty similar results. both reduction in heart failure hospitalization and cardiovascular death. So, secondary endpoints, total heart failure events and cardiovascular death were also reduced by DAPA, and there was the improvement in the questionnaire score also. Safety, you can see no hypoglycemia episodes, not different from placebo. One more important thing I would like to add here is loop diuretics in heart failure. Now we all know that loop diuretics is the most important therapy in acute heart failure, but it unfortunately doesn't have the mortality benefit. But this study is showing that within the first 30 days of hospital admission, loop diuretics do show mortality benefit and they prevent recurrent hospitalization. So loop diuretics definitely are an important role to play in heart failure with preserved ejection fraction. A small cartoon about device therapy. Now that heart failure with preserved ejection fraction has got increased LA pressure, and you know the LA volume is large, so we have got methods to reduce LA volume and pressure by putting in some shunts across the atrial septal defects, and we're creating artificially left to right shunts. Then you have got LV expanders, and you have got mechanical supportory devices, and you have got stimulation, baroreceptor stimulatory devices. You can now have pulmonary artery pressure monitoring by putting in cardiomems, and this comes very handy because it gives a signal once the PA pressure starts rising. So you can escalate the diuretic dose based on these signal inputs and prevent worsening of the heart failure scenario from happening. So the take-home message is that now patients with heart failure with preserved ejection fraction are united by the presence of increased filling pressure. They have cardiac output at rest with exertion and the preserved left ventricular ejection fraction. But they are a very diverse population, and because of the heterogeneity of heart failure with preserved ejection fraction, majority of the clinical trials have failed. So we now need to improve classification of these different phenotypes of heart failure with preserved ejection fraction and individualize treatment accordingly. So phenomapping will play a novel role here. The other key takeaway message is that prevalence and rates of heart failure hospitalization and resource utilization in preserved ejection fraction are greatest with heart failure with reduced ejection fraction, but with heart failure with preserved ejection fraction, 30% mortality in 1 year after hospitalization. So treat the etiologic comorbidities like hypertension, congestion, atrial fibrillation in patients with HFpEF. My regime would be to give SGLT2 inhibitors irrespective of diabetes status, use loop diuretics, try ARNI, particularly if the ejection fraction is less than 57%, and maybe ARB, MRA, mineralocorticoid receptor antagonist in that hierarchy order may be tried. I thank you for your time and attention. Thank you so much.
Thank you, Dr. Gozusne. As usual, is a nice presentation on a difficult subject. The subject is difficult for the patient as well as the physician, concerned physician, because very little things to be done to the patients. And you have just given a glimpse of this HFpEF, and we are very pleased to announce that 2 or 3 questions may be allowed in this discussion.
Good afternoon, sir. So, ARNI, if the patient is having uncontrolled hypertension, so do you continue to increase the dose of ARNI, or do you add something as another agent as an antihypertensive?
No. ARNI is not meant for hypertension per se management. So for hypertension management, we'll be using antihypertensives. Now, if the patient has got a mid-range ejection fraction or a reduced ejection fraction, definitely you will omit the ACE inhibitor ARB and switch over to ARNI to give him those benefits. The problem with heart failure with preserved ejection fraction is that ARNI were not shown to be of much benefit above ejection fraction of 57%, and particularly in male subjects. It was in female and up to the EF of 57% in Paragon heart failure that ARNI was shown to prevent heart failure hospitalizations. So for hypertension management, we will be using antihypertensive as per the need of the patient.
Thank you, sir.
One more question, regarding the acute heart failure or worsening of heart failure. It differs from these patients. How to manage this kind of patients with HFpEF patients?
Yes, loop diuretics would be the first choice of therapy, and adequate use of loop diuretics to decongest the patient would be the first one. And then thanks to this DELIVER trial, we can see that we can use SGLT2 inhibitors namely in the acute stage also, in hospital course and early after discharge. So these are the only two dedicated therapies. Other, you have to treat the comorbidities. Why the patient went into heart failure? Is it atrial fibrillation with fast ventricular rate? Then you need to control the ventricular rate. So is it uncontrolled hypertension, as sir was suggesting? So then you have to control the hypertension. So like that, you have to treat the comorbidities.
Sir, I want to say one observation that so many cardiologists are prescribing the ARNIs in case of heart failure with preserved ejection fractions. So what is your opinion regarding this?
Yes, the guidelines are very clear about it. So far the data goes, it is only up to 57%. So one important thing to consider here is that if it is a case of improved ejection fraction. Now initially we don't know if the ejection fraction was below 40%, and with therapy it has now improved. All the data suggests that you continue the ARNI. Don't stop the ARNI even if the EF has improved. So possibly maybe these cases people are using ARNI. Now their ejection fraction is in the range of preserved range, but initially they are the subsets of improved ejection fraction.
In that case we have to
You continue the ARNI.
So do you agree that in future this longitudinal strain is going to replace the other parameters in detecting this HFpEF?
In future, we have now, there is a host of literature on AI. AI is coming in a big way, artificial intelligence, and looking at the data, they are phenotyping heart failure with preserved ejection fraction. Now, like I said, these three subset of patient. One is the elderly with calcified vessel. This is one subset with poor prognosis. The other is the obese diabetic type, and the other is the young with low BNP levels. So these three, they can't have the same medication. So it will always be tailored according to the phenotyping and phenomapping of heart failure with preserved ejection fraction. So whenever we are using blanket therapy like ACE inhibitors, beta blockers in reduced ejection fraction, it's always been a failure in heart failure with preserved ejection fraction.
Thank you very much. We are really indebted.
Please, sir.
SGL2 দিলে আর ব্লাড প্রেসার যেন ফেলিওরে তো অনেক কম থাকে।
Yes, you have to titre according to the blood pressure level. You have always to titre according to the blood pressure level.
কারণ SGL2 দেব আবার ফুলসেমাইড দেব তাতে অ্যাগ্রাভেটেড কিছু হবে না?
No. We can give, we have to titre according the blood pressure level. You will detect hypotension if there is mental status, there is disorientation, the urine output is decreasing, and all cold clammy extremities. These kind of patients, then you have to act accordingly. But there is no harm in adding SGLT2 inhibitors with diuretic, but definitely your point is very much well taken, particularly in Indian subset in hot humid conditions. When we sweat a lot, you must always look at his volume status before going on such form of therapy. But decongestion is the key message in heart failure with preserved ejection fraction. So always we'll try to decongest our patient.
Thank you.
Thank you, Dr. Ghosh. It is always fascinating to hear from you, and we are really enlightened by your speech. Thank you so much.
Thank you. Thank you, sir, for having me.
Thank you, sir. Sir, please have a seat. So I would request Dr. Satyajit Ray and Dr. T.N. Banerjee to please felicitate Dr. Dipankar Ghosh with a small token of gratitude from the scientific committee. A photograph, please. Thank you. Thank you. Now, one small time I am taking for a big event. That is because of the traffic congestion in the expressway, Dr. Satyajit Ray couldn't come during inauguration, but he is our designated chief guest. So I would request to felicitate our organizing secretary, Dr. Dharmendra Kumar Gupta, to felicitate Dr. Satrajit Ray, and he is instrumental in actually collaborating with all excellent physicians of Asansol Durgapur region to make Asansol Coalfield Diabetes Association a reality, and he has been successful for consecutive 3 years to have a beautiful annual conference. So he is our chief guest. I would request Dr. Ray to say a few words about our ABCDCon and your ACDA.
থ্যাংক ইউ স্যার। প্রথমেই আমি দুঃখ প্রকাশ করছি একটু দেরি হয়ে যাওয়ার জন্য, আর সায়েন্টিফিক এজেন্ডার মধ্যে বেশি কথা বলবো না। প্রথমেই আমি শুভময় স্যার এবং এবিসিডির যারা অর্গানাইজিং কমিটি, সুব্রত ভট্টাচার্য স্যার সবাই বসে আছেন, প্রত্যেককে আমার ধন্যবাদ জানাই। তারা এবার আমাকে চিফ গেস্ট করেছে, আমি জানি না আমি এটা যোগ্য কিনা, কিন্তু এটা আমি বলি যে এবিসিডি আজকে আমাদের আসানসোল, দুর্গাপুর এবং বর্ধমান মিলে 3টে অর্গানাইজেশন, তার মধ্যে সবচেয়ে পুরনো, এবং তারা দীর্ঘ 9 বছর ধরে এই প্রোগ্রাম করে চলেছে। এবং মানে বেসিক্যালি আমাদের কনসেপ্টটাও এসছে যে কলকাতার বাইরে পেরিফেরাল রিজিয়নে যে এই ধরনের কনফারেন্স করা যায়, সেটা আমরা এবিসিডির থেকেই প্রথমে দেখেছি। আমার মনে হয় স্যারের কাছ থেকে প্রথম আমি আইডিয়াটা নিয়েছিলাম জয়পুরে আরএসএসডিআই, জয়পুর আরএসএসডিআই, দ্যাট ওয়াজ 2018, কীভাবে এটা করা যায়। তো যাই হোক, এখন 3টে কনফারেন্সই খুব ভালোভাবে চলছে। তো আমার একটাই মানে ইচ্ছে, এবং বা আমাদের মানে ডক্টর বিশ্বাস চলে গেছেন, আমি আলোচনা করছিলাম 3টে অর্গানাইজেশন মিলে কনফারেন্স না হোক, কোনো একটা সোশ্যাল ওয়েলফেয়ার অ্যাক্টিভিটিস যদি একসঙ্গে করা যায় অ্যান্ড এ কনক্লেভ, সেটা একটা দারুণ হবে। আর বেশি সময় নেব না, অর্গানাইজার ডিকে ধন্যবাদ অসংখ্য। থ্যাংক ইউ স্যার।
Now our next session will be delivered by one person who is again very close to our heart, Dr. Rakesh Kumar. A short introduction, the chairing the session is Dr. Dinobandhu Naga and Dr. Mofidul Islam. I would request Dr. Naga and Dr. Islam to please come to the stage. And a short introduction about Rakesh. I am calling him Rakesh actually. He is a MBBS, MD, PG, Deep Clinical Endocrinology and Diabetes, RCP UK, Professor and ex-HED Department of Community Medicine, Director, Dr. Kumar's Diabetes and Lifestyle Clinic, Durgapur, in charge and consultant of a diabetes clinic, IQ City Medical College and Multi-Speciality Hospital, Durgapur, West Bengal, Assistant Secretary and Research Wing Head, Diabetes Awareness and You, that is called DAY, Research Publications 28+, Indexed Publication, Diabetes India 2021 winner for the best contribution in diabetes care in a challenging situation. So, Dr. Kumar, please.
Thank you for a warm introduction and having me here for ABCDCon. So today we are going to have a session on remogliflozin. এই molecule আমরা just 1 বছর আগে গাদা ইউজ করতাম। This molecule just got a blow just because one important molecule became off patent and price has been reduced. So does this molecule still relevant in Indian context? Let's see. So globally there are around 537 million people having diabetes, and it will cross 1 billion in next 30 years. And believe me, dear friends, all predictive models has failed to predict the rise of diabetes patients, because we were supposed to reach this magic figure of 537 million by 2030, but we reached this figure 1 year earlier, that is in 2022. And the recently concluded INDIDAB study, that is an ongoing study of the ICMR, says that in last 4 years India has shown a 44% increase in the diabetes patients, and now we are having 100 million patients. But the more scary data which we are not focusing from the INDIDAB is at least 47% of the population of India has some sort of dysglycemia. We are saying that the prevalence is only 11% of diabetes, but the INDIDAB study has used 3 different criteria for the diagnosis of diabetes. One is the OGTT, one is HbA1c, and one is combined. In OGTT, they have got more than 11% prevalence of diabetes. In HbA1c, they have got more than 20% of the prevalence of diabetes, and when they combine these two data, they have got almost 23% prevalence of diabetes. So whatever we are thinking less than what we are going to have in future. This is latest ADA guideline. Basically, we all are familiar with the guideline, divides the patients into two groups, whether the obese or non-obese, having ASCVD risk factors or not. The main molecules are either GLP-1 or SGLT2 inhibitor or both. The ATA asks one important point, that is with proven CV benefits. That's because FDA needs a CVOT trial for the drug approval, where there are multiple other countries like European Union, Indian government, that is DCGI, they did not require any CVOT trials. We have many fantastic molecules we are using since decades, like vildagliptin. This molecule does not have any US FDA approval, but European Union has approval of approving this molecule. Indian government approving this molecule. Telligiptin. This is another molecule, does not have any US FDA approval. So because CVOT trial is only mandatory to get a US FDA approval. So glucose variation with glycemic variability or different states of hyperglycemia, we all know that glycemic variability as an independent risk factor for the macrovascular complication, especially hyperglycemia, is one of the important components to predict the outcome of macrovascular complication. And diabetes patient has got 2 to 4-fold increased risk of having cardiovascular morbidity, and 2/3 of the death among diabetes patients can be attributed to cardiovascular complications. Now SGLT2 inhibitor, what it does, these molecules as a class reduces RAS, reduces oxidative stress, reduces inflammation, reduces sympathetic nervous system overactivity. These four mechanisms counteracts the most of the oxidative stress and improves the endothelial compliance. So this is one of the study, that is randomized control trial to compare the effect of remogliflozin versus dapagliflozin on 24-hour glucose profile assessed by CGM in Indian patients in type 2 diabetes patient. So primary objective was to evaluate effect of remogliflozin in 24-hour glucose profile assessed by parameters derived from continuous glucose monitoring in Indian patients of type 2 diabetes mellitus, and secondary objectives were to evaluate the safety and tolerability of remogliflozin in comparison to dapagliflozin. Study design was randomized 2-arm parallel group, open label. 6 weeks was the duration. Sample size was 33 in the remogliflozin and 32 in the DAPA group. Study drug was remogliflozin 100 milligram twice daily and DAPA 10 milligram once daily. 4 study sites were selected across India, 1 in Hyderabad, 2 in Hyderabad, 1 in Guntur and 1 in Pune. Key exclusion criteria were presence or evidence of decay or acute complications. Inclusion criteria were adults having on metformin monotherapy or dual therapy with DPP-4 inhibitor and random blood sugar level less than 300. So this was the study flow. CGM was installed. The current medication was continued for 7 days. Then the new molecule were introduced in the both group, and after 7 days CGM was removed, and after the gap of 3 weeks again the CGM was introduced and discontinued after 2 weeks. So the comparison of glycemic parameters at baseline: age, HbA1c, mean glucose, time in range, MAGE, CV, LAGE, MPPG, and PP 1 hour and PP 2 hour, all were comparable with in the both arms, and they were non-significant. Now coming to the comparison of glycemic parameters from baseline to phase 1. This is within molecule comparison, not between molecule comparison. So on left hand side we can see the remogliflozin. All the parameters except the coefficient of variance has got significant improvement, be it time in range, be it mean glucose, mean 1 hour PP, be it 2 hour PP. On the other hand, dapagliflozin, apart from CV, 2 other parameters, that is MPPG as well as PP 1 hour, were not significantly improved. And after phase 2 end, remogliflozin maintained the improvement. On the other hand, dapagliflozin, in addition to the 1 hour PP, MPPG and CV, mean glucose as well as PP 2 hour lost significant improvement. Between a molecule comparison, almost everything was similar and there was no significant difference. But one thing I here to mention that look at the time in range. Although the difference is non-significant, there is slightly more time in range associated with the remogliflozin, maybe because of its twice daily dosing. This is the same graph which we discussed earlier. All changes were statistically significant. Be it, there was significant improvement from baseline to phase 1 and phase 2 with both Remo and DAPA. There was no significant difference in improvement observed between remogliflozin as well as dapagliflozin. Mean change in continuous glucose profile across 24 hours from baseline to phase 2, we can see here that more reduction seen with Remo compared to the DAPA, especially at night. On the right hand side, we can see the peak of typical Indian patients which are having high carbohydrate diet at least 2 times per day, may be breakfast or lunch and dinner. So remogliflozin may be more effective in controlling PP peak or carbohydrate peak when they are taking it twice daily. So this is another study, Remit study conclusion. PP hyperglycemia is independent risk factor for CVD and has shown to further increase the risk of CV events in diabetic patients. Indian meal pattern of high carbohydrate meals per day contributes to more PP hyperglycemia. Significant improvement in time in range and HbA1c levels within both the groups, but no difference between the groups, but numerically more better improvement of time of range was observed with the remogliflozin group. Significant improvement in postprandial glycemic parameters. Significant improvement in the PP glycemic parameters at almost every meal time with remogliflozin, but fewer with dapagliflozin. Similar adverse events found in both the groups. Remogliflozin might be better in reducing glycemic variability with effective PP glycemic control in Indian type 2 diabetes patients. So this is tried RMB study. So background was the finding of the INDI study. The prevalence of diabetes was more than 11% in India. Study design was for the 24 weeks. The study enrolled 215 patients diagnosed with type 2 diabetes mellitus. Primary objective was to assess the safety of fixed dose combination of remogliflozin, metformin and vildagliptin in management of patients with type 2 diabetes mellitus patients uncontrolled on dual drug therapy of metformin plus SGLT2 or metformin plus DPP4 inhibitors. Secondary objective was to assess the efficacy of FDC RMV in Indian type 2 diabetes mellitus patients in terms of glycemic and extra glycemic assessment. In type 2 diabetes patients uncontrolled on dual drug therapy of metformin plus SGLT2 inhibitor or metformin plus DPP4 inhibitors. Exclusion criteria were hypersensitivity to or contraindication to any known molecule, patients of type 1 diabetes, patients suffering from acute complications, recurrent UTI, patients with a history of malignancy or diabetic ketoacidosis, women only currently on pregnant or lactating. So summary of subject disposition, female bear 36% of the population, male bear 64% of the population. Comorbid condition, most of them had hypertension followed by dyslipidemia, neuropathy, and less than 1% had benign prostatic hypertrophy. On the right hand side, major medications we can see here, antihypertensive. So despite having a drug of choice like AC inhibitor ARB, only around 5% of these patients are actually getting these first line antihypertensive, which should be used among diabetes patients. So not only glycemic parameters, there are other things which is giving important clue inside the diabetes management among Indian patients. So diabetes patients of Indian origin are not getting recommended antihypertensive as per their need. So efficacy results comparing the glycemic parameters between baseline to week 12 and 24. So baseline at HbA1c mean was 9.2, and at 12 weeks it was 7.9, and at 24 weeks it was 7.2, and the reduction of 2% was seen over the period of 24 weeks. Coming to the fasting, almost 40 milligram per deciliter reduction was seen at 24 weeks, and PP almost 60 milligram per deciliter reduction was seen at 24 weeks. Proportion of patients achieving glycemic target of less than 7% was 15% at 12 weeks and close to 45% at 24 weeks. Weight reduction of almost 2.7 kg was achieved after 24 weeks, and waist circumference of around 0.8 inches reduction was observed at 24 weeks. Blood pressure, when it comes to systolic and diastolic, mean reduction was around 2 millimeter of Hg. It may be less in our sense, but dear friends, most of the antihypertensive medication target and mean blood pressure reduction is around 4 to 8 millimeter of Hg. So this 2 millimeter of Hg is a free add-on with the glycemic control. So summary of over adverse events: almost 25% of population faced some sort of side effects, out of which adverse events of special interest like hypoglycemia, UTI and genital tract infections were faced by 2% and 5% population altogether. Hypoglycemia were observed in less than 2% patients, UTI in less than 2% and genital infection less than 1% patient. So comparing the lab parameters between baseline at 12 weeks and 24 weeks, be it blood urea nitrogen, bleed, EGFR, creatinine, everyone have shown improvement over a 24 weeks duration of treatment period. Good lipid profile improvement has been seen with the remogliflozin treatment over the 24-week treatment duration. When it comes to transaminase, reduction in the ALT, AST and bilirubin seen after 24 weeks of treatment with this molecule. So conclusion from this study: initiation of triple fixed dose combination of remogliflozin, metformin and vildagliptin showed significant reduction in HbA1c, fasting and PP from baseline to week 12 and week 24. There was a significant blood pressure and weight reduction over 24 weeks. No decline of renal parameters was observed and EGFR and serum creatine value were maintained. Overall, 4.7% of patients experienced adverse events of special interest like hypoglycemia 1.9%, UTI 1.9% and GTI 1%. No serious adverse events was observed in the study. Triple fixed dose combination was found to be well tolerated, safe and effective in patients with type 2 diabetes. Uncontrolled on dual therapy or metformin plus SGLT2 or metformin plus DPP-4 inhibitor. Hence twice daily dosing of remogliflozin, metformin, vildagliptin offers significant achievement of glycemic control in Indian T2DM patients consuming high carbohydrate meals. So this is one further study, one largest one-year prospective study data with any SGLT2 inhibitor in Indian type 2 diabetes patient. Name is Remolution. Study design was a prospective multi-center open label single arm observational active post-marketing surveillance study. Data were collected from across the India over the 60 sites. Data collection point was at 0 month, 1 month, 2 months, 3 months, 6 months, 9 months and 12 months. Exclusion criteria were patients whose GFR were less than 60, patients with moderate to severe hepatic impairment, patients with evidence of recurrent UTI, GTI, female patient on the oral contraceptive patient who are not willing to switch to the other modes of contraceptive. Sorry. Patients who have participated in any clinical trial 3 months prior to enroll and would not be participating in clinical study during the period of the study participation. Any other medical disorder, clinical condition that in opinion of investigator would pose additional risk to subject or preclude adequate assessment of efficacy. So almost 3,500 patients were enrolled in remogliflozin group, 1,500 in the remogliflozin metformin 500 and 235 in the remogliflozin metformin 1000. And almost more than 70% of enrolled people completed study in all the 3 arms, and most important reason to drop out was loss of follow-up, close to 25% in all the 3 arms. Adverse events were less than 1% as a reason for the dropout. So this is the comparison of clinical social characteristics of the population. Age was comparable. Gender, female 42%, 42%, 47% in all the 3 arms, male 57, 57 and 52%. BMI, blood pressure and HbA1c was also comparable. A slight higher HbA1c was in the remogliflozin metformin 1000 milligram arm. So summary of comorbid condition: hypertension again leading the comorbid condition, followed by dyslipidemia, neuropathy, heart failure. Anti-diabetic medication history. Overall summary of the adverse events safety population, that is more than 5,000 population was there. The most common adverse events reported were asthenia, fatigue, GTI, UTI, hypoglycemia, burning sensation, paresthesia, poikiluria and nocturia. All are less than 0.5% in some cases. Majority of the adverse events were mild in nature and resolved without sequel. No new safety signals were detected in the study. Hence, remogliflozin and FDC of remo, metformin and metformin tablets were well tolerated and safe among Indian population with type 2 diabetes mellitus patients. So, safety results, summary of serious adverse events. There was a total of 40 serious treatment emergent adverse events reported during this study. A total of 40 adverse events were reported in 36 subjects, that is 0.69%, again less than 1%. Out of which 18 serious events were reported with remogliflozin alone, 21 with the remogliflozin metformin 500 and only 1 with the remogliflozin metformin 1000. So ASI were reported as hypoglycemia, 33 events, 0.63% of the total events. UTI again 0.69% of the all events, and GTI in both male and female 0.77% of the all events. So efficacy results we can see here, everything, that is be it body weight, be it mean fasting, be it mean PPBS, mean HbA1c, everything have seen improvement over a period of time, and weight reduction can be up to 3 kg. So efficacy results, again same thing, both in terms of fasting, PP and HbA1c. Conclusion, reduction in HbA1c, fasting and PP levels were gradual among all 3 groups till 1 year. Overall, 43.67% of patients in the remogliflozin metformin group, 45% in the 500 metformin group and 49% in the 1000 metformin group achieved HbA1c less than 7 over a period of 1 year. No drug-related cardiac events were reported. The twice-daily regimen of remogliflozin and FDC potentially offer a better glycemic control in Indian patients whose dietary pattern consists of 2 large carbohydrate-rich meals. The results confirm the twice-daily regimen of remogliflozin 100, FDC of remo, metformin, and FDC of remo, metformin, and Vilda are effective among Indian patients and well tolerated. There are rich evidence of remogliflozin in Indian type 2 diabetes patients. Forever among 182 patients, Inspire around more than 37,000 patients, Revolution more than 5,000 patients and still ongoing. Phase 3, 906 Indian patients, Remit GV 75 Indian patients, Remit heart failure study, Remosef acute heart failure study recently concluded. Data will be available soon. Thanks from my side for the discussion.
Very relevant, practical and nice presentation from Dr. Rakesh. Many thanks to him. If there are any question from audience, please. No.
Yes, sir. There are many comparative study between CANA, EMPA, DEPA, that is. So main contender of this remogliflozin is dapagliflozin because the price came down because of the off-patent label. So there are few studies which one I have shown comparison with the dapagliflozin. Almost everything was non-significant among both the groups. Rather, few things, that is the time in range was non-significantly better among remogliflozin twice daily dosing. At 12 weeks, where the dapagliflozin lost significant reduction from the baseline, that is not between the molecule, within the molecule, where dapagliflozin from baseline to 12 weeks lost control, significant control from the PP1 hour, PP2 hour coefficient of variance, but remogliflozin maintained it.
One query is from me.
Yes.
We know that remogliflozin twice daily, 100 milligram. Is there any data, a maximum tolerated dose?
Yes. There are actually what we are using in the day-to-day practice of remogliflozin is peanut, because there are two types of arm. One was healthy people, one was type 2 patients. Among healthy people, 20 to 1000 milligram of remogliflozin was used. Among type 2 diabetes patients, 50 to 500 milligram milligram of remogliflozin was used. There is one other study where there was single daily dose of remogliflozin. They used up to 500 milligram, 4000 milligram of remogliflozin. So the therapeutic index of remogliflozin is very high. So even if you use a higher dose, 1 gram, 2 gram, there will not be any side effect at all, because the therapeutic index has been established up to a 4,000 gram of remogliflozin.
Sir, your presentation is auto-explanatory, very fantastic, nothing to say, but my curiosity is that, is there any scope in remote on the journey of glyphosine? We will use and guideline will be available on treatment of hypertension only?
Actually, many cardiologists, it's a good question indeed, sir. Many cardiologists are using this molecule for the heart failure, and blood pressure reduction is add-on. Right now, there is no clear-cut guideline, no guideline which promotes any SGLT2 inhibitor as an anti-hypertensive molecule. Blood pressure reduction is add-on because of the natriuresis and volume reduction. But this molecule has been, one or two SGLT2 inhibitor has been approved for the use for the cardiologist in the heart failure.
We can expect in future, because this is the journey of glyphosine. Another curiosity is whether glycemic control and glycemic variability. Double daily BD dose in remogliflozin, is there any benefit from glycemic variability?
Yes, sir.
In relation to the dapagliflozin or others?
In dapagliflozin, what happens, the T half of the DAPA is 12 hours, no doubt in that. So with the passage of time, the effect of dapagliflozin reduces. So when we take dapagliflozin in the morning and we take dinner at the night in the form of high carbohydrate diet, so the post-dinner reduction may be less in case of dapagliflozin, may be less, not definitely. While the remogliflozin, the availability is rapid, T max reaches between 0.5 to 1.5 hours, and it covers both the peak, be it post-breakfast peak or post-lunch peak or post-dinner peak. Especially all those working people in the office who are taking high carbohydrate meal at the breakfast, then take a light snack in the lunch, and then again high carbohydrate meal over a dinner. So this Remo twice daily might be a better molecule for control of glycemic excursion post-meal, as well as reduction of glycemic variability among those patients. So we can have various types of patients who are fit to get this molecule.
Thank you, sir. Actually, glycemic variability is another parameters other than glycemic control. So remogliflozin in this context is very suitable. Thanking sir again. Nothing to say for me.
Thank you, sir.
Thank you so much, sir. Kindly take your seat. I will be requesting you to kindly take your seat. And ladies and gentlemen, I will be requesting our chairperson to come and felicitate our speaker with a bouquet of flower, followed by that a token of appreciation. I will be requesting our chairperson as well as our speaker to come and join us for the frame. Yes, thank you so much. And now I will be requesting Dr. Arno Banerjee and Dr. Shantanudan to come and felicitate our chairperson. Thank you so much. So please come and join us. So please come and join us. We need another flower bouquet. I will be requesting 4 of you to come and join us for a picture so that we can have a sweet, cute little frame. So please come and join us in front. Yes. Meanwhile, I would like to introduce the next speaker. The next speaker is none other than Dr. Dilip Kumar, MBBS, MD Medicine, DM, Cardiology, FSCC, FRCP, Glasgow, FC, FSCAI, FESC, FICC, FHRS Certified Cardiac Device Specialist, CCDS, HRS USA, Dr. Dilip Kumar is Kolkata's well-known interventional cardiologist and structural heart expert. He is presently a senior consultant interventional cardiologist and electropsychologist and director cardiac cath lab services at Medical Institute of Cardiac Science. He possesses a professional experience of 15 years as a cardiologist and is an American board cardiac device specialist with vast experience in device implantation. He has also innovated many new ways of doing complex device cases and has immense experience of doing cheap coronary cases, with many cases published in international and national forum. Thank you, sir, for being here. But before that, I would like to call the chairperson for this session, the first Dr. Gautameshwar Mojumdar. Yes, sir, please come and join us. And followed by that, I will be requesting Dr. B.D. Chatterjee to come and join us as the chairperson for this session. Can we all get a round of applause for them? Over to the chairperson.
Dr. Bishash, without any delay, I am requesting you to deliver your lecture.
Thank you.
Welcome, Dr. Kumar. You please start your deliberation.
Thank you. Thank you, sir, and good afternoon, everyone. And thanks for having me here. So I will be little brief. I will try to finish my presentation in 10 minutes. There are a lot of questions on heart failure. I would like to discuss in 4 to 5 minutes after that. So these are my disclosures. I am national international proctor for these devices. I accept honorariums, and I am also advisor and consultant for these companies and get frequent honorariums. So let's go to the HFrEF and journey in India. So mortality rate in HFrEF in Indian patients is on rise. Even though we have so wonderful drugs, devices, and able physicians, able implanters, but still the mortality rate, you can appreciate here, is still on rise. And the biggest factor is the lack of GDMT. What we do is, in India, the proper utilization of GDMT is pathetic. And this is, we have very, very limited data, scarce data as well as scary data. So one of the, amongst the few data, we have a National Heart Failure Registry, which try to look at the clinical presentation, practice patterns in heart failure patients in India. And what they found was 1 of 2 eligible heart failure patients failed to receive GDMT. So this is really not done. And majority of our patients, if they don't receive GDMT, what would be the fate? And that is what is being reflected in the data from NHFR. There is a very high risk of mortality in our patients, and that too, it becomes 4 to 5 times than a normal patients with heart failure once they get hospitalized. So, and the maximum, the mortality happens in the first month after the discharge. So patient goes home, and within 1 month he is on, straightforward red flag. The doses needs to be adjusted. The patient needs to be more compliant and vigilant, because we see here the first month after discharge is really, really stormy. So GDMT is the foundation of heart failure care, and it is expected to be given in all heart failure patients. And ARNI becomes the #1 drug of GDMT. As class 1 indication, the first drug introduction should be ARNI, subject to blood pressures and other variables in heart failure patients. So you see here, what we are talking about, 50% less patients getting GDMT, but when it comes to ARNI, this is even less than 10%, 4.7% in one registry, 4.8%, 3.6%. So this is far, far, let alone acceptable. This is really, really, something which should not be acceptable. So when we choose for ARNI, the biggest apprehension is the patient is admitted with heart failure. Should we start or not? The patient never had a, RAS blockers like enalapril, ramipril, or a, ARB. Should we start on that? And patients with diabetes, is it going to work in the same manner? So you look at these all evidences. besides chronic heart failure, hospitalized patients, de novo patients, HFrEF patients with diabetes, these ARNI is well recommended, established beyond doubt that they have got evidence and they should be given. This is the largest paradigm heart failure trial, showed 20% reduction in cardiovascular death and around 21% reduction in heart failure hospitalization. And in this is the Indian cohort of patients in paradigm heart failure trial, one of the most appropriately done trial amongst the global trial with a very large significance. Indian data, Indian contribution was not a small one, it was a good number of patients were there, and Indian patients achieved similar kind of benefits in a paradigm heart failure trial. So our patients are equally at stake and can get better with this drug. When it comes to hospitalized patients, you see the hospitalized patients get more benefit. You see from 20% it becomes 42%. The benefit in reduction of cardiovascular death or rehospitalization is 42% when we start the drug earlier, when the patient is still admitted of inotropes, and that is the significance of the awareness and the will to start ARNI. This is again composite endpoints in hospitalized HFrEF patients, 42% reduction in serious composite endpoints, and you can see the Kaplan-Meier curve diverging and diverging. So if we follow the patients more, we can get more benefits. This is data from Pioneer heart failure trial, and you can appreciate here de novo hospitalized heart failure patients, they do get the same kind of benefit and same kind of Kaplan-Meier trend with ARNI. So we see that in chronic heart failure ambulatory patients we get a 20% reduction, but in those patients who are hospitalized we get 46% reduction. So high time we should realize that we have to start ARNI earlier when the patient is still admitted and a little bit stabilized, no inotropes, no IV Lasix, then we need to start this. And there is also a concern, do diabetic patients achieve the similar kind of benefit? Yes. Diabetic patients, still you get 20% reduction in risk of cardiovascular death and heart failure hospitalization, as do we see non-diabetic patients from paradigm heart failure trial. And also we see similar kind of remodeling in diabetic patients, improvement in LV ejection fraction up to 9.2 points. And HbA1c reduction is cherry on cake. We also get HbA1c reduction with ARNI. So you get so many benefits, and that is why we are looking at larger picture. What about beyond HFrEF patients? So Dipankar clearly showed us two of the trials, like Paragon heart failure trial he showed. There is another trial which has come, Paramount heart failure trial, where there is a significant reduction in NT-proBNP and left atrial volume reduction at 36 weeks in a significant manner. So this is just a matter of time when ARNI is going to be endorsed in guidelines for HFpEF patients as well. Just a matter of time. India has already approved this patient. DCGI, you see sacubitril valsartan in HFrEF patients, and HFpEF is going to be there endorsed in the guidelines very soon. So why innovator ARNI? Just a little word for the company which brought the drug. This is a very complex molecule with 1:1 fixed molar ratio, and this supramolecular complex has unique physicochemical properties. I really don't know. The drug which has given you such a wonderful result, a little alteration, is it going to reflect the same or not in clinical patients? We really don't know, and that is where solubility, hygroscopicity, dissolution and bioavailability of final molecule differs or not. So we have more than 6 years of clinical expertise, 230 clinical trials, more than 3 lakh patients, and trusted worldwide with 78 lakh patient years of exposure. So we may give little edge on this kind of innovator drug on others if the patient stake is heart failure. So here lies the future with ARNI. This is the last slide, and just a little while back there was a question, heart failure patients, whether the patient has ARNI on 50 BD, if the patient is still hypertensive, the blood pressure is still more than 170, 180, should we go on increasing ARNI or should we adding other drugs? Definitely there is a point in increasing the ARNI to maximum possible dose, because ARNI is recommended as antihypertensive therapy in China and Japan. It is used as a drug for hypertension, and soon so many trials are coming up which can put this drug in this bracket of problem as well. Hypertension can be treated with ARNI, and look at the situations. Acute coronary syndrome, this is being investigated. Transplant patient, this is going to be investigated. Chronic kidney disease, this is going to be investigated. So this is just a tip of iceberg what we see the caliber of ARNI in heart failure patients, and there is much more to come in future. With all this, one of the extra kind of push which brought me here was to just tell you about one or two things. These two kits are just like two tower valves against a surgical aortic valve replacement. 10 years back, it looked like two tiny children what they will do against shower, and now things are reversed. In India, there are 5-6 tower valves are available. We are doing it in Calcutta in our center, and I think most likely the Pankaj was just telling, in Vardhaman this is also going to start. Maybe if he calls me as a proctor, we do that. So there is a word of awareness about tower therapy which is totally established in Calcutta, so there is no need of kind of thinking and putting for giving these patients a surgical option only. We have a good tower options. With this, I conclude here, and I hope there will be more heart failure, questions regarding heart failure, which were little, kind of confusing. If I can throw some more light on that. Thank you so much. Thank you very much.
Thank you, Dr. Kumar, for your nice and brief discussion about ARNI. If anybody has any question, you can please ask.
Any questions, sir? Yes, sir. Please. Yeah.
Worsening of heart failure.
Yes.
So, what is your remarks about the how to manage it and how to detect it? Yeah. Worsening of heart failure, both in HFpEF and HFrEF.
So, worsening heart failure is an entity which has come with a very, very, strange kind of, problem which arose in US. In US, the heart failure physicians were over admitting these patients. Little bit of shortness of breath they were admitting, and insurance were, the patients being charged, and insurance company were reimbursing. So they came up with an idea that we will penalize those physicians who will admit heart failure patients more than 3 times in a year. And then there was a kind of a competition that heart failure patient is, even if this is deteriorating, they were not admitting the patients, and they were settling the patients even in kind of OPD with intravenous Lasix. They were giving shots of intravenous Lasix, 6 to 8 hours they were stabilized and they were pushed back. And these were the exactly patients where they termed worsening heart failure. And this was the origin of worsening heart failure patients category. And then vericiguat, the drug, which brought this idea that where should be our place? Let's look at this kind of patients who are having OPD basis of Lasix, who are decompensating heart failure hospitalization within 6 months, and apparently increase in diuretic dose. And they have shown in Victoria trial that these group of patients probably vericiguat works and gives significant benefit. So worsening heart failure is a definite entity now, and it should be treated with, first we have to rule out the secondary features. If the patient has uncontrolled hypertension, any infection, any hemoglobin anemia, we need to treat that, and we can maybe probably optimize the drugs, heart failure drugs, or 4 pillars, and maybe we can add vericiguat in these patients.
What about the role of MRA, this non-steroidal MRA, Finrenon?
Finrenon, yeah. So Finrenon should not be considered as a drug for heart failure. This is primarily a drug for diabetic nephropathy, only in those patients, and that too not advanced. So if the patient has a GFR of more than 60, in between 90, the patient is having albuminuria, in these kind of patients in Fidelia and Fidelio, they have shown benefit, reduction in cardiovascular events, but is yet to be established in all across diabetic patients with no albuminuria or no compromission of the eGFR. If the GFR is more than 90, if there is no albuminuria, there is no role of Finrenon. No established study till now. Maybe it is on the way, but at this moment, this drug is only for diabetic nephropathy in moderate to mild diabetic nephropathy.
In one of the trials in China, it has been shown that this Finrenon is as good as placebo.
Yeah. So still, So this is the only evidence, diabetic nephropathy. Many patients, they say, physicians, they have got this idea because of the kind of outreach program from company. They endorse, such a way. Some of the speakers also, they endorse such a way that they get confused what to do with this drug, we should write or not, whether it is better than spironolactone or eplerenone. So at this moment, this is just for endocrinologist colleagues, diabetic nephropathy they write, for cardiologists, heart failure, we are awaiting some trials so that we have some evidence to start with if we get some benefit.
You have rightly told that you'll have to, regarding this worsening of heart failure, you'll have to take care of the precipitating
Secondary
factors. And what is your take about this intravenous furosemide? How long we should give it, and how long we'll have to wait it, or how long you'll have to, after doing this, all these things, I will refer to the cardiologist.
Yeah, so intravenous diuretic should not be going, beyond euvolemia. So if you shouldn't be making the patient hypervolemic because the kidneys get at all, because heart failure patients, they have a compromised GFR also. If you reduce the intravascular volume to hypovolemic level, so you need to see the IVC or a pulmonary capillary wedge pressure if you have the facility. So I think ultrasound machine is everywhere. We can assess the IVC. If any time we see IVC is severely collapsing, less than 12 to 14 millimeter, you should stop giving IV diuretic. We can switch on the oral diuretic. So it should be maybe 24 to 48 hours IV diuretic if you give. I think it is more than enough to stabilize most of the patients.
Okay, sir. I have two questions actually.
Yes.
One question is that this patient is stable on the suppose this patient on enalapril is on stable, but somehow we try to earn in that stage in the stable patient. Supposed to be the NHY2 in the patient is on that, and patient is stable on that. But some study shows that if you shift the patient,
it has to be shifted, sir. If you wish a good future of this patient, the present is good, patient is doing all right, but this heart failure is never a stable heart failure. There is something going on, and you never know when the patient is going to decompensate. So for just like a mutual investment, is a fixed deposit, you have to shift this patient from enalapril or ramipril to ARNI. You will get a better future outcome, sir.
Another now the new pillar is coming in the heart failure, that is the iron carboxymaltose.
Yes, sir.
What is the anything is you can emphasize on that?
Yeah, so iron therapy is very important. Anemia is a very important risk factor for rehospitalization, decompensation, and initially the iron therapy, we were not able to give 500 to 1 gram below 7 days of time span. But now these combinations are there. We can give it in a bolus dose of half hour to 1 hour. The patient can take it at home even. First injection he can take in hospital. We see the allergic reactions. If there is no allergic reactions, we can recommend IV iron at home. They can get it done. They get it at home. Half an hour to 1 hour, they can infuse it with the help of nearby nursing home, any kind of paramedical staff.
What are in the case of heart failure, the fluid restriction, we are always say that. There is any definite guideline is that there's what amount of water he or he to take?
It depends on weight, sir. How we have to monitor the patient's weight. If the patient is overhydrated, the weight is increasing, so we have to advise more stringent water reduction, fluid restriction, and diuretic doses you have to escalate. If the patient's weight is maintained, you can just carry on with that. If the patient's weight is reducing, then you can relax your fluid restriction to 1.2 to 1.5, maybe 1.8 liters like that.
Sometimes patient is coming with some renal edema is there.
Yeah. So we can't be lesser than 1.2. Yes. Can't be lesser than 1.2. Yeah. Yes. Orthostatic hypotension. Yeah.
Careful about that.
Yeah. Yes. Heart failure, when the patient is in heart failure, so when the patient is in CKD, the urine output is equal to your intake.
Enough time has been spent by our learned speaker.
Just one
question answering.
So in all
we should
heart
to
failure
get some relief on that. No.
Can you give iron therapy in all heart failure patients? Can you give iron therapy?
Iron therapy only for iron deficient patients, not all.
Yes, that is.
Thank you, sir.
Every time we are talking regarding that it is reducing the mortality. What should be the actual term? Increasing the survivability or reduction of morbidity?
Yeah, so reduction of cardiovascular death is there. Total mortality is also, has been found to be
in relation
lesser.
to the heart failure. I am talking in relation to the heart failure. Does it reduce the mortality?
It reduces the mortality. Yeah, it reduces mortality, cardiovascular mortality as well as total mortality.
Okay, thank you.
Arnie.
No. It increasing the survivability, not the mortality.
Yes.
Mortality benefit.
So Arnie reduces the mortality. SGLT2 inhibitors, the dapagliflozin and empagliflozin, there is a little concern. Dapa reduces cardiovascular mortality. Empa doesn't have reduction in cardiovascular mortality or total mortality. It reduces the heart failure hospitalization.
What is the
So for
rationality? What is the rationality of this? It's not reducing the mortality despite doing so many good things. Is it a time fraction?
Time fraction. So if you follow these patients for more time, you may get a significance in mortality as well. Yeah.
One more practical thing.
Increasing.
One more practical question. While patient is in acute heart failure, you do the echo. Echo doesn't give this this ejection fraction or all this. When should we repeat this echo after controlling this acute heart failure?
Yeah, so echo, we also do pre-discharge echo. When the patient is admitted, we see not only the ejection fraction. I told there was a very good question whether the strain pattern is going to change and from EF we are going to global strain. No, it is not going to happen. Global strain we are learning, teaching, we are learning and sharing and knowledge of global strain right since 2005. If it has not established in 22 years, all the basis of treatment lie and all the studies have conducted till now on ejection fraction criteria. So ejection fraction is not going to be displaced with global strain. It is not a new kid in block. It is right there for last 20 years. People ask this question, I answer the same way everywhere in all the platforms. So global strain is an additional marker, maybe more AI and more specific kind of measurement and global strain if it comes, and we need more and more trials and data on that. Only then it takes it going to displace ejection fraction. So pre-discharge echo at the admission. During the course of hospital stay, you can look at the IVC. Before the patient goes, what we look at is at euvolumic status, what is the PA pressure, what is the LO volume, because it differs. In hypervolumic situation, the patient heart failure, LO volume will be automatically high, your PA pressure will automatically high, and then LVEDP will automatically high. At the baseline, when you have treated these patients, which parameters the patient is going on at, going to be get discharged. So at that time, the LV dimensions, LA volume and PA pressure is very important.
What about this patients with heart failure with LBBB? Suppose duration this is more than 160.
Yes.
What is your suggestion?
So we in Medica we conduct workshops for CRT implantation, and all across India people come and do. We are the we shouldn't be saying the masters, but we are the center of excellence for CRT. So patients with more than 120 millisecond LBB from ESC guideline and AHA guideline says more than 130 milliseconds. You get a patients with LBB and more than 120 to 130 millisecond on optimal medical therapy. Still he is having signs of decompensation or symptoms. This patient should undergo an angiogram first to rule out any coronary involvement. And if the angiogram is normal, you should fix a device, ideally a combo device, or if it is non-ischemic cardiomyopathy, a CRT plane, CRT-P is as good as combo device.
What are in presence of hypertrophic cardiomyopathy with failure, any mechanical device?
Hypertrophic cardiomyopathy, mechanical device, we do myomectomy in these patients. Sometimes a dual chamber pacemaker, a short AV, there was 1 or 2 trials which was there. So so myomectomy is the answer and the treatment.
Do you do septal ablation, this alcohol frequently?
We have we have done around 15 to 16 cases, and it does reduce the the gradients. And if the gradient is more than 40, you should be going for that. You should not be waiting for more. So if it is, and it will be beneficial only if you get a good septal. If a good septal artery, only then if you occlude it with alcohol, you are going to get an infarction of that area, and then the LV OT gradient will reduce.
Thank you.
Sorry, I took a little more time.
Aspirant audience can ask a lot of questions to a learned fellow, but time should not permit. So
Thank you, sir.
Thank you very much.
Thank you, sir. Thank you.
And this time also, I will be requesting our chairperson to come and felicitate Dr. Dilip Kumar. Thank you, sir. And I will be requesting Dr. Arno Banerjee to come and felicitate our chairpersons. All four in a frame, we request. Thank you so much. Right now, we will be continuing to the next session. And for the next session, again, I will be requesting Dr. Subroto Bhattacharya and Dr. Arno Banerjee to come and join us as chairperson. I will be requesting Dr. Subroto Bhattacharya and Dr. Arno Banerjee to come and join us as a chairperson. Thank you, sir, for being here with us. Dr. Abhinav Chaudhary will be coming instead of Dr. Arno Banerjee. Instead of Dr. Arno Banerjee, Dr. Abhinav Chaudhary will be coming and joining us. Thank you, sir, for being here. And the speaker that I would like to call upon the stage is none other than Rajarshi Mukhopadhyay, MBBS, MD, DNB, DM, MRCP, CCT, MRCP, FRCP as well as FACE from USA. The current affiliation includes the Royal College of Physicians, Edinburgh, and London Association of Physicians of India, API, Endocrine Society of India, Endocrine Society of USA, American Association of Clinical Endocrinologists. His current status includes a visiting consultant and HOD, Department of Endocrinology, World Health Hospital, Durgapur. So I will be requesting Dr. Rajarshi Mukhopadhyay to come and join us.
Well, unfortunately, I am starting after Rakesh, because Rakesh has already told everything about the the double trouble, etc., whatever. So it is our new drug, that is gliflozin, and the old drug, that is DPP-4 inhibitor, which causes double attack on dysglycemia. So here you can see that in ICMR India diabetes study, poor glycemic control was seen across both urban and rural India. And 64% of Indian type 2 diabetic patients do not attain the HbA1c target of less than 7%. So what are the realities with that traditional system of treating diabetes, that is the pyramidal system? So you start with one, then go up like that. So 50% of patients already have complications when you diagnose, especially type 2 diabetics. Then up to 80% of beta cell has already been lost when they are diagnosed. Two-thirds of patients do not achieve target HbA1c, and majority require polypharmacy to meet glycemic control over time. Of these, all the points, I would request you to just look at that 80% beta cell loss. Currently, diabetes, we diagnose only when the person has lost about 80% of beta cell. Hence, this type of approach increases the risk of complications. Individuals with high baseline values require particularly urgent and intensive treatment, and monotherapy is often insufficient in those individuals, and combination therapy should be initiated earlier.
So combination therapy has got increasing evidence and rationale of increasing durability of glycemic control, potential to address the therapeutic inertia also. Simultaneous targeting of multiple pathologic process is characterized, which is characteristic of type 2 diabetes, and potential impact on medication burden, adherence and treatment persistent. I have seen that patients, whenever you prescribe more than 2 drugs, they will start bunking 1 or 2. And complementary clinical benefits like glycemia, weight, cardiovascular profile, etc. So what do ADA 223 guidelines suggest on combination therapy? They say that should be considered in patients presenting with A1C level between 1.5 to 2% above target, and incorporation of high glycemic efficacy therapies of CV or renal reduction, for example, GLP-1 receptor agonist, SGLT2, etc. And may allow for weaning of current regimen, particularly of agents that may increase the risk of hypoglycemia like sulfonylureas. So what is the rationale for SGLT2 inhibitor and DPP4 inhibitor fixed dose combination? For patients, the drug of choice is based on efficacy, avoidance of side effect, cost and access, as well as preference. And SGLT2 and DPP4 inhibitors are preferred because it is safer, rapid and sustained glycemic control can be achieved, improve both insulin resistance and beta cell function, helps reduce body weight and blood pressure, which comes under extra glycemic effect, reduces pill burden, that is adherence and compliance improves, and overall cost effective after the SGLT2 inhibitors price has come down. So SGLT2 inhibitor and DPP4 inhibitors can provide up to 1.5% of HbA1c reduction with less risk of hypoglycemia, weight reduction and CV safety. As you can see, there's SGLT2 and DPP4 are more or less complementary, though I would say that GLP-1 receptor probably is better than DPP4 inhibitor, but it is that it is still mostly injectable, though oral is also available, and the cost. See, the cost is the main burden even if the oral GLP-1 receptor is available. So our motto will be to start early, start safely with an SGLT2 inhibitor and DPP4I combination after metformin. And if the patient cannot tolerate metformin, then this will be your ideal choice. Now we know about ominous octet. So what is that? Just to remind you that in diabetes there is decreased incretin effect, then increased lipolysis, increased glucose reabsorption, then decreased glucose uptake in the muscles, then neurotransmitter dysfunction, increased hepatic glucose production, then increased glucagon secretion, and lastly decreased insulin secretion. So as I've said that 80% of the beta cells are lost, so decreased insulin secretion is the prime problem which leads to increased glucagon secretion. And DPP4 inhibitor can inhibit all these 4 places, and GLP-1 agonists also. And SGLT2 is particularly on that increased glucose uptake is reduced, and this is one of the wonder drugs suddenly we have found. So just to go through the physiology, that DPP4 inhibitors like gliptins, they stop the DPP4 enzyme which remains in the body for few minutes, and because of DPP4 inhibitor, its circulating time gets increased, and hence it increases the our own GLP-1 in the body. And regarding SGLT2, as we know that glucose is reabsorbed, which we have seen, that sodium glucose cotransporter 2 absorbs most of the glucose, and in case of type 2 diabetes, the threshold also goes above 200. And most of the filtered glucose is not absorbed after blockade of SGLT2. And this leads to loss of excess glucose and hence reduction of HbA1c as well as body weight. And these are the pleiotropic mechanisms of SGLT2 inhibitors. That is, diuretic effect, we have already discussed that. Then nephroprotection, it increases the erythropoietin level, it decreases left ventricular mass, improved diastolic dysfunction, then reduced vascular stiffness and improves the endothelial function. It also increases the utilization of ketone bodies and hence improve the energy utilization process, especially in the heart. So SGLT2 and DPP4 inhibitor combination is a synergetic and complementary effect, and this leads to less weight and systolic blood pressure reduction, as well as in case of DPP4 it causes weight neutrality, and all of these effects merge to cause reduction of hyperglycemia, as well as quite a beneficial pleiotropic effects are there. And another benefit of this fixed dose combination is that it causes less urinary tract infection compared to if you use SGLT2 alone. So higher efficacy of EMPA-LINA FDC over monotherapies is up to 1.8 to 1.9% reduction in HbA1c, and both cases, that is in drug naive as well as metformin. So early achievement of goal and durability of action, even at 8% baseline HbA1c, only FDC arms could reach target HbA1c, even if they are on metformin background. So combination of EMPA and LINA can reduce the risk of CV risk, including heart failure. So SGLT2 inhibitor with proven CV and HB and heart failure benefits are preferred agents in case with cardiovascular disease, including heart failure. And DPP4 inhibitor has got proven CV and heart failure safety, except saxagliptin, have shown a favorable CV safety profile, including no increased risk of hospitalization due to heart failure. And these two combination may be preferred over other conventional therapies, those which have little CV benefit in case of established CV disease and or heart failure risk. Significant body weight, systolic blood pressure and diastolic blood pressure reduction is present in these combination therapies. As you can see that with EMPA and LINA, in the highest dose it reduces the baseline body weight by about 3 kilo and baseline blood pressure by about 3 to 4 millimeter mercuries, as well as the diastolic blood pressure by 2. And this is the first classic description of the empagliflozin, which shows that it causes early and sustained risk of CV reduction with in patients with type 2 diabetes and atherosclerotic CVD, which is the EMPA-REG outcome study. And just to show you, the benefit is more in case of Asians. In CKD, this combination, that is the EMPA kidney key outcomes trial, that is here 6,600 patients were randomized, 2-year follow-up. eGFR was between 20 to 45. And urine albumin to creatinine ratio of more than 200. And it shows that EMPA alone reduces the CKD by about 13%, hospitalization by more than 4%, and the hospitalization rate was 4%. However, in case of placebo, the hospitalization rate was more, and hospitalization for any cause is obviously less with empagliflozin 10 milligram. And results were consistent in patients with and without diabetes, as my previous colleague has just told you. So in conclusion, among a wide range of patients with CKD who were at risk of progression, empagliflozin therapy led to a lower risk of progression of CKD or death from cardiovascular causes than in case of placebo. And linagliptin was associated with a significant reduction in albuminuria progression. So these two combinations, that is SGLT2 and DPP4, are ideal alliance with no benefit undone. Both of them reduces albuminuria progression, though EMPA more than LINA, but both of them are working in unison, and DPP4 inhibitor is not working against EMPA in any of the other points. So who can benefit from the gliflozin plus LINA combination? So initial combination therapy in patients presenting with high HbA1c, patients with high CV risk and or heart failure risk who have HbA1c 1.5% above the individualized targets, treatment naive patients for whom metformin is contraindicated or who are metformin intolerant and HbA1c is above 8%. Patients uncontrolled on metformin with HbA1c above 8.5% and patients with diabetes and CKD. Lastly, promote weight loss with no increased risk of hypoglycemia. So in summary, poor glycemic control seen across urban and rural India. Monotherapy is often insufficient in these patients and combination therapy should be initiated. Unmet needs in diabetes care for treatment that provide both glycemic and non-glycemic benefits. Beyond glycemic control, EMPA and LINA combination addresses the CV, renal, metabolic aspects of type 2 diabetes also. And EMPA-LINA combination therapy may be pertinent partner to metformin in providing meaningful glycemic control without increasing risk of hypoglycemia and improving the metabolic profile of the patients. And we also have FDC of EMPA-LINA and metformin as well as DAPA, LINA and metformin. Thank you.
Thank you. An excellent deliberation. As I myself consider that DPP4 is our poor man's GLP-1 RA. So a combination like this is very helpful for addressing all of the pertinent risk factors that are associated with diabetes, be it renal or the cardiac, or even EMPA has demonstrated efficacy in NASH caused by diabetes. So now the floor is open to question and we can take 2 or 3 questions.
Okay, sir. So actually there is so many G2 combination in the market. Is already now we are now discussing that is EMPA and LINA combination. Now the DAPA.
No, I'm not discussing only EMPA and LINA. I am discussing both because I started with all.
Yes.
That is gliflozin and DPP4 inhibitor. This is just an example.
Yes. Now my question is that in now the DAPA CETA combination is also in the market. What is your actually experience in as a diabetic segment? So what's the benefit is you get the more than this EMPA-LINA combination?
To be honest with you, I usually start LINA and DAPA in case those who have got some form of renal impairment, because you never know that patient may be lost to follow-up. And here you can give it and forget it type of medicine. So you don't need to monitor their renal function again and again. But if in case of CETA or DAPA, CETA and VILDA, you have to monitor them, because the moment their eGFR reduces below 45, then you have to reduce the dose of VILDA as well as CETA, and when it reduces further, then you have to reduce the dose of CETA further. So that FDC combination, if you think, then the EMPA and LINA will be EMPA-LINA and DAPA-LINA will be better.
Actually, there is in case of EMPA, you can give up to eGFR 20, and in case of DAPA is eGFR
because
45.
They haven't done
there is a
it
combination.
Is simple because the trial they didn't do it. Yes. I don't think there is any mechanistically different thing is there. Because so EMPA came everything first, so they were more bold. Yes. And the other people were not so bold. They didn't take all the severe patients more. They took all the severe patients more. Yes. But heart failure, you can see that DAPA is better than EMPA.
In case of heart failure patient, just I tell you, that is you all know the SGLT2, there is a class effect is there. And now as per G2
it is not class effect, because in heart failure, gliflozin didn't have any effect.
Okay.
So it is not a class effect. Probably most of them has got some heart failure effect, but etrogliflozin didn't.
And now the Vilda combination is also there, is that. And sometimes we know that vildagliptin is also precipitate the heart failure. It will be the rational combination in case of heart failure patient, you can give that patient, or you have to choose other one, that is Lina or
To be honest with you, Lina hasn't got any problem with heart failure.
Yes.
And for means my problem with Vilda is that it should be given twice a day.
Yes.
And as you know, the number of medicine you increase, your patient's fault rate increases. So it is absolutely direct proportion. Yes. So one time they will take, and then the next time they might forget. So in total, you might get worsening HbA1c reduction compared to Lina plus EMPA or DAPA plus CETA.
Yes. Okay. Thank you.
I would like to ask one thing, that from your personal experience, a DAPA-CETA combination or a EMPA-LINA combination, if I take the DPP4 part, which has a better HbA1c reduction, if I exclude the CKD part and the other thing?
It is my personal experience. Do not take it on face value, because there is no evidence that one is better than the other. But personally, I think CETA is a little bit better than Lina. But that is only my experience. It is nothing to do with any evidence.
Sir, here linagliptin, its receptor is extensive from CNS to everywhere.
It is not so powerful. I don't have any answer to that. It's just been shown. To be honest with you, in the trials, both of them had reduction of 0.5 to 0.8.
And is there any adverse?
All DPP4 inhibitors reduces it by 0.4 to 0.5 to 0.8.
That is my question. Okay, thanks.
Sir, we'll be requesting you to kindly take your seat, and we will be requesting our chairperson to felicitate sir with a bouquet of flower followed by a token of appreciation. And I will be requesting the gentlemen present here to put your hands together. And right now I will be requesting Dr. Sujan Sarkar and Dr. Jayant Rana to come and felicitate the chairperson. Yes, the photo is a must. So 5 people together on a single frame. Thank you so much. Moving forward to the next session, I will be requesting our chairperson to come and join us. I will be requesting Dr. Shapturshi Vishnu, and I will be requesting Dr. Jayant Rana to come and join us as chairperson for this session. The speaker for this session will be Dr. Amartya Shankar Chaudhary, MD Medicine, DM Endocrinology, Consultant Endocrinologist, the Mission Hospital, Durgapur, West Bengal. Dr. Neelam Kukreja, Best Postgraduate Award in Medicine 2011, publication in index journals including 3 book chapters, faculty at various regional and national conferences, organizing chairpersons, Endocrine Society of India's Satellite Symposium 2023. So thank you each and everyone for being here, and kindly put your hands together for Dr. Amartya Shankar Chaudhary.
Actually, it's our pleasure. Dr. Amartya Shankar Chaudhary is many times delighted us in Bardhaman and give us their various experience regarding and always, yes, sir, already said that very many times he's giving us, that is, gives us pleasure and very close to us. So please.
Thank you so much for the warm welcome, and it's really, the feeling is mutual. It's really nice to come to Bardhaman in midst of you. I also enjoy coming to here, and I especially enjoy the food, and unfortunately I came late. So I had already had my lunch anyways. So thank you the organizers for having me here, and I'll be speaking on basically NFLD in diabetes, the two sides of the same coin. I'll be dealing some of the aspects on this topic, but mostly I'll be focusing on the various nomenclature, the diagnosis of NFLD, and the brief overview of the treatment of NFLD as such. I'll be trying to cover the most of the spectrum of NFLD as such for from clinical point of view and from practice point of view. Now, why are we discussing so much about NFLD? Liver, ST bede ache, ALT bede ache, thik ache, cholche. So, but the idea about diagnosing NFLD is because of the fact that it is associated with not only diabetes, insulin resistance, obesity, PCOS and as such, but it has been found to have a very close association with future cardiovascular disease, cardiovascular risk factors, as well as progression of the chronic complications of diabetes like CKD, worsening of diabetic retinopathy. So it's very important so that this entity can be diagnosed early, and we initiate mechanisms, maneuvers, therapies so that this can be controlled and we can prevent worsening of the complications. Prevalence is very high, global prevalence around 25%. India, the prevalence is even higher, leading by South India almost 40.1%. East India, thankfully, we are having a little less prevalence of NFLD as far as the studies are concerned. Now, the history of the term of NFLD is something which is very interesting. Now, this was first proposed by Mayo Clinic way back in 1980. So, at that point of time, they were confused about what sort of disease this is. This was something which was very closely related to alcoholic liver disease with a propensity for future development of cirrhosis in absence of significant amount of alcohol intake. And this NFLD term has continued for so many years. This term is, however, very broad and very non-specific, does not exclude many other liver diseases. And recently, with the probably advent of social media, some people are becoming more concerned, more self-esteem. They have found that this fatty word is stigmatizing to some. They don't want the fatty word to be there. I don't drink alcohol, I am neither fatty, but still I have fatty liver. Why should you call me fatty? So there are some things which have led for the last probably 4 or 5 years or so in thinking about newer nomenclature for NFLD. So thus came in 2020, the NFLD was tried to be renamed as MFLD, or metabolic associated fatty liver disease, because of its close association with diabetes, pre-diabetes and other features of metabolic syndrome. So anyone who had a hepatic steatosis of more than equal to 5%, this can be based on either imaging or a biopsy, in association with either presence of type 2 diabetes or patients who are overweight or obese, or in absence of diabetes or obesity, if there is a presence of 2 out of these 7 metabolic abnormalities. Most of these are the parts of the metabolic syndrome, like increased waist circumference, high blood pressure, high triglycerides, low HDL, pre-diabetic state, increased HOMA-IR, increased HSCRP. Any 2 out of these, if it is present, along with more than equal to 5% liver fat, we can diagnose MFLD. Now again, MFLD had some drawbacks or limitations. They did not take into account the excessive alcohol consumptions. Neither did they take into account features of viral hepatitis, other liver diseases or drug-induced liver injury. So again, many experts believe that even this term was flawed. And recently in 2023, a newer terminology has come in which is now called as MASLD, or metabolic dysfunction associated steatotic liver disease, as per ASCL 2023. Almost 236 panelists from 56 countries participated. They felt the earlier terms were flawed. Stigma associated with alcoholic or non-alcoholic or fatty liver was given due consideration, and steatotic liver disease was given a newer name covering the broader spectrum of the disease. So steatotic liver disease associated with cardiometabolic risk factors, which I'll come to in the later slides, gives actually the MSLD or the newer terminology of NFLD. Now this is the broad terminology of steatotic liver disease, which had been divided into one, either MSLD. In presence of alcohol intake, this can be again called as MET-ALD. If the alcohol intake is high, then it is predominantly ALD. If alcohol intake is low, it is predominantly MASLD. then it can be altogether just an alcoholic liver disease, or specific etiologies like drug-induced liver injury and so on. So, this is just what I have told. Then, presence of steatotic liver disease and any one of these 5 cardiometabolic risk factors are needed to diagnose MASLD. Elevated triglycerides, more than 150, again like features of metabolic syndrome. Low HDL, less than 14 males, less than 15 females. Type 2 diabetes, pre-diabetes, obesity and high blood pressure. Now, but NFLD still continues to be the umbrella term. We have not done away with NFLD. It's very easier because we have been more accustomed, and it is a widely used term, and it's very more people are accustomed to in using this term as such to describe any fatty liver disease. So NFLD again is a spectrum of disease which can range from either just a fatty liver or steatosis, where there is no ballooning inflammation of the hepatocyte, or a steatohepatitis or NASH, which actually needs a biopsy to be diagnosed. We have to demonstrate fatty liver with inflammation and hepatocyte ballooning, or a cirrhosis again, which actually again is a biopsy proven diagnosis. Imaging techniques are non-invasive, gives an idea, but actually we need to show increasing fibrosis and extensive fibrosis, periportal fibrosis to really say the patient has undergone cirrhosis. And finally, the end stage of cirrhosis, the hepatocellular carcinoma, which we are really afraid of in these patients of type 2 diabetes or obesity, who really have higher chances of developing hepatocellular carcinoma. Now comes the interesting point, which is the initial event actually which leads to NFLD? Is it the NFLD itself, which is basically an inflammatory state of the liver, which leads to insulin resistance and future diabetes, or already the patient is diabetic, high insulin resistance, which again leads to or precipitates NFLD? That is a big question. Now, NFLD is commonly associated with metabolic conditions like type 2 diabetes, obesity, dyslipidemia, hypertension, PCOS. Same goes for type 2 diabetes. These are the conditions which type 2 diabetes is also associated. So basically, common associations of metabolic diseases are there. And as I've already mentioned, patients with type 2 diabetes can have as high as 70% of cases of type 2 diabetes can have NFLD, and up to 80% even have been reported in some patients. So therefore, if you're treating or coming across a type 2 diabetic patients, you can take it for granted, unless it is proven otherwise, the patient already has NFLD. So and there is actually a meta-analysis of 33 studies where it has been seen that patients with NFLD, there is a 2.2-fold increased risk of incident diabetes. That is, NFLD occurs earlier, and then there is increased risk of developing diabetes in the near future. Now, the exact cause, exact mechanism is yet to be known, but the first causal relationship was initially diagnosed when a persistently high ALT or SGPT was found to predict future development of type 2 diabetes in Pima Indians. Even the Shanghai Changfeng community study also found that the liver fat of more than equal to 10% was associated with increased resistance and insulin resistance and diabetes. And prior to onset of diabetes, sometimes we have seen in a clinical practice, pre-diabetes, slightly overweight, fasting blood glucose is high, nocturnal blood glucose is high. This predicts that the NFLD is basically a predisposing factor which might lead to future diabetes and insulin resistance. Mechanisms not clearly known, but probably the inflamed visceral adipose tissue, which releases various inflammatory cytokines, adipocytokines, hepatokines, may initiate a process which can lead to future diabetes. Briefly about the pathogenesis, we need to know the pathogenesis, then only we can initiate the treatment, and the treatment will be more effective. Now, this is a very complicated slide, try to make it easy. Now, these are the adipocytes, if you can see those. So, these are the adipocytes, basically they are the regions where the stored fat is kept in the form of triglycerides. Now, there are some hormones like adipocyte triglyceride lipase, which breaks down the triglycerides into free fatty acids. We don't want free fatty acids to be excess in the body. Insulin is something which inhibits this hormone, the adipocyte triglyceride lipase. So, in presence of insulin resistance, this hormone is not inhibited, so there is excess of lipolysis from this adipose tissue. That is, that the triglycerides are broken down into excess of free fatty acids. Now, if there is free fatty acids in the blood, where will they go? They will go to the liver cells. So, ultimately there is a flux of free fatty acids in the liver. Now, this is not the only source of free fatty acids in the liver. because of excess consumption of carbohydrates, refined sugars, especially fructose. Sugary drinks have high fructose. These sugars undergo de novo lipogenesis and again produce lot of free fatty acids in the liver. Now, the fate of free fatty acids in healthy state, what happens? If you can see the two pathways which are going down, one is the mitochondrial beta oxidation and the other is the triglycerides. That means in a healthy state, normally these excess free fatty acids undergo beta oxidation, which is a natural biochemical process to provide energy. And the other part, the free fatty acids are esterified to provide triglycerides. Now, when there is excess of free fatty acids, these two pathways are overwhelmed and the rest of the fatty acids are now converted into lipotoxic lipids such as ceramides, diacylglycerols. Now, these are the culprit lipids which cause endoplasmic reticulum stress, oxidative stress, inflammation activation, liberation of lot of unwanted harmful cytokines. Excess of cytokines, inflammation leads to damage, and we are all aware of pathology. Whenever there is a damage, the Kupffer cells or the macrophages come in. Macrophages again liberate more of inflammatory cytokines. Vicious cycle continues. These inflammatory cytokines again cause further increase in insulin resistance, and all the cycle continues. Further activation leads to activation of hepatic stellate cells, which again deposit collagen. Ultimately, there is tissue repair, collagen deposition, and which progresses to fibrosis. So, this in a nutshell what happens in a fatty liver disease. With increasing insulin resistance, there is hyperinsulinemia, which again increases the de novo lipogenesis, further free fatty acid, and the presence of insulin resistance, again there is excess of breakdown. So, ultimately lot of free fatty acids which are unwanted and which are harmful are moving around in the body. Now, coming to the other side, the patients who are type 2 diabetes, again it has been seen that the NFLD progression is very rapid, very severe. In this multi-center prospective study, it was seen that over a period of 12 years, 73% higher risk of fibrosis progression was seen in type 2 diabetes. So, in absence of alcohol intake, this is just the crux of the problem, is that anybody who has fatty liver, uncontrolled diabetes, obesity has very high chance of progressing into cirrhosis and hepatocellular carcinoma. So, this you can see the normal spectrum, the natural course where NFLD goes into NASH, then cirrhosis, then hepatocellular carcinoma, and this entire process is significantly aggravated in patients with or people with type 2 diabetes. Now, the duration of diabetes is again something which is very important. A landmark analysis show longer the duration of diabetes, more was severe was the liver related events and more was the all cause severe mortality. So, it is not just cirrhosis we are dealing with, but we are dealing with excessive rise or high rise of cardiovascular disease and all cause mortality, and this is where the crux of problem lies. Everything ultimately boils down to the heart, and there is the significantly increased association of cardiovascular events have been noted with patients with MFLD. Now, given this strong association, some researchers claim that NFLD is just an overlooked complication of diabetes, is not a single different entity at all, coexist together. Treatment is almost similar to how we treat type 2 diabetes. Now, coming to screening part, I won't go into details, just briefly whom to screen. Now, this is the addendum which was added earlier this year in 2023 by ADA. All patients with type 2 diabetes, pre-diabetes, overweight or obese, those who have cardiovascular risk factors or established cardiovascular risk factors should be screened for NFLD even if the liver enzymes are normal. So, this is something which the ADA has come up with. Adults or pre-diabetes, and the screening involves a very simple tool which I will come to it. It is a FIB-4 calculation, and people with diabetes who has a persistently elevated ALT and the FIB-4 is low, then he should be evaluated for other liver disease. If FIB-4 is high, we go into next set of tests which again I will be discussing later, and in those who have intermediate or high risk, they should be referred to hepatologists or gastroenterologists for further evaluation. Even the AAC guidelines 2022 recommend that even in absence of diabetes, everyone who is overweight, anybody who is obese, having features of metabolic syndrome or elevated liver enzymes should be evaluated for NFLD, and the treatment procedure should be initiated. FIB-4 is actually a very easy calculation. Lot of apps are available. Just open Google, type FIB-4. 4 parameters are just needed: age, AST, LT, and platelet count, and the result will immediately come out. You just have to know 2 cutoffs: 1.3, below 1.3 is everything is fine, 2.67, more than 2.67 there is a high probability of fibrosis, and in between is intermediate, and both intermediate and high probability of fibrosis needs a second test, which is basically a transient elastography or a vibration controlled transient elastography. So this measures actually the liver stiffness and the controlled attenuation parameter. The CAP score suggests high amount of liver fat, and the LSM score suggests high amount of liver fibrosis. So this is in the nutshell the evaluation algorithm. Initially identify the patients who need to be screened, go for FIB4 estimation, FIB4 less than 1.3 low risk, just follow up. FIB4 more than 2.67 high risk, in between is intermediate. Both intermediate and high risk go for liver stiffness measurement or ELF tests. Again, those who identified as intermediate and high risk should be referred to hepatologists and gastroenterologists for further evaluation. People with type 2 diabetes, more than 50 years, higher BMI, more metabolic risk factors, some genetic risk factors are at higher risk of progressing into cirrhosis, and these group of people definitely need close attention and follow up. Management, briefly about the overview. Most importantly is lifestyle. Diet control, weight reduction have a significant role to play in patients with NFLD. Not enough drugs. Yes, we have some approved drugs, but not enough drugs, and therefore we give a lot of stress on lifestyle modification. Managing comorbid conditions, and some pharmacotherapy and bariatric surgery in those which is indicated, like in obese patients. Now coming to the two sides of the coin, as we have seen, both these, one is that probably NFLD begets type 2 diabetes, again type 2 diabetes leads to excessive or aggravated progression of the disease process. Now if you again see the treatment part or the management part, all the maneuvers which target insulin resistance while treating type 2 diabetes again are beneficial in the treatment of NFLD. Now among the lifestyle treatment options, dietary reductions, Mediterranean diet, hypocaloric diet, around 500 to 750 kilocalorie per day energy deficit have been seen to be beneficial in these patients. Lot of fibers, low in saturated fat, low in refined carbohydrates. Interestingly, coffee there are some observational studies where drinking of coffee without sugar definitely has been linked to somewhat reduction in NFLD, but we do not have large robust studies to really come to a conclusion. Now weight loss, as I have told you, even a 3%, more than equal to 3% weight loss, so somebody who is 90 kg or 100 kg, even if it comes down to 97, there is a steatosis improvement, but we should promote at least a 10% weight loss, because more than equal to 10% weight loss have been shown to reduce fibrosis. A fibrosis regression was seen in 45% of patients. Now the problem is in weight loss is that it has to be sustained. एक साल exercise किया छोड़ दिया is no good, no harm, no improvement. It has been sustained, and it has been, the studies have shown that only around less than 10% have a sustained weight loss after 1 year, and therefore all the benefits which was previously experienced was lost. So sustained weight loss is something which we have to motivate the patients, and therefore it has shown significant improvement. Now coming to pharmacotherapy, pioglitazone is one diabetic drug which is probably the earliest, one of the earliest drug to have shown good benefits in reducing steatosis, inflammation, ballooning, but no significant improvement in fibrosis. But again, pioglitazone has to be cautiously used. There are some relative contraindications or contraindications in the uses of pioglitazone, which the risk benefit has to be seen. Type 2 diabetes, in those patients where it can be given, it is definitely a useful choice. Now as I have seen in the addendum of 2023, recently pioglitazones and GLP receptor 1 agonist with demonstrated benefits have been approved in patients or people with type 2 diabetes with proven, biopsy proven NASH or NFLD in the treatment of type 2 diabetes. GLP-1 receptor agonists like injectable weekly semaglutide, liraglutide, tirzepatide have shown definite benefits. But again, each has its own advantages, disadvantages. GLP is costly. Pioglitazone has its own side effects, which I won't go into the details now. So it have to be individualized, and it has to be chosen carefully. Now coming to the Indian treatment or Indian molecule, the saroglitazar. Saroglitazar has been approved for NFLD in India basically the only approved therapy for atherosclerotic diabetic dyslipidemia and NFLD in India is saroglitazar. This has been there. Now, the PPAR, it's basically a PPAR alpha and gamma dual agonist. The PPAR alpha is found in liver, kidney, heart muscle, and it is implicated in the uptake and oxidation of fatty acids and lipoprotein metabolism. So, as I have mentioned in the pathogenesis, the normal fatty acids undergo beta oxidation. So, increase in fatty acid oxidation, the pathway is moved towards that pathway, so that less harmful lipotoxic lipids are generated. It also reduces, improves the atherosclerotic or atherogenic dyslipidemia, diabetic dyslipidemia, decrease in triglycerides, improvement of HDL, more importantly has anti-inflammatory action. The PPAR gamma is basically expressed in adipose tissue with beneficial effects on glucose homeostasis by increasing insulin sensitivity and glucose disposal, prevent beta cell mass in pancreas, some of the studies have shown, and again an anti-inflammatory action. So, dual PPAR alpha gamma is a mechanism of action by which saroglitazar works and is being approved. Lot of small and large studies, mostly Indian studies, which have been done. This is one phase 3 biopsy proven data from India, where the patients were followed up for around 52 weeks, and it was observed that the NFLD activity score of more than equal to 2 was reduced in 52% of patients without worsening of fibrosis at week 52, and this made the Indian guideline INASL 2023 recommendation to continue saroglitazar for at least 12 months in patients where treatment of NFLD is initiated. Now, this is one of the latest addition to the drug armamentarium, resmetirom. This has received quite very good reception from the FDA, due to be probably available in 2024. Basically a THR beta agonist, again improves the beta cell oxidation or drives the excess of free fatty acid in the beta cell pathway, beta cell oxidation pathway, and thereby improving the liver histology. This is one of the latest study which has been published in clinical medicine, which I just come across and wanted to share. This is something which is interesting. This is basically a retrospective cohort study or retrospective observational study in Taiwan database of more than around 33,000 patients. These patients, those patients who have been receiving aspirin or ecosprin, whatever, for a long period of time, especially for more than 3 years, there is a significant reduction has been seen in hepatocellular carcinoma. Now, this is again something which is very important, even though HCC, the incidence is not significantly high, we are not coming across, but yes, the risk remains, and this is something which we can consider, still not in the guidelines, but yes, it needs, it can be given a due thought, especially when considering a wholesome treatment of NFLD, especially in type 2 diabetes. Then there are other drugs. Metformin is one drug probably you are using in all patients with type 2 diabetes, but metformin, the meta-analysis have shown there is no significant reduction in steatosis, ballooning or fibrosis reduction. With just a few kgs of weight loss, some studies had shown there is a reduction in steatohepatosis, but the most important part about metformin is that those patients or those people with type 2 diabetes and NFLD who have been given metformin for a long period of time, there is a 50% reduction in the incidence of hepatocellular carcinoma, which is again very significant. No reduction or not much benefit in NFLD, but definite reduction in hepatocellular carcinoma as such. Now, there are a lot of other drugs in the pipeline. Obeticholic acid has already been launched, but there are definite side effects, some cholestatic jaundice and other adverse effects for which the use has been limited, and the recent trials have shown not significant benefit overall in NASH resolution. Then we have cilofexor, tropifexor, the farneside X receptor agonist. Elafibranor is again a PPAR alpha delta. We have PPAR alpha gamma delta. Elafibranor again is a PPAR alpha delta agonist which is being studied. Lanifibranor is a pan PPAR agonist, alpha delta gamma agonist, which is again there. And we already have studies with GLP-1 receptor agonist, definitely a very useful molecule in patients with type 2 diabetes, obesity, overweight with NFLD. So finally, to summarize, it is definitely the prevalence is very high in India, and assessment of NFLD screening is very important. FIB4 is a very easy and useful screening index to be, which is available, can be an OPD, very useful in OPD practice. lifestyle modification is definitely the key and the first line therapy. And we have drugs. In India, we have saroglitazole that is being approved. ADI has approved pioglitazone on GLP-1 receptor agonist in people with type 2 diabetes. And we need to identify these patients early and initiate therapy early so that we can prevent the complications of type 2 diabetes and NFLD. Now, coming back to the title of the slide, whether it is the two sides of the coin. Now, the friendship between type 2 diabetes and NFLD is unholy and it's unwanted, it's harmful for us. And if you can remember Sholay, the Amitabh Bachchan's coin, the both sides of the coin were same, both it was not different. So basically we are not dealing with any different entities, but only one large broad entity which we are dealing with, and we have to carefully identify these patients, initiate treatment early on so that we can prevent the long-term complications and provide a good quality of life to our patients. Thank you so much for your kind and patient hearing. Thank you.
Thank you. As usual, Dr. Amartya Shankar Chaudhary is enriched us, and I request to House, there is any question regarding NFLD and
মাঝে মাঝে এক্স-রে ইউএসজি ভাষায় পাঠানো হয় গ্রেড 1 গ্রেড 2 গ্রেড 3 এটা কি এটা দিয়ে কি বুঝবো?
Basically the imaging are just a screening of showing that there is, as I have said, there should be a minimum of more than equal to 5% hepatic steatosis along with other risk factors which I have mentioned to say that patient is having a fatty liver disease. If on imaging, whatever be the grade 1 or grade 2 by the imaging we have to go for the next, the most sensitive screening index, that is the FIB-4, and then a much better test which is basically even better than ultrasound. It will be a transient elastography which can identify the LSM score and the CAP score. The CAP score is useful for identifying the liver fat content, and LSM score will give us the whether the patient is having fibrosis. মানে ওটা জাস্ট একটা স্ক্রিনিং টুল হিসাবে নিয়ে ওটা যদি আছে দেন we should calculate the FIB-4 AST/LT দেখে platelet and age-টা calculate করে, and then we should proceed further.
আমাদের এত বড় বর্ধমানে ফাইব্রোস্ক্যান নেয়
না, at least FIB-4 ফাইব্রোস্ক্যান আসে, ফাইব্রোস্ক্যান দুর্গাপুরেও নেই, মানে they usually come from Kolkata. Clinically basically any patients with type 2 diabetes, pre-diabetes, overweight, high ALT for a long period of time, they need to be screened for NFLD. And the easiest screening tool, কোনো imaging কিছু দরকার নেই, ইন্টারনেট দরকার, মোবাইল বা ল্যাপটপ দরকার, FIB-4 স্কোর, FIB-4 স্কোর লিখে জাস্ট কি বসাতে হবে বক্সগুলো চলে আসবে, AST, ALT, platelet, age, এই কটা জাস্ট প্যারামিটার্স যদি বসানো হয় then you'll get the score. At least you'll get an idea fatty liver আছে নেই বা NFLD আছে নেই. Even if there is the AST, LTs are high for a pretty long time, more than 6 months, and the FIB-4 is less than 1.3, then the patient needs to be sent to a gastroenterologist or hepatologist to identify other causes of liver disease.
অনেক সময় দেখা যায় নরমাল ওয়েটও ফ্যাটি লিভার গ্রেড 1 গ্রেড 2 করে পাঠাচ্ছে, তাহলে সেই ক্ষেত্রে কি
হ্যাঁ, so this is again something very important. We have seen some lean type 2 diabetic patients. Basically again we Indians are thin fat Indians, আমাদের abdominal adiposity টা বেশি, the visceral adipose tissue, again that is something which is harmful and that is related to, strongly related to fatty liver, NFLD. And again there are some genetic phenotype correlations. কিছু genetic phenotype আছে যেরকম PNPLA3, then we have TM6SF2, কিছু এত মনে থাকে না, but those are some genetic variants where even the strong association with NFLD, even in absence of diabetes, they have these genotypes have been shown that the insulin sensitivity is even being preserved. They do not have diabetes, but they have significantly high NFLD and high propensity to progress into cirrhosis.
Thank you.
Dr. Chaudhary. Dr. Chaudhary, wonderful talk. I have rarely come across such a wonderful exposition on fatty liver and diabetes. even in gastroenterology circles. Thank you so much. I cannot emphasize more what you said about FIB4. It is the cheapest thing in the market. Exactly. It is even available in all those Medex Plus, all those apps have got FIB4, and এটা কিছুই লাগে না, মানে কোনো খরচই নেই। পেশেন্ট যখন আমাদের কাছে আসে একটা এলএফটি অলরেডি আছে, একটা সিবিসি অলরেডি আছে, পেশেন্টের এজ আমরা জেনে যাচ্ছি। সো ইটস মানে it's as good as measuring your blood pressure. It takes less time to calculate than measuring your blood pressure even. So FIB4 is something that we should take home from sir's talk today, that we should incorporate it in our daily practice. And so just I had one question for you. Now it is seen that achieving the 10% weight loss is actually very difficult. So we are happy if there is at least a 5% weight loss, because 5% weight loss will correspond to the normalization of the ALT or AST. So what is the target weight loss you would want for your diabetes?
So in basically even in diabetes, as I have said, two sides of the coin or one side of the same coin, whatever we are advising for our obese type 2 diabetes holds good and holds true for treatment of NFLD. So dietary approach, exercise and lifestyle changes definitely is the mainstay of therapy, because we have very limited drugs, and the drugs which we have apart from saroglitazone, which is widely available in the country, pioglitazone has its own benefits and demerits. GLP-1 is very expensive. Other than that, we do not have any established and approved therapy. So definitely we have to give a lot of stress on weight loss. So any diabetic patients who come to us who are obese or obesity, we ask to go for at least a 7 to 10% of weight reduction. 15% in new onset diabetes, there are studies which have shown there are 15% weight reduction. These diabetic patients, or people with diabetes, rather is a terminology to avoid stigmatizing them. In people with type 2 diabetes, these patients can go into diabetic remission. So the concept behind what you have said is absolutely true. Even a 5% weight loss has been shown to in reduction in ballooning, hepatocyte ballooning, which can go a long way. But definitely we should motivate and promote and push for at least a 10% of weight reduction, because this has shown at least a fibrosis reduction by 45%. And if the patient can maintain a 10% weight reduction, there is probably very less chance of progressing into cirrhosis and hepatocellular carcinoma. So when we actually, it's all about how we talk about the disease. When a patient comes to us, or when they go to an oncologist, the perspective is something which is very different. ক্যান্সারের কাছে গেছি, যা বলেছে তা সত্যি, আজকেই স্মোকিং ছাড়লাম, আজকেই টবেকো ছাড়লাম। ডায়াবেটিস হ্যাঁ চলবে, হবে, এই তো আবার আসবো ডাক্তার কাছে, আবার ঠিক করে দেবে, এই পুজো গেল, এই মিষ্টি খেলাম, এই খেলাম। So we need to be very proactive in explaining that you have this problem, this will lead to heart attack, this will lead to cancer in the future. Now you decide whether you want to reduce your body weight, you do not want to reduce your weight. So there are sometimes we have to take the lead, sometimes we have to, be the evil, we have to play the evil side. We don't, the unwanted things or wanted phrases, sometimes we have to choose for the benefit of our patients.
Okay, in my lab, Dr. Saptoshi is now in Bardhaman, is a renowned gastroenterologist. He's come, his time to us from the house. I am requesting to give some experience regarding this topic. Already said, already discussed. He obviously, from the gastroenterology view, anything enrich us to us, that will be very encouraging to us.
Thank you, sir. I will start with sir's question, that people are coming with grade 1 fatty liver and grade 2 fatty liver. The jeta confusion ta hoy, people will come and say, sir, last year I had grade 1, this year I have got grade 2. So, amar ki kharap holo? Well, last year I had got grade 3, now I have got grade 2. So, this is a misconception. Basically, ultrasound grade 1 and grade 2 has got to do with the sonological appearance, with the echogenicity. Now, একটা echo machine and echogenicity, Ananda will be able to espouse it much better, can depend on so many things, gain, frequency, depth, so many settings. আপনি যাকে গ্রেড 1 দেখলেন, একটু যদি সেটিংটা চেঞ্জ করে দেওয়া যায় আর ভেতরের জিনিসগুলো দেখা যাবে না, so it will appear as grade 2. So it is very much operator dependent and it is not reproducible. You can show it grade 1, the same patient will go to someone, it will show as grade 2. সুতরাং only the word fatty liver in ultrasound is important. The grade 1 and grade 2 is not important at all. what is important is what damage the fatty liver has done to the, that fatty liver has brought upon the liver, the biochemical damage, the fibrotic damage, and the damage accumulated by the associated comorbidities. So this is important. Grade 1 and grade 2 are not indications for therapy. The damage to the liver and the damage to the other end organs is very important. And regarding fibroscan, we do have transient elastographies, we do have shear wave elastographies like ultrasound elastographies also in Bardhaman. And a new modality has come up which is called MR elastography. MR elastography is a very sensitive measure, and it has already come in Kolkata. It is fantastically expensive. The machine is expensive, but it is available in a number of centers in Kolkata, whereby a special driver, a plastic driver, it is put on the patient's abdomen, and it sort of gives an oscillation of the shear wave, pressure wave, which travels throughout the liver, and the MRI machine captures an image of the shear wave. Now, more fibrosis, the more will be the velocity of the shear wave. So a map is made like, so that it gives you an entire 2D and 3D idea about the distribution of fat and distribution of fibrosis in the liver. So this is a newer methodology which has come. Obviously, it is not available to us right now, but in the future, we are going to get patients who are coming with reports of MR elastography, I'm sure. So I think that day is near enough.
What is the SGOT and SGPT level in the Indian patients? Normal?
Actually, there is a landmark analysis which Dr. Saptoshi will be agreeing. So the landmark analysis, it used a very strict cutoff. For males it was 25, for females it was 19 upper limit. Now considering other studies and associated results, the American College of Gastroenterology has said for males the upper limit is 33 and females it is 25. It is not that 40, 45 we see in the reports. It is actually males having an SGPT of more than 33 and females having an SGPT of more than 25. They are people who fall into the category who need to be screened.
It's the Indian data I am talking about. Because the waist ratio is quite different from the western part. Same. Another thing is that what about the infiltration in the other organs? Pancreatic fatty infiltration we often come across, and liver, kidney infiltration with fat.
Sir, I don't know about the kidney much, but fatty pancreas, that report we get, it's good for my business, but I get a lot of referrals for that. But actually, if you correlate it in terms of MRI, if you do MR, that same patient who has got an MRI PDFF proton density fat fraction, which is a very sensitive method to pick up fat. So if you do MRI PDFF for that patient, you will hardly ever find fat in the pancreas. And even in biopsy studies, autopsy studies for these patients, fat has rarely been found in the pancreas. So fatty pancreas is an urban myth. I'm sorry to say, fatty pancreas is an urban myth. We can straight away neglect fatty pancreas, because if you look into the basic pathology books, like if you go back to your Robbins pathology books, you will never find a heading or a chapter called fatty pancreas. So I think what happens in radiology circles is that because of the overlying gas, because pancreas is a retroperitoneal organ, it is lying just above the vertebral column. So there is a lot of gas artifacts and a lot of bone artifacts there, reflection artifacts. So I think it sort of tends to create that effect where the pancreas appears a little more hyperechoic. So I think this has been just like transposed, this idea of fatty liver being hyperechoic, it has been transposed by radiologists to understand the hyperechoic pancreas is a fatty pancreas. It does not have any clinical implication or clinical basis. Sir.
What?
I just want to put a comment over it. First of all, a fatty liver, fatty pancreas, এগুলো সবই observational. Okay? So what যেটা বললো, observer defect থাকতেই পারে। ইকোজেনিসিটির স্ট্যান্ডার্ডটা হচ্ছে রিনাল কর্টেক্স। হ্যাঁ, আমরা জেনারেলি কম্পেয়ার করি রাইট রিনাল কর্টেক্সের ইকোজেনিসিটির সাথে লিভারটা, আর দেয়ার বাই গ্রেড 1 গ্রেড 2টা করে, বাট স্ট্যান্ডার্ড রেডিওলজির টেক্সট বইয়ে কিন্তু এই গ্রেডটা নেই। ইট ইজ অনলি ইন সাম ওই মানে ইন্টারনেট ডেটার থেকেই এটা মেনলি কালেক্ট করা। ট্রুলি অবজারভেশনাল, কিচ্ছু নেই। আর আরেকটা তুষারদার কোয়েশ্চেন, শিয়ার ওয়েভ ইলাস্টোগ্রাফি যেটা ইউএসজিতে করা যায়, মানে ইউএসজি সফটওয়্যারটা আছে, সেটা কিন্তু আমরা বর্ধমান মেডিকেল কলেজেও এনেছি। কাজী বর্ধমান মেডিকেল কলেজের রেডিওলজি ডিপার্টমেন্ট শিয়ার ওয়েভ ইলাস্টোগ্রাফি হয়। আর এমআর ইলাস্টোগ্রাফি যেটাও বললো কথা চলছে, এখনও আসেনি, এটা অনেক কস্টলি এফেক্ট, কিন্তু আমরা চেষ্টা করছি ওটাও আমাদের ইয়েতে আনার।
Dr. Chaudhary, one more question. Is there any correlation? We are coming across a lot of MODI patients. MODI. And is there any correlation between HFN positive MODI and this NFLD? Is there any data on this?
No, as far as my, I'm not aware, I have to look. Type 1 diabetes, yes, because we are seeing a lot of even pediatric cases of NFLD. Even type 1 diabetes, around 1/3 population is obese. They definitely have, and the NFLD goes as high as 22% prevalence. MODI, I'm sorry, I have to look. I'm not sure.
One more thing, I think bedside clinics is now most of the time neglected. Can there be any correlation between this filling the surface or filling the edge of the liver, and the surface of the liver is equally important in the fifth four score? You can incorporate. What is your take?
Yeah, this is something again. This has gone down drastically. We see people in chairs, and sometimes if it is a reclining chair, sometimes we can palpate the liver. All these things have really been something which is we should be ashamed, and probably all of us needs to be blamed. Rarely someone makes the patient go up to the bed and palpates the abdomen. But definitely the liver palpation and the age of the liver, which has been taught in clinical medicine, has a long way, I mean very important, especially when the patient has become cirrhotic and it progresses to the advanced stages of hepatocellular carcinoma.
So I think there is I mean this is unpublished, there's nothing, this is just anecdotal personal experience. I think palpation of the liver will not give you very much information about the amount of fibrosis, because mostly it is associated with a thick subcutaneous fat. You are not likely to palpate the liver very closely or get a good idea. So mostly in obese NASH patients, I hardly palpate the liver. I get to feel the liver or much less appreciate its surface or its margin.
Most of the diabetic patients are lean and thin. That's why my question is that can bedside clinic can do something in follow-up these patients? Lean and thin patients, diabetic patients, so look at the liver age. Sometimes it is now from smooth to it is turning towards sharp. It's a bad prognosis.
So I think it will be fraught with personal bias and inter-observer. I think it won't be a very, it is not going to be a very accurate methodology.
Right, thank you.
Okay. Okay, thank you. To conclude the session, because there is now the felicitation will be started.
Yes, I will be requesting our chairperson to felicitate Dr. Amartya Shankar Chaudhary, please, with a bouquet of flower and a token of appreciation. And similarly, I will be requesting Dr. Arnav Banerjee and Dr. Shujan Sarkar to come and join us on the stage to felicitate the chairperson present here. I will be requesting 5 of you to come and join us for a picture, and we will be felicitating the chairperson. Thank you, sir. Thank you for being here. And yes, the next speaker, and most probably the last speaker of this session, is Dr. Shubir Roy, MD, MRCP UK, FRCP Edinburgh. The present designation is a Senior Consultant Physician and Adjunct Associate Professor. Present affiliations, Department of Medicine, Division of Diabetes and Endocrinology, Apollo Hospital, Kolkata, India. With publications in more than 30 publications in peer-reviewed journals including Nature, Lancet, BMG, JAMA, Diabetic Medicine and DRCP. But before that, I would like to call upon the chairperson for this session, Dr. Arnav Banerjee and Dr. Sujan Sarkar. So please come and join us as a chairperson, Dr. Arnav Banerjee as well as Dr. Sujan Sarkar. I will be requesting you both to come and join us as a chairperson. And right now I will be requesting our speaker, Dr. Shubir Rai, to come and join us. Please, ladies and gentlemen, put up your hands together.
Thank you very much for your kind introduction. Thanks for inviting me. This is my city, my birthplace. So it's always a pleasure to be here with you guys. Most of you are either my seniors in the school or my juniors in the school. Can't you hear me? I guess you can. Yeah, it's a small room. So, I mean, right. So today I'm going to talk about insulin 2GO, U300 glargine for the next 30 minutes. I've got around 30 slides with me. And I'll be touching upon these areas. I will talk about the right balance of efficacy with low risk of hypoglycemia, particularly in the initial time of diabetes initiation, insulin initiation. I'll talk about the risk of nocturnal hypoglycemia, the lower risk of hypoglycemia in high risk population, a comparative study of efficacy vis-a-vis risk with premix insulin and co-formulation, the flexibility of insulin 2GO, and the beauty of the latest Gen 2 basal insulin U300 glargine. So why did we need U300 glargine? What was wrong with the previous one? So if you just go down the timeline, around 75, 78 years back, we had our first so-called prolonged insulin. I mean, I'm not talking about lenti or ultra lenti or semi-lenti kind of thing, because those are out. So NPH was the first, to some extent, basal insulin. Then we had to wait for another 50 years before we got the first true gold standard basal insulin in the form of insulin U100 glargine. Then after a few more years, we had insulin detamine, you know the name, Levemir. And then again, after 15-20 years, we had back-to-back appearance of two Gen 2 basal insulins, that is insulin degludec followed by insulin U300 glargine. So if you look at the comparative graph down, I can see that NPH had a prominent bump and it did not work for more than 10-12 hours. Insulin detamine was slightly flatter than NPH, but again it fell short by its time duration. It was not more than 15-16 hours duration. Insulin degludec and insulin U300 glargine is prolonged insulin, a true basal insulin, and much flatter in comparison to even a gold standard insulin called insulin glargine U100. So what was the difference between U100 and U300 glargine? It's a concentration. U300 glargine is 3 times more concentrated than insulin U100 glargine. So naturally, when something becomes more concentrated, the volume goes down. And if the volume goes down, that overall surface, the surface area goes down. If the surface area goes down, the absorption gets slower and prolonged. So that made the difference in the PK and PD of insulin 300 glargine. So if you look at what has this brought on board, have we got anything new? Yes, we have. If you look at from the patient's perspective, because having science is not the ultimate thing. Using science in a very a realistic way is called art of practicing medicine. So if you look at from the patient's perspective or the patient's area, we've got one insulin which is actually full day covering insulin, okay? Because if you are not a diabetologist and if you are asking for a flat basal insulin, what would you be asking for? Yeah, dada eta shara din cover korbe to. Is it going to give us full 24 hours cover? Yes, this is one insulin which gives you more than 24 hours covers, or at least 24 hours covers, because the long half-life, okay? So the patient, if the patient is getting a basal insulin only, you are just giving one injection. In NPH insulin or even in detamine insulin, you are ending up giving 2 injections. Even in glargine U100 insulin, in some situations, if the patient is very, very insulinopenic, you probably cannot cover 24 hours with one flat basal insulin, because it is probably not exactly 24 hours long. It is probably around 20 to 23 hours long. So there is 1 hour gap, and many times you will see blood sugar going up. Particularly it happens when you are using glargine U100 insulin in type 1 diabetes patient. It is not so prominent in type 2 diabetes patients because you are using other oral hypoglycemic agents which can cover the window. Okay, so the patient is getting a flat true basal coverage. The patient is getting 1 injection a day. So naturally the patient tends to be more adherent, more compliant. And if the patient is more compliant, what goes down is complication. Okay, so if a patient is taking the insulin regularly, the patient tends to take it, the patient tends to have less complications, and if the patient is having less complications, the cost goes down. So whatever we discuss about the cost of any insulin whatsoever is absolutely related to the complication. So if our insulin is making the patient more compliant, bringing the complications down, the patient will benefit immensely by cutting down the hospitalization cost of hypoglycemia and the complications related to hospitalization. So we have to think about it, okay? So the patient gets less hypoglycemia. Why? Because the flat insulin, I'll show you the PK/PD. And it gives the patient slightly less weight gain. I'm not saying this is a huge difference, but even half a kilo weight gain, less weight gain is immensely important. So altogether, the patients tend to become happy. Many times we tend to forget the happiness quotient of the patient. We all try science for the benefit of the patient, but while trying hardcore science, many times we forget about the person sitting in front of us. The quality of life goes down because the doctor is not trying too hard to push science down the patient's throat. Okay, so we have to think about the happiness of the patient, the quality of life. So if a patient gets 1 insulin, which is flat, doesn't give too much hypoglycemia, less fluctuation, can be taken once in a day, gives good glycemic control, decent control, the doctor becomes happy. Every time the patient comes back, the doctor says, "Bhalo korechen, khub sundor hoyeche, age che better." The patient gets a feeling that I'm winning the race. This is a lifelong battle. Diabetes is not a pneumonia treatment. It's a lifelong battle. We have to get the patients in the happy zone. Otherwise, you cannot drag the patient along. Okay, so this insulin, this Gen 2 basal insulin, brings that happiness quotient on board. Now, if you look at from the doctor's perspective, okay, from the scientific angle, what do we get? We get less, we get stable and prolonged PK/PD compared to the previous so-called gold standard U100 glargine from the same stable. Okay, so when I'm talking about 2G, I cannot probably pin down U100 glargine because U100 glargine is the elder brother of the U300 glargine. It is the same insulin in a concentrated, in a better form. You get the dosing flexibility of few hours. Okay, 3 hours this way, 3 hours that way. So you have a 6 hours window. Many times it makes huge difference because the patient says that, "Dr. Babu, আমি তো সেলসম্যানের কাজ করি, আমার রাত্রে কোনোদিন আমি ফিরি 12টার সময়, কোনোদিন ফিরি 9টার সময়, যেদিন যেমন কাজ থাকে, কি করে আমি রাত্রে 10টার সময় রোজ নেব ইনজেকশনটা?" So that flexibility is important for the patient. Okay, so U300 glargine gives you that extra flexibility which you could not offer with glargine. Okay, Lantus insulin, U100 glargine. Less weight gain. Majority of our type 2 diabetes patients are obese or overweight. They are actually struggling Well, we've been talking about this weight gain, 5% weight gain and 10%, 5% weight loss and 10% weight loss. I'm working on obesity front. I know how tough it is. I know that 90% of the patients, even those patients who can lose weight of 10%, will regain them back in 5 years down the line. That's why I'm working on semaglutide and cagrilintide. Okay, so this is a very tough area. So any less weight gain is welcome. The pain is beautiful pain. It can't be messed. Okay, many times you'll see that one insulin being pushed by other pens. It's like you're using the wheel of a Tata car in Maruti Suzuki, which is non-compatible. So you have to have absolutely separate pain. And since it is given free by the company, the patient doesn't have to pay any extra. So that pain is added advantage. And the hypoglycemia area, this insulin gives you less hypoglycemia when it matters. In the daytime, if the patient gets hypoglycemia, it's manageable. If the patient gets hypoglycemia at night, it is less manageable because most of the family members are actually sleeping. Many times the patient is elderly, the patient cannot really walk to the kitchen and have something. Okay, so nocturnal hypoglycemia must be avoided by all means, particularly in elderly patients, but particularly in vulnerable population like renal failure patients. Okay, so this insulin brings all those scientific things on board. So from the patient's perspective, it is a good insulin. From the doctor's perspective, it is a good insulin. Which of you want to have a phone call at 2 a.m. at night? Amar babar na doctor sugar ta kome geche ki kori bolun dekhi. We hate that. Okay, so you want one insulin which gives you less hypoglycemia. Okay, not only that, you are trying to avoid the unnecessary phone calls. You just want to make the patient's ride less topsy-turvy. Okay, we all want, insulin is just a vehicle. It brings the patient to the destination, and you want the ride to be smooth, not bumpy. So any insulin that gives you less bumpy ride is a great insulin from my perspective. Any evidence? Ato lomba chora kotha bolchi kisher upore base kore bolchi. There are plenty of evidence. Okay, and this evidence is generated by putting this molecule against the best in the business. Okay, so if you want to know which one is a better batsman, Sachin Tendulkar or Virat Kohli, you cannot compare because they belong to two different eras. They did not play against each other. Okay, so this molecule has been played against the best in the business. That's the U100 glargine. It's been pitted against insulin deglutide, which is another, say, Brian Lara versus Sachin Tendulkar kind of thing. It's another great insulin. And it's been pitted against premix insulin to see efficacy, safety, other issues. So we've got plethora of evidence coming in. Okay, and the PKPD again is against U100 glargine. We have got the real life evidence, because many times you can question that, oh, ota to trial hoychilo. Trial e to shobi apnara ঠিক ঠিক করে করেন, কিছু এদিক ওদিক যায় না। আমরা প্র্যাকটিস করার সময় এই দেখি, no, we have got real world evidence as well, and I was a part of that study, ATO study. Okay, so we have got the evidence coming from type 1 diabetes patients, type 2 diabetes patients, elderly patients, renal failure patients, and we have got the other PKPD trial as well as we have got the head-to-head competitive study against insulin deglutide, which is called BRIGHT study. I'll touch upon all those things. And we are getting more and more evidence about the newer concept of the diabetes, hyperglycemia management, that is time in range. You all know about this time in range nowadays. We do not depend on fasting sugar, PP sugar, HbA1c anymore. That gives you a three-dimensional thing. Now we've got the fourth dimension, that is time in range. More time you spend in a certain range, 70 to 180, you are better off, you are more towards the target, ideal target. Okay, so this is a PKPD. If you look at this is against insulin U100 glargine lantus. Okay, and you can see the difference. U300 glargine is much flatter and much prolonged. Okay, so you do not get even the slightest peak which you get in lantus. Many times if you give lantus at midnight, you might get a small hypoglycemic blip around 4 o'clock in the morning, because it reaches the peak around 6 to 8 hours after the injections. Okay, if you give NPH insulin, you get the peak after 3 to 4 hours of the injections. Glargine U100 is a better insulin, much better than U100 NPH, but it is not a true 100% flat insulin. It gives you a small peak. Okay, And U300 glargine is almost a peakless insulin, and it's a prolonged insulin, so you can easily give it once in a day. And particularly, it is very, very important in very insulinopenic patient and type 1 diabetes patients who do not have any insulin reserve. They cannot afford to be off insulin at any point of the day. This is the risk of hypoglycemia, the total, nocturnal and severe when compared to U100 glargine. You can see it's falling on the left side and is favoring the U300 glargine, that less severe hypoglycemia and more importantly less nocturnal hypoglycemia. I am really scared about nocturnal hypoglycemia thing. Daytime hypoglycemia is manageable. We keep on eating. We are in a fed state 16 hours a day. Okay, I am worried about hypoglycemia, particularly severe hypoglycemia, when we are not being fed that 8 hours from midnight to morning. This is the evidence coming out from the EDITION study. EDITION study is a study, in-house study against U100 glargine. You can see it's been done in type 1 diabetes patients, in type 2 diabetes patients, and in different situations, in patients who are insulin naive, the patients who are on basal bolus therapy, patients who are OHA plus basal therapy. So in all kind of situations, we have got evidence coming out. And what does it say? It says that it gives you better glucose control, you get marginally better HbA1c control, you get less weight gain, half a kilo less weight gain, and on the right side you can see you get less hypoglycemia if you use U300 glargine 2GO. So when compared to the so-called gold standard, it gives you a better result, it gives you a safer result. And while we are achieving this better result, we are not losing out on the weight gain front as well. The patients are getting less weight. Okay, so it is much better. Or I cannot say much better because I'm a very, very big supporter of U100 glargine. I've got thousands and thousands of patients on Lantus. Okay, but I've got thousands of patients on 2GO as well. The ATO study, I was a part of ATO study. Okay, ATO study is a real world study, it's a big study. Okay, and what did he say? We had a very bad initial baseline pictures. Okay, you can see that in ATO study it's a multinational study, and 1/3 of the patients were from India. If I'm running slow, please give me a bleep. I'll go faster. Okay, and after giving U300 glargine, we saw that 25% of the patient, they achieved HbA1c target of 7% in 6 months time. Okay, achieving HbA1c target is a huge job. If you know the real world scenario in India, 80% of the patients are not on target. Okay, average HbA1c in India is 8.5%. The time when insulin is initiated is 9.2 HbA1c. Okay, not more than 10% of the patients in type 2 diabetes patients are on insulin. So achieving HbA1c in 6 months flat is a huge gain. It's a huge gain. So please think about it. Okay, so the use of 2GO brought the HbA1c down by almost 2% mark in 6 months time. The fasting blood sugar went down almost by 70. Okay, and while gaining this, there is no hypoglycemia or weight gain. Okay, so 2GO in real world is real world. Okay, jeta amra practice korchi sei world it has proven its mettle. Okay, now coming to BRIGHT study, which is a head-to-head study with the best in the business. Okay, another Gen 2 basal insulin degludec from Novo Nordisk. Okay, I do not see any huge difference between these two, but this study was done head-to-head to see whether there is any slight difference. And what did you see? Efficacy-wise, they are same. Okay, weight gain-wise, there is no significant difference at all. Okay, if you look at fasting blood sugar, again there is hardly any difference. Where did it go different was the initial titration period, where 2GO insulin gave less overall hypoglycemia and less nocturnal hypoglycemia when compared to insulin degludec. So it proved to be safer initially. Why initial safety is important? I'll come to it. So why initial safety is important? আমরা যখন সাঁতার কাটতে শিখি তখন যদি হাবুডুবু খাই হেভি ভয় লাগে পড়ে। প্রথম গাড়ি চালানোর সময় যদি অ্যাক্সিডেন্ট করি তারপরে গাড়ি স্টিয়ারিং এ বসলে হাত কাঁপে। So initial few weeks is extremely important, because insulin initiation is very, very important. But what is more important is titration the dose up. Otherwise, হবে না তো আপনি 10 ইউনিট দিয়ে স্টার্ট করবেন, ওকে, চাই করুন না কারণ আপনি 10 ইউনিট দিয়ে স্টার্ট করলেন, 10-এ তো হবে না, আপনি 3 বছর আগে 10 দিয়েছেন, এখন পেশেন্ট 10 নিচ্ছে, এইচবিএনসি থোড়ি না কমবে। তো পেশেন্টকে বাড়াতে হবে। পেশেন্ট বাড়াবে কখন? যখন পেশেন্ট সেফলি এগোতে পারবে। যদি সেই সময় হাইপোগ্লাইসেমিয়া হয়, বাড়াতে ভয় পায়, না ডাক্তারবাবু বাড়াতে গেলে আমার সুগারটা ফল করে যাচ্ছে। So initial few weeks of safe ride, makes the patient more compliant and it brings the patient's HbA1c maximum. এরকম নামে তারপরে ফ্ল্যাট হয়। আপনি যতগুলো ট্রায়াল দেখবেন ইনিশিয়ালি নামে তারপরে অলমোস্ট ফ্ল্যাট। ওকে, এরকম না, এরকম নামতে 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 তাহলে তো হাইপোগ্লাইসেমিয়া মরে যাবে সবাই। So initial 12 weeks titration phase is extremely important, not only for the patient's benefit, but also give the patient confidence to initiate the titrate the dose up and achieving the HbA1c target eventually. If the patient gets a bad hypoglycemia initially, the patient keeps on getting hypoglycemia in the later part. Okay, so initial few weeks of smooth ride is very, very important. And if you look at this BRIGHT study, whatever cutoff of hypoglycemia you use, insulin 2GO did better. Whether you want to use 54 as the hypoglycemia cutoff, because in many trials they use 54, in many trials they use 70. So whatever cutoff you use, 2GO did better in the initial 12 weeks when compared to insulin degludec as far as hypoglycemia is concerned. I'm not talking about efficacy to bring down HbA1c. We want the patient to reach destination with less accidents. Right. Coming to another very vulnerable population is the renal failure patients. Okay, why do you not want to use insulin in renal failure patient? Hypoglycemia hoye jabe to. Why hypoglycemia hoye jabe? Because insulin ta to systemic insulin আমরা দিচ্ছি চামড়ার তলায়, ওখানে ইনসুলিন আসে না। ওকে, নর্মাল ইনসুলিন কোথায় তৈরি হয়? পোর্টাল সার্কুলেশনে। ওকে, it is not supposed to be delivered under the skin, but when we use exogenous insulin, it gets excreted so the systemic circulation through the kidney. So if kidneys are not working, a lot of insulin stays back, which we call pooling effect. So if one insulin comes on top of other, we call it stacking effect. So we get hypoglycemia. So hypoglycemia কখন হয়? যখন ইনসুলিনের পিক থাকে তখন hypoglycemia হয়. If we have a peakless insulin, there is less hypoglycemia. That's why, at contrary to the popular belief that longer insulin যদি দিই তাহলে পরে ওটা আরো বেশি থাকবে, তাহলে পরে আরো hypoglycemia হবে, না, longer insulin stacking হয় না. That's why basal insulin is safer than any bolus insulin in renal failure patient. And in different trials, you call it addition trial or deliver trial or BRIGHT or ETO study, we have seen that 2G insulin has proven to be safer and effective. It gave the patients less hypoglycemia. Okay, so it has proved to be better in renal failure patient. I would rather say safer in renal failure patient. Coming to another high, elderly population, other high risk population. Again, we have got multiple evidence generating studies, addition, ETOS, BRIGHT, and deliver, and there you have seen that 2GO gives equal effective HbA1c lowering result with less hypoglycemia and less nocturnal hypoglycemia. This is a study against premix insulin. I hate these studies because you cannot compare an apple with an orange. Premix insulin is premix insulin. Basal insulin is basal insulin. You can probably compare degludec and 2GO as long as you can, but I do not want to compare premix insulin. This is kind of a defensive approach. But the thing is, we always get this question: what should be the initial insulin of choice in Indian scenario? Should it, because premix insulin by tradition is the preferred insulin in India. We give it twice a day, once a day. So naturally, many of our colleagues are very comfortable with premix insulin. So they do not want to change that practice. So now what we have got? We have got this basal insulin, which is safer, which is as effective as premix insulin, when you're talking about HbA1c lowering is concerned, and the patient is getting less weight gain and less hypoglycemia. Why do they get more hypoglycemia premix? Because premix is a mixture of short acting and a slightly prolonged acting insulin. So naturally, you use more short acting insulin, you get more hypoglycemia. You do not need to be a rocket scientist to understand that. Okay, so HbA1c lowering is not the ultimate gain. We have to bring the patient to the destination with less problems. That's why our patients, even when they are on insulin, are not on target, because they do not want to increase the dose of insulin for the fear of hypoglycemia. How many of your patients, many of you write insulin almost every day. How many of your patients are actually checking blood sugar daily? Zero, nada. Okay? Nada. রোজ চেক করে দাদা, রোজ চেক করে, খুব কম, একমাত্র প্রেগনেন্ট পেশেন্টগুলো করে। Okay, একমাত্র ওরা করে, they are motivated. Okay, so if a patient is not checking blood sugar, it is very risky to give insulin that can give hypoglycemia. Okay, আপনার ড্রাইভার যদি বলে দাদা আমি তো 40 বছর ধরে গাড়ি চালাচ্ছি কিন্তু আমি সামনের দিকে তাকিয়ে গাড়ি চালাই না, আপনি তাকে রাখবেন না? রাখবেন না। So if somebody is not checking blood sugar, it is futile, it is dangerous to give the patient insulin. And if you want to give insulin, you give that insulin which gives you less hypoglycemia. That's why basal insulin, a flat basal insulin like 2GO, is a better choice than premix insulin. Okay, I just want to skip this one because I have already said that premix insulin gives you more hypoglycemia compared to the IDEC insulin, which is Tresiba and Novorapid combination, insulin Ryzodeg, and again you can see the similar thing. Efficacy wise, HbA1c lowering power is equal, weight gain is slightly less with 2GO, and hypoglycemia is less, again because it doesn't have the short acting component of it. Okay, so insulin 300 glargine at 2GO has shown to be equally effective as far as HbA1c is concerned. The insulin final dose is almost similar, and weight gain is less compared to the IDEC-ASP. This similar kind of, these are different RCTs showing safety and efficacy of 2GO compared to this. This is time in either many studies coming in this field, because it's a evolving field. Okay, time in range. Okay, there are many time in studies coming in type 1 diabetes patient, in type 2 diabetes patient, mostly in Japanese, East Asian studies, because they are very gung-ho about gadgets. Okay, we are using gadgets as well. Nowadays we are using time in range in many situations. Many patients, they cannot check blood sugar so many times. Many patients, they are actually dependent on their children, younger family members. ডাক্তারবাবু আমার ছেলে তো সকালবেলায় বেরিয়ে যায়, কি করে সুগারটা চেক করবো বলুন তো? Use flash glucometers. Okay, লাগানো থাকবে, এটা দেখে নেবেন, লিখে রাখবেন, easy. Okay, and what we want to see in time in range, that the insulin is giving you less fluctuation, glycemic variability, because we now know that glycemic variability is very important for the cardiovascular health. So if a patient is getting less glycemic variability, the patient is supposed to get better cardiovascular outcome. And a flat insulin gives you less variability compared to insulin degludec. 2GO insulin in different time in range trials has shown less hypoglycemia, particularly less nocturnal hypoglycemia. I've already told you about this flexibility of dosing administration, 3 hours here and there. So if you tell the patient to take insulin 2GO at 10 o'clock, tell the patient যদি এদিক ওদিক হয়ে যায় 2-1 ঘন্টা অসুবিধা কিছু নেই, নিয়ে নেবেন, ভুলে যাবেন না। Okay, and that gives the patient a solid cushion. Okay, তাই ডাক্তারবাবু বলে দিয়েছে এটা। লাইক আমি যখন পেশেন্টকে থাইরয়েডের ওষুধ দেওয়ার কথা বলি, আমি বলি সকালবেলা খালি পেটে খাবেন, তারপরে 45 মিনিট 1 ঘন্টা কিছু খাবেন না, কিন্তু যদি কোনোদিন ভুলে যান, যখন পেটটা খালি আছে খেয়ে নেবেন। It gives the patient a bit of cushion. Okay. Right, pregnancy, another area. Okay, অনেকে প্রশ্ন করে এই যে নতুন ইনসুলিনগুলো প্রেগন্যান্সির সময় দেওয়া যাবে? হ্যাঁ, দেওয়া যাবে। They can all be allowed. Okay, not in GDM, but in pregnant diabetic patients. You do not need basal insulin in GDM that often, very, very rarely. Okay, for pregnant type 2 diabetes patients, the type 1 diabetes patient, all insulins can be allowed. None of them are category A, okay, but they can all be used. You can say that downlines. Okay, insulin Levemir during pregnancy if clinically needed, yes. Insulin Lantus can be used during pregnancy if clinically needed. Insulin Tresiba can be used if clinically indicated. Insulin 2G can be used in pregnancy if clinically indicated. Okay, so all of them can be used if you can prove the merit of the use. This is a pen. If you haven't used it, please tell your nearest Sanofi person to give you some demo pen. It's a beautiful device, and the delivery thing is very smooth. Okay, কিছু কিছু পেন আছে দেওয়ার সময় খটখট খটখট করে. Okay, smooth delivery না. This one is a technological marvel. Okay, to summarize, insulin 2G U300 glycine has proven to be effective and can cause sustained glycemic control. It is safer in titration period, even when compared to the best in the business, the latest Gen 2. Laser overall and nocturnal hypoglycemia, minimum weight gain, stable and prolonged action, and flexible dosing of ±3 hours. So it's a beautiful insulin. Embrace modern technology. Don't be dogmatic about that. I've been using that for the last 35 years, so I'm not be using it. In that way, you'll never be using smartphones. Okay, you'll still be in pagers days. Okay, we are all using the latest technology. Okay, price is not an issue. It is not more expensive than the older variety, just marginally this way, that way. So try that, and then you can have your own opinion and talk about it. Thank you so much.
Thanks, Dr. Rai, for enlightening us about the recent advances. Today we had two very good sessions on insulin. If any question, please ask.
বেজাল ইনসুলিনের আপার লিমিট কিছু আছে?
Well, there is something called over basalization. Okay, so if somebody is getting basal insulin, initially we start with a dose of say 0.2 to 0.3 unit per kg body weight. So if you go, you can go as high as 0.5 unit per kg body weight. Suppose একজনের ওজন হচ্ছে 60 কিলো, তো 30 ইউনিট যদি তার basal insulin লাগছে, এখন HbA1c কন্ট্রোল হলো না, that means you have to give prandial insulin as well. শুধু basal insulin হবে না. So 0.5 unit per kg body weight basal insulin is probably the upper limit, where you can probably use just one insulin. After that, you have to use prandial insulin. Otherwise, HbA1c আসবে না.
স্যার প্রিমিক্স ইনসুলিন আমাদের তো হসপিটাল সাপ্লাই আছে, প্রিমিক্স ইনসুলিন থেকে আমরা বেজাল ইনসুলিন যাব, এরকম কোনো একটা ভালো পদ্ধতি বলে দেন?
Well, premix insulin মধ্যে 70% এ আছে, 70% NPH ইনসুলিন আছে. সো সাপোজ আপনার পেশেন্টটা 40 ইউনিট প্রিমিক্স ইনসুলিন পাচ্ছে, ঠিক আছে, তার মধ্যে 70% 28 ইউনিট আপনার এ আছে, বেজাল ইনসুলিন আছে. So you can start with 28-30 unit of basal insulin. Okay, do not just convert the whole premix insulin to basal component. Okay, তাহলে পরে পেশেন্টটা hypoglycemia হয়ে যাবে. So start with 70% of the dose or 80% of the dose, then you see where your fasting sugar stands. খালি পেটে সুগারটা যদি sorted out হয়, তারপর যদি পিপিটা বেশি থাকে, you can add prandial insulin. That makes you easy, because premix insulin in the in-hospital setting is very difficult. পেশেন্ট কখন খাচ্ছে না, কখন NBM রেখে দিয়েছে, USG হবে, কখন CT scan হবে, খেতে দেয়নি. Premix insulin in the hospital is very difficult. If a patient is on premix insulin before getting admitted in the hospital, give the patient a basal insulin and keep the prandial options open. Okay, so that you can adjust the dose. যখন বাড়ি যাবে তখন you can always continue with basal bolus, or you can if the patient is very comfortable with premix insulin, you can switch back to premix insulin.
আমার দুটো পেশেন্ট আছে, বলছে যে আমরা আর ইনসুলিন নেব না, রাইট, আমাকে অন্য ট্যাবলেটে দেন, আর পারছি না. তো এই SGLT2 ইনহিবিটর তার সঙ্গে DPP4
এই জিনিসটা কখনো করবেন না, বিকজ 7 থেকে 10 বছর once the patient is diagnosed with diabetes, the beta cell mass is almost 60% gone. Okay, তারপরে আরো 40% যেটা থাকে, by 7-8 years time the patient is really insulinopenic. Okay, and if the patient is on insulin and the patient doesn't want to take insulin, and if you start SGLT2 inhibitor, the patient will end up having euglycemic decay. Okay, so do not stop insulin and start SGLT2 inhibitor. You can always reduce the insulin dose if you want to try SGLT2 or DPP4 and see how it goes. Okay, ধীরে 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 ডোজ কমানোর পারমিশন তো দেয়াই থাকে পেশেন্টের, বাট in a burnt or diabetic patient who's been diabetic for donkey's years, I will not stop insulin altogether. I will explain the patient why he needs insulin. If the patient is fed up with twice a day, thrice a day insulin, I can always give a basal insulin support and see whether I can tweak with the weights and see the patient sails through. Now, I do not stop insulin. It's my job to tell the patient why the patient needs insulin. যদি কোনো পেশেন্টের থাইরয়েডের সমস্যা হয়, the patient যদি বলে আমার রোজ রোজ থাইরয়েড ওষুধ খেতে ভালো লাগে না, আপনি বলবেন কি হ্যাঁ ঠিক আছে বন্ধ করে দিচ্ছি। থাইরয়েডের হরমোন ডেফিসিয়েন্সির জন্য থাইরয়েড ওষুধ দেওয়া হয়, ইনসুলিন ডেফিসিয়েন্সির জন্য ইনসুলিন দেওয়া হয়। এর মধ্যে মারামারি লড়াই করার কি আছে? ইনসুলিনটা আনফর্চুনেটলি শুকে নেওয়ার, মেখে নেওয়ার, চেখে নেওয়ার, দেখে নেওয়ার ইনসুলিন পাওয়া যায় না। এখনও পর্যন্ত ইনসুলিনটাকে ইঞ্জেকশনে নিতে হয়। যদি পেশেন্ট অনেক বছর বেঁচে থাকে তাহলে পরে শুকে নেওয়ার, মেখে নেওয়ার ইনসুলিন চলে আসবে। মুখে খাওয়ার ইনসুলিন কিছুদিনের মধ্যে আসবে। হ্যাঁ ওই আর কি।
স্যার Dr. Roy, sir, I have a discussion more than a question. Sir, in acute setting, most of us use basal bolus regimen, and usually the recommendation are that 50% of the total dose should be used in basal form. But all of us are mostly accustomed with 100 IU basal insulin. Can we replace there with Toujeo? What's your take, sir?
Oh yes, it's a dose-to-dose conversion. Suppose the patient was getting 20 units Lantus, you want to use Toujeo, give 20 units of Toujeo. The patient might require a couple of units more later on, but you start with the same dose, dose-to-dose conversion. You don't reduce dose and increase dose. Because you're using a different pen. This pen is geared to deliver this U300 concentration glycine. There are different pens. You'll see there are different companies who are bringing U200 insulin, and they have got a different pen. Okay, please tell the patient this pen is for this insulin. Okay, most of the time those pens are non-compatible to other cartridges. Okay, similarly, Toujeo 300 pen is not compatible to other cartridges because you cannot fill cartridge. It comes with a set. Okay, the top end.
থ্যাংক ইউ ভেরি মাচ ফর কি বলবো তোমাকে, তুমি যত শুনি তত প্রেমে পড়ে যায়। আই এম অ্যান অ্যাডমায়ারার, গ্রেট অ্যাডমায়ারার অফ ইউ। যদিও আমরা অল অফ আস, আমি একটু না যেটা বলছিলাম যে আমাদের আমি আমার পার্সোনাল এক্সপিরিয়েন্স বলছি, যদিও খুব কম। U300 usually একটু 10% মনে হয় একটু বেশি লাগে ল্যান্টাস, বাট উইদিন 6 months it comes as a par with ল্যান্টাস। এটা এক নম্বর কথা। 2 নম্বর কথা হচ্ছে আমি একটা জিনিস বুঝি না, those patients which are having no subcutaneous fat, how it is going to act, because this XMR needs to be deposited in the subcutaneous tissue. Is a long মানে আমার অনেক দিন ধরে জানার ইচ্ছা আছে এটা কীভাবে কাজ করে, those patients without having least subcutaneous fat.
Well, I mean, we all have subcutaneous fat.
Least.
We cannot survive without subcutaneous
No,
fat.
malnourished patients. So sometimes we come across malnourished patients. They are
you just deliver it under the skin, okay? You deliver it under the skin. Well, I mean, theoretically speaking, if the patient doesn't have any subcutaneous tissue there at all, many times inadvertently you can inject in the muscle and it becomes very erratic absorption. That's why I prefer abdomen, because we always have abdominal, little bit abdominal fat, okay? I never ever tell the patient take it in the arms or the front of the thigh, because there you get less of fat. But abdomen is probably one area where you can rely on. If a patient is completely devoid of fat and is diabetic, type 1 diabetic, the patient has to be, and you're pretty happy to give under the skin. It doesn't cause much problem. Yes.
No, because of the personal practical experience, what sir says is absolutely true. So we cannot be devoid of subcutaneous fat. This is something always true. But yes, again, depends on how much amount of unit you're injecting. If it's a smaller unit dose, then it's fine. If it's a larger dose, you can definitely split the dose into 2 different areas instead of giving in one area with the subcutaneous fat if you feel is very less. And the first part of your point, you have found slightly higher dosing requirement initially. It is again something related to the deposition of the insulin Toujeo, because it is a compact insulin, more compact surface area where it is getting deposited, and a very slower release from that area, which might really reduce the bioavailability of the insulin. That is basically a theoretical concept. Again, in some people,
it's a very
it's
theoretical
very theoretical.
concept.
Some people have even find some reduction in doses once Toujeo was
Yes.
changed. This is something which is very.
In fact, this smaller volume of Toujeo is beneficial for patients who do not have big subcutaneous fat, because the volume is small. The subcut shearing and the tearing forces less, so less subcutaneous injury, less fibrosis later on, so better absorption in future. And this 10% excess dose requirement is absolutely trial finding. It's very difficult to tell whether this patient would be requiring less insulin had you been using a different insulin. It's absolutely theoretical, it's a hypothetical thing. You just give insulin to bring the sugar to your target level. We don't always bother whether the patient is requiring 22 units or 20 units. The patients are not actually worried about that. They are worried about whether they are bringing the right numbers to the doctor's clinic and making the doctors happy. Pass kore gechen, bhalo hoyeche ajke. And that makes their life. Okay, ami onek shomoy patient smiley diye di prescription er moddhe khub bhalo korechen 10 e 10, and it makes their day. Okay. Right. Okay. Thank you so much. It was a pleasure.
One last comment from my side. One last comment from my side, because Dr. Banerjee has asked that question. Apart from the type 1 patients who need insulin and insulin, otherwise if even a thin Indian requiring insulin, the availability of so many fine molecules OAD, so the need for dosing of insulin, high dose insulin, is gradually reducing actually.
Yeah, that's true.
I
That's
think.
very true.
That is why it is not very impractical to give even a single dose of insulin.
Yeah, that's absolutely true. DPP-4 inhibitor can bring the insulin requirement down by around 20%. SGLT2 inhibitors can bring it down by 25%. So if you use them, metformin can make insulin's life much easy. If you cleverly use pioglitazone, the patient requires less dose. So use your weights very cleverly when you are using basal insulin. Okay, don't depend too much of sulfonylurea, because you're just squeezing last extra remaining juice out of the dry and dying pancreas. So use those DPP-4 inhibitors, SGLT2 inhibitor, metformin, pioglitazone in clever combination along with basal insulin. You'll be better off.
Thank you, sir. If there is no other question, we can conclude the session. Sir, you are really a showstopper, and hearing your fascinating lecture, we really don't look at the time, and this is our penultimate session from ABCDCon 9. And we just conclude the academic session. And again, thank you, sir, from the organizers. We'll happy to have you later.
So we'll be requesting you to be there on the stage, and I will be requesting our chairperson to felicitate sir. Yes, the photographer is right there. I will be requesting Dr. Ashish Mukherjee and Dr. B.D. Chatterjee to come and join us on the stage to felicitate the chairpersons. So please join us for the picture. It's a request. 5 of you together. Thank you so much. Thank you so much, each and everyone. And now for the vote of thanks, I will be requesting our secretary, Dr. Shubhamoy Chatterjee, to say a few words. And the organizing secretary, Dr. D.K. Gupta, as well.
Please stay with us. We are just concluding with a valedictory session.
Subho Sondha. Hello. So, Subho Sondha, good evening to all. And at the onset, I would like to thank all the speakers, chairpersons, moderators, all the participating houses and delegates for their active participation. Because of their participation and encouragement, we are now going to conclude our academic session for 9th ABCDCon. It has been always an honor to meet the expectations of my seniors from this group called ABCD, and this has been almost my 5th year as an organizing secretary concluding the annual conference. It has been a journey which started with a panic whether I would be able to fulfill it or not, but with the help of my seniors, Dr. Soumya Chatterjee sir, Subrata Bhattacharya sir, T.N. Banerjee sir, Sujan Sarkar sir, Arnab Banerjee sir, and later on added by Dr. Joyanto Rana sir, Dr. Abhinabo sir, and Dr. Mofidul Islam sir, we tried our level best to include the topics which are very much relevant to day-to-day practice of most of the physicians, cardiologists, and diabetologists. Every year, beyond these topics, we always try to include some topics which are less talked about. Like this year, we included the topic of adult immunization. It has been an endeavor to include and share the academic knowledge amongst all the participants, physicians practicing in and around Bardhaman. And with this, I would like to thank you all again for making this program a huge success and expecting your biggest participation in the coming 10th ABCDCon so that we can make it another grand success program. Thank you. And now the dais is for our secretary, Dr. Soumya Chatterjee sir. Sir.
থ্যাংক ইউ ডিকে। তো ডিকে তো সবাইকে থ্যাঙ্কস দিয়েই দিয়েছে, আমার নতুন করে বিরাট কিছু বলার নেই। দু চারটে জিনিস শুধু বলি, আমি বাংলায় বলবো, প্রত্যেকবার ইংরেজিতে বলি, এবার ঠিক করেছি বাংলায় বলবো। আমরা ABCD, অ্যাসোসিয়েশন অফ বার্ডওয়ান কার্ডিওলজিস্ট অ্যান্ড ডায়াবেটোলজিস্ট, এই নামটার পিছনে একটা হিস্ট্রি আছে। এখানে আমার সামনে ডক্টর বিডি চ্যাটার্জি বসে আছেন, আমার শ্রদ্ধেয় বাসুদার সাজেশন ছিল এটা যে এমন একটা নাম দাও সবাই একবারে মনে রাখতে পারবে। পরে তার মধ্যে অল অ্যালায়েড ফ্যাকাল্টিজ অফ মেডিসিনস ইনক্লুডেড হয়, কিন্তু প্রথমে এটা শুরু হয়েছিল এইভাবে যে ABCD নামটা কি করে করা যায় সেটা কিন্তু বাসুদার সাজেশন ছিল। সেটা ছিল 2013 সাল। 2013 সালে আমরা কোনো কনফারেন্স করিনি, আমাদের প্ল্যাটফর্মটা তৈরি করতেই 1 বছরের কাছাকাছি লেগে গিয়েছিল। 2014 সাল থেকে আমরা শুরু করি ফার্স্ট ABCDCon। কল্যাণী হোটেল, ফার্মা ইন্ডাস্ট্রির যারা আছে তারা জানে যে কল্যাণী হোটেলটা কোথায়, কোন গলির মধ্যে, এবং তার 3 তলায় কতটুকু একটা ছাদ আছে। সেই ছাদে আমাদের প্রথম ABCDCon শুরু হয়, এবং আমি গর্বিত এটা বলে যে আমাদের এখানে যারা আছেন, পরে যারা জয়েন করেছেন, তাছাড়া যারা আছেন প্রত্যেকে এখানে উপস্থিত আছেন। আমার শ্রদ্ধেয় সিনিয়ররা আছেন, আমার কন্টেম্পোরারি কলিগসরা আছেন, তারা সবাই পার্টিসিপেট করে এবং যে সমস্ত লুমিনারিজ সেই ABCDCon-এ এসেছিলেন তাদের আনতে পারার জন্য আমরা গর্বিত ছিলাম। কোভিডের 1 বছর ছাড়া, যদি এটা কোভিডের যে অভিশপ্ত বছরটা না থাকলে আমাদের এটাই 10th ABCDCon হতো। তো ম্যাজিকটা কি, রহস্যটা কি? কল্যাণী হোটেলের ছাদ থেকে আজকে বর্ধমান ভবন খুব বেশি জার্নি নয়, আমি বলবো না যে বিরাট কিছু জার্নি আমরা করেছি, কিন্তু আমরা প্রত্যেক বছর করে যাচ্ছি। আর করে যাচ্ছি এমন কিছু, আবার বলছি, চিকিৎসা জগতের এমন কিছু শ্রদ্ধেয় ব্যক্তিত্বকে নিয়ে, তারা আমার সিনিয়র, তারা আমার কন্টেম্পোরারি কলিগ, তারা আমার জুনিয়র, তাদের নিয়ে যারা বছরের পর বছর এখানে আসতে ভালোবাসেন। আমি নামগুলো বলছি না, কিন্তু আমার কাছে ফার্স্ট ABCDCon থেকে এই নবম পর্যন্ত সমস্ত যারা যারা এসছেন তাদের প্রত্যেক রেকর্ড আছে, কারা কারা এই ডায়াসটাকে গ্রেস করে গেছেন। এটা কিন্তু আমাদের চলার পথের, ভবিষ্যতের চলার পথের, আমরা যখন আমাদের জুনিয়রদের ছেড়ে দিয়ে যাব তাদের চলার পথের জন্যে এটা কিন্তু একটা দিশা। বর্ধমানে অনেক কিছু নেই, এর সংখ্যা প্রচুর। এক্ষুনি যদি জিজ্ঞেস করা হয়, হাত তুলতে বলা হয়, প্রচুর লোকে হাত তুলবে। আমাদের 5 স্টার হোটেল নেই, আমাদের বড় হল নেই, আমাদের ঝাড়লণ্ঠন নেই, আমাদের সামনে দিয়ে বিরাট বিরাট এক্সপ্রেসওয়ে নেই, সবে তৈরি হচ্ছে, জ্যামে ভর্তি। আমাদের ভালো ইভেন্ট ম্যানেজমেন্ট নেই, যে বর্ধমানে ডাকলেই একটা এরকম করলেই ইভেন্ট ম্যানেজমেন্ট চলে আসবে। আমাদের দারুণ দারুণ ক্যাটারার নেই। তাহলে আছেটা কি? কেন হলো এই নবম ABCDCon পর্যন্ত আমরা টানলাম কি করে? তার কারণ আমাদের কিছু জিনিস আছে। 1 নম্বর আছে আমাদের ভালোবাসা, 2 নম্বর ঐতিহ্য, 3 নম্বর আতিথেয়তা, আর 4 নম্বর সবাইকে কাছে টেনে নেওয়ার ক্ষমতা, যদি নাও বলি চেষ্টা। এবং আর আছে আমাদের ফিজিশিয়ান যারা আছেন, আমার দাদা ভাই বন্ধু সবাই, তাদের কনস্ট্রাকটিভ ক্রিটিসিজম। এইটুকুকে সম্বল করে আমরা কিন্তু এই 9 বছর 10 বছর আমরা পথ চলছি। তো সেই দিকে দাঁড়িয়ে আমরা 9 থেকে 10-এর দিকে এগিয়ে যাচ্ছি। আমাদের সেলফি পয়েন্ট ডক্টর ডিকে গুপ্তর অ্যাডভাইসে করা হয়েছে এবার। সেটা হচ্ছে, লেখা আছে সেখানে যে উই আর প্রাউডলি প্রগ্রেসিং টু 10th ABCDCon। এবং সত্যি উই আর প্রাউড অ্যাজ এ বডি যে আমরা কলকাতা, সাউথ বেঙ্গল বা অল বেঙ্গলে কনজিকিউটিভ 10 বছর ধরে একটা কনফারেন্স আমাদের মতো করে চেষ্টা করে যাচ্ছি, যেখানে আমরা অ্যাকাডেমিক্সকে প্রাইমারি ইম্পর্টেন্স দিই, বাদ বাকি সব কিছু তারপরে থাকে। তো এর জন্যে আমি সম্পাদক হিসেবে আমার পুরো সায়েন্টিফিক বডি, এক্সিকিউটিভ বডি এবং অর্গানাইজিং বডির তরফে আমি গর্বিত। আর আমার বিশেষ কিছু বলার নেই। যেসব বন্ধুরা আমাদের হেল্প করেন অনেক রকম, তারাও অনেক রকম ঝগড়াঝাটি করে, বর্ধমান একটা জায়গা কি এমন, এই চাষবাসের গায়ে ঘেরা জায়গা, হ্যাঁ, বড় বড় শহর, মেট্রো এসব তো নয়। এখানের জন্য একাডেমিক গ্রান্ট আনতে তাদেরও অনেক সমস্যা হয়, আমরা জানি। তার জন্যে অনেক সময় এমনকি মতান্তরও হয়, মনান্তরটা কখনো হয়নি। তো এইসব মিলিয়ে আমরা চলছি, আমরা ভবিষ্যতেও চলবো। এবং শেষে থ্যাঙ্কস গিভিং বলতে যেটা দিতে হয় সেটা অলরেডি ডক্টর ডিকে গুপ্ত দিয়েছেন। আমাদের একটা ট্র্যাডিশন আছে, যে সমস্ত ফার্মা হাউস আমাদের পাশে আছেন, আমাদের হেল্প করে এসছেন চিরকাল, যার ফলে এই কনফারেন্সটা আমরা করতে পারি। তো সেইটার জন্যে তাদের আমরা একটা টোকেন অফ গ্র্যাটিটিউড এবং থ্যাংক ইউ দিই। তো আমি ডক্টর ডিকে গুপ্তকে অনুরোধ করব যে আমার পাশে আসতে, আমি নামগুলো বলবো, প্রত্যেকে যেন আসেন এবং আমাদের নমস্কার গ্রহণ করে যান, প্লিজ। তুমি এসো এখানে। কি? হ্যাঁ হ্যাঁ, সব বলা আছে। হ্যাঁ হ্যাঁ, সব বলা আছে। সান ফার্মাসিউটিক্যালস একজন দয়া করে আসবেন, একটু হাততালি দেবেন সবাই। USV, Cipla Vitalis, Alchem, Torrent, Boehringer Ingelheim, Sanofi, Boehringer, Sanofi, Lupin, Zydus, AstraZeneca, GSK, Glenmark, IPCA, ইপকায় যারা যারা পার্টিসিপেট করেছেন আসবেন দয়া করে। সিপ্লা গ্যাস্ট্রো ডিভিশন, নোভার্টিস, Altius, Radicals, IPCA HYQ division. Oh, okay. MacLeod's, Frisco Hill Pharmacia, অজন্তা ফার্মা, জয়ন্ত আর কৌশিক, আমার ডান হাত আর বাঁ হাত। সিপ্লা রেসপিরেটরি নেই, সিপ্লা নেবুলাইজেশন ডিভিশন, বিবি ক্যাটারার কোথায় গেল? ওকে ওকে পরে দিয়ে দেবো। আমার অত্যন্ত প্রিয় শ্যামল, নিউ মুভিটন সমস্ত গ্রুপের তরফে, এমনকি সুমনার তরফেও। অম্বরীশ ফ্রম নিউ আমোদিতাস ফ্রেম, যে এই কনসেপ্টটা দিয়েছে যে স্ক্যান করে নিন ছবি ডাউনলোড হয়ে যাবে, অসাধারণ কনসেপ্ট দিয়েছে এবছর। ও ল্যাপটপেই বসে আছে, ছবি ডাউনলোড করিয়েই যাচ্ছে। এছাড়া যারা আমাদের গাড়ি দিয়েছেন, গাড়ির ড্রাইভার, তাদের সবাইকেও আমি থ্যাঙ্কস গিভিং দিচ্ছি। এবার আমি অনুরোধ করব আমার পুরো সায়েন্টিফিক বডি অর্গানাইজিং কমিটিকে ডায়াসে আসার জন্যে। আমরা ট্র্যাডিশনালি জাতীয় সঙ্গীত দিয়ে আমাদের একাডেমিক সেশন শেষ করি, তারপরে 1 থেকে 1.5 ঘন্টা বাদে আমি সবাইকে ইনভাইট করছি আমাদের গালা ডিনারে আসার জন্যে। 7টার থেকে আমাদের কালচারাল প্রোগ্রাম শুরু হবে। ফার্মা হাউসের সবাইকে ইনভাইট করব যে আপনারাও তাতে জয়েন করবেন। একটু দাঁড়াবেন, একটু দাঁড়াবেন। ন্যাশনাল অ্যান্থেম হবে, জাতীয় সঙ্গীত হবে। হ্যাঁ, নেব। ফার্স্ট ইউ কাম টু দি ডায়াস, জাতীয় সঙ্গীত হবে এখন। প্লিজ কাম টু দি ডায়াস। পঙ্কজদা, প্লিজ কাম টু দি ডায়াস। প্লিজ কাম। জাতীয় সঙ্গীতের আবার ইয়ে আছে কিনা, তোমরাও দাঁড়িয়ে যাও লাইন দিয়ে। লেটস স্টার্ট।
जनगण अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चय जलधिकरंगा तव शुभ नामे जागे तव शुभ आशीष